السلام عليكم ورحمة الله، كيف حالكم جميعا؟ رمضان كريم علينا وعليكم. Do you like to start now or do you like to wait for another 5 minutes? I would prefer to start exactly at 7:05 since not everyone here. So let's start إن شاء الله. حنبدأ على الساعة 7:05 بالضبط. بارك الله فيكم. حياكم الله جميعا. الصوت موجود، الله يبارك فيكم. We will start in 1 minute. هل الصوت واضح للجميع؟ ممتاز، بارك الله فيكم. So welcome everyone. رمضان كريم علينا وعليكم. To introduce myself, I'm Dr. Faris Saad. I'm a medical doctor specialized in infection control, and I have a master's degree in infection control, as well as I have the CIC, LTC, CIP, and last thing I have is CBHQ. So today we have 8 lectures. We will start our lectures with the infection control manual. Uh, our agenda for today for this topic, 1 minute. So in this presentation, we will begin with an overview on the importance of infection prevention and control manual. Uh, Also, we will go through why this manual is not just a document, but it is a cornerstone of healthcare safety. and we will examine the crucial role of leadership in IBC implementation and how leaders shape the culture and efficacy of the IBC practices. In this segment, we will also take it will also take us through a process of tailoring the IBC manual for diverse healthcare environment, highlighting the manual adaptability to various settings from hospitals to long-term care facilities and ensure the relevance and applicability across the board. Transitioning to the content, transitioning to the content of the IBC manual, we will provide a closer look to its structure, starting with the table of content, moving on with the specific policies and procedures, and we will also discuss the updates, the importance of continuous updates of those policies and manual. And lastly, we will shift to empowering our staff with the IBC manual-based training and spotlighting the essential role of continuous learning and competency in IBC practices. As we conclude, we will engage with the practice Q&A question session, is an opportunity for us to just revise what we have learned in each presentation of today. So why is the infection prevention and control manual is indispensable in healthcare? Today, we highlight or we go through the journey to understand how this manual transcend its pages and becoming a vital tool in ensuring the highest standard of safety and quality in patient care. It is not just a document, as we said in the agenda, it is a fundamental strategy for prevention and guide for our collective commitment to excellence. The Infection Control Manual lays the groundwork for infection prevention and control practices within the healthcare settings. It acts as the blueprint and it is meticulously outlining the path we follow to mitigate the risk of infection transmission. This manual is crucial for ensuring the IBC policies and procedures are standardized across all the touch points of care, guaranteeing that each protocol from hand hygiene to sterilization processes يس حتكون كاملة في الإنجليزي صحيح align with the pinnacle of best practices. طبعا المحاضرات هتكون بالإنجليزي لأنها طويلة ويصعب علي إني أنا أتكلم إنجليزي وعربي في نفس الوقت. طيب وأغلب المصطلحات حتكون بالإنجليش. Education and continuous training of our healthcare workforce are anchored in the wisdom contained within the pages of this manual. It serves as educational cornerstone, enlightening everyone from clinicians uh, to even housekeepers on the critical importance of infection prevention measures. And the manual instills, it creates a culture where uh, important infection control practices are not just followed, but embraced, creating environment that encourage the patient safety and put it as a highest priority. In the face of infectious diseases outbreak, the manual transforms into a command plan. It offers clear, actionable protocol for isolation, case management, and disease containment. Also, the manual endure our adherence to the compliance with both national and international health regulation. And this adherence is not merely about meeting legal obligations, it is about affirming our commitment to excellence and trust in healthcare delivery, and it illustrates our unwavering dedication to maintaining a care environment that meets the highest standard of safety and quality. At its essence, the infection control manual symbolizes our pledge to protect the well-being of patients and healthcare workers alike. It reflects our dedication to fostering an environment that is not only healing, but also protective. And this dedication is what distinguishes us as leaders in healthcare commitment committed to the highest ideal of patient care and safety. Importantly, the manual is a dynamic, evolving document. It is continuously updated to reflect the latest scientific evidence and advancement in the infection prevention and control, which ensure that our practice is not only current, but also based on the strongest empirical evidence, demonstrating our commitment to innovation and continuous improvement in healthcare. So leadership within the healthcare setting isn't just a title or a position, it is embodiment of a vision for achieving IBC excellence. Leaders sets a stage for the vision by demonstrating a steadfast commitment to infection control, ensuring that infection prevention and control is not just a policy, but a priority, and the infection prevention and control team actually has the authority to implement their standards and to reach the excellence in infection prevention and control. The support and enforcement of IBC policies by leadership is very important and critical. It involves not only the development of comprehensive policies, but also the allocation of necessary resources. Be uh, Also, it ensures that those policies are effectively implemented and leaders enforce compliance, and not through mandates only, but by modeling the behavior and practices they expect to see, and creating an environment where adherence to APC guidelines is the norm, not the expectation. A culture of safety and quality is the bedrock of effective infection prevention and control. Leadership fostering this culture by promoting open communication, encouraging the reporting of incidents or near misses, and viewing these as an opportunity for learning and improvement. In this culture, every member of the healthcare team feels empowered to contribute to infection control efforts, knowing their voices are heard and valued. Education and advocacy are also vital. Leaders champions ongoing education and training on IBC practices, understanding that the IBC manual is a living document that evolves. And by advocating for regular updates and training sessions, leaders ensure that the healthcare team is not only informed of the latest practices, but also engaged in the manual continuous improvement. Finally, accountability and the drive for continuous improvement are very important for an effective leadership in the infection prevention and control. Leaders establish mechanisms for monitoring compliance and outcome, using data to drive decisions and improvements. They recognize the importance of regular reviewing and updating of the IBC manual, ensuring it reflects the latest evidence and best practices through accountability. And leaders underscore their commitment to not just maintain, but elevating the standard of care. In hospital settings, the IBC manual includes comprehensive protocols tailored to high-risk departments, and these guidelines are meticulously designed to address the complexity of high stakes, the emergency care, of intensive treatments, and surgical procedures, ensuring that infection control measures are both strong and effective. Our outpatient clinics For our outpatient clinics, where patients' turnover is high and spaces are often shared, the manual is customized to tackle these unique challenges, and it offers strategies for managing patients' flow and maintaining hygiene in waiting areas and examination rooms, and therefore it, as a conclusion, minimize the cross-infection risks. In the context of long-term care facilities, the IPC manual takes on a different focus, where it adapted to protect a vulnerable resident population living in a close quarters, emphasizing the preventive measures that can be seamlessly integrated into daily routines without compromising the residents' quality of life. Crucial to the manual effectiveness is its dynamic nature. Regular updates ensure that it remains aligned with the latest research and global health recommendations. This process for continuous improvement allows healthcare facilities to customize the manual guidelines and ensuring that they are relevant and practical for their specific operational context. What makes the IPC manual truly invaluable is its ability to maintain a consistent standard of infection prevention and control while providing a flexibility for tailored implementation. This balance ensures that regardless of the healthcare setting, the manual serves as a reliable resource for developing and enhancing infection control protocols, directly in contributing to a safer healthcare environment for everyone involved. So, in the journey to uphold the highest standard of infection prevention and control, the architectural blueprint of our IBC manual emerges not merely as a reference document, but as a strategic tool meticulously designed to navigate the complexity of healthcare safety. Central of its utility and effectiveness is the table of content, a carefully crafted index that serves as the getaway of a wealth of knowledge and guidelines essential for safeguarding the health of both patients and healthcare professionals. Reflecting a commitment to precision and accessibility, the table of content is current in step with the best practice and recommendation. The structure of this table now, do you have any problem? I think the voice is now clear. ممتاز. So the structure of the table of content is a testament to the thoughtfulness and intent behind the organization of the IBC manual. Each policy is systematically indexed not only by its unique policy number, but also by its title and the precise page name, a number. And this meticulous organization facilitates swift navigation and retrieval of the information and empower the healthcare worker with the ability to quickly locate and apply critical IPC measures to their daily routines. It is a feature designed not for the manual convenience, but its practical, real-world application in fast-paced healthcare environment. Beyond the ease of access, the division of the manual into distinct sections ranging from administrative policy to supportive services mirror the multifaceted approach required to effectively manage and prevent infection. While administrative policy sets the stage, offering the overarching framework and vision of infection control efforts hospital-wide, the departmental policies and procedure drills down to the specific delineating the responsibilities and risk practices tailored to the unique dynamic of each department. Isolation procedures provide a protocol for effective segregation of infection risk, crucial in preventing the spread of pathogens. Environmental health emphasizes the role of a clean and safe environment as foundational to patient and staff safety, and support services highlight the collaboration efforts required across all departments, reinforcing the infection prevention and a collective responsibility. As we progress to the more into the IPC manual, we reach the cornerstone upon which our infection prevention and control efforts are built. The policies and procedures section, the segment is the manual soul. It includes in it the detailed guidance and the protocols that empower our healthcare worker to not only understand um, but master uh, the power of the infection control. It is here within these pages that the theoretical foundation of infection prevention are translated into actionable, practical measures that can be implemented in the complex, dynamic environment of healthcare. The policies and procedures section is meticulously structured to cover a comprehensive range of protocols. It starts with the infection surveillance and reporting procedures, which are critical for early detection and management of potential outbreaks. This early warning system is essential for proactive intervention, enabling us to contain infections before they can spread farther within the healthcare setting. Hand hygiene protocol form the bedrock of our infection prevention strategies, recognized universally as one of the most effective methods to prevent healthcare associated infection. And those guidelines are detailed with precision, ensuring that all staff understand the critical moments of hand hygiene, the proper technique, and the significance of this simple yet profoundly impactful practice. Also, moving forward, the use of personal protective equipment is another pillar within our manual. These policies meticulously outline which type of PPE are required for various clinical scenarios, ensuring that staff are not only protected but also knowledgeable about the rationale behind PPE use. And this understanding is crucial for fostering compliance and instilling a culture of safety among all the healthcare workers. Moving forward, we have the cleaning, disinfection, sterilization procedures that are covered with exhaustive details, recognizing the vital role that environmental cleanliness plays in infection control. And these procedures ensure that every surface, instrument, and a piece of equipment meet the highest standard of hygiene, minimizing the risk of infection transmission through those contaminated surfaces. Then we talk about the waste management and disposal protocols, which address the safe handling of disposal of potentially infectious materials. And these guidelines are essential also for protecting healthcare workers and the environment from the risks associated with biomedical waste, ensuring that such material are dealt with responsibly and accordance to the regulatory standards. What truly sets our IPC manual apart, however, it is dynamic nature, and it is a living document, regularly should be reviewed and updated to reflect the latest in evidence-based practices and global health recommendations. And this commitment is continual improvement signifies our dedication to excellence and our unwavering resolve to protect both patients and healthcare workers from threats of infections. So once we talk about the infection control manual, we have to give a focus on the references for IPC excellence. And as we say, grounding IBC in science, the role of authoritative references, it becomes evident that the integrity and efficacy and trustworthiness of our IBC manual are direct reflection of an excellent or strong reference. And this uh, and those references should be incorporated, should be based on scientific and approved references like scientific papers or MOH references or CDC, EPIC, um, GCC, WHO, and we should ensure the credibility and reliability of our IBC practice and ensure that we are using the uh, current and most updated references. So updating our IBC manual is a task we take seriously, and it reflects our dedication to high quality of care and acknowledge that infection prevention is an area where things change quickly. And we aim to review and update the manual every 2 to 3 years or even sooner if necessary, due to new research findings or to the appearance of new infectious diseases. And this thorough review process is more than just routine work. It is a deep dive into our current practices to align them with the newest guideline from top healthcare organization and research findings. And this continuous cycle of updates keeps our infection control strategies effective and it ensures our healthcare professionals have access to the latest in knowledge and tools to face infection control challenges. And we incorporate new guidelines from from uh, good references or excellent references, such as, for example, when we talk about national regulation from the Ministry of Health or CDC, WHO, or others. And the need for these updates is critical in a world where new infections can appear suddenly and resistance to treatments can develop. Having an up-to-date IBC manual is like having a reliable map in an unknown territory or country. It guides us clearly and confidently through the complex world of infection prevention. Moreover, updating the IBC manual is a team effort involving healthcare professionals from across our organization. It's not only a job of infection prevention and control, it has to be a collaborative approach that enriches the manual with practice inside and ensure that the advice it gives is both scientifically accurate and applicable to everyone in the patient care. As we think about the importance of keeping our manual current, let's see it as a positive step forward, not a core. Every update to our IBC manual may marks progress in our ongoing efforts to provide safer and more effective care. So making sure everyone can always reach our infection prevention and control manual is essential. In accessibility and resilience, we should ensure that uninterrupted IBC guidance. We focus on why it's so important for this manual to be easy to access to all healthcare workers, no matter what happened. We keep this manual available in both electronic formats for convenience and printed version for reliability, ensuring that everyone can use it even if there's a power cut or a technical problem. Having the IBC manual easily available in every department in both digital and paper format isn't just about making things easier, it's about being prepared. In today's digital world, we often rely on electronic devices, but we also know that technology can fail. And that's why having printed copy as a backup, a plan that ensures vital infection control guidelines are always within the reach of arm help us keep patients and staff safe even during unexpected tech outrages. And this approach is to have the manual readily accessible underlines our broader goal to be ready for anything and to empower our healthcare team. It recognizes that to follow the guidelines and protect our patients, healthcare worker needs to have these instruction handy at all time by making sure that the IPC manual is available in every format. We are not just preparing for the what if, but we also showing our deep commitment to maintaining a safe healthcare environment. The advancing IPC through manual-based training program. In this slide, we underscore the critical role of IPC manual, not just as a set of guidelines, but as a set of comprehensive educational tool within the healthcare institution globally. Training programs rooted in the IPC manual ensures a standardized approach to infection control, fostering a shared understanding and consistent application of best practices. And by tailoring training to the to different roles within our healthcare professionals, from medical staff to administrative and support team, each member understands their part in preventing infections, making the guidelines practical and applicable to their daily roles. Interactive learning approaches such as simulations, playing, and other ways of learning, interactive approaches are very crucial, and they transform theoretical knowledge into skills that healthcare professional can apply in real-world scenarios, enhancing the efficacy of the IBC measures. The landscape of infection control is ever-changing, necessitating a commitment to ongoing education. Continuous learning sessions informed by the latest updates of the IBC manual ensure that the healthcare team are always at the cutting edge of the IBC practices. Assessments play also a key role in these training programs, and not just to evaluate, but to reinforce learning and applicable application of the IBC practices. The inclusion of feedback mechanisms further enriches these programs, allowing for adaptation and improvement based on direct input from participants. So in today's digital age, the utilization of online platform and digital tools in training programs amplifies accessibility and engagement, making it possible for all healthcare workers to participate regardless of their location or schedule. Training program based on the IPC manual are not merely educational initiatives. They are a testament to the healthcare sector dedication to continuous improvement in infection control, and they highlight a global commitment to not just react to IBC challenges, but to proactively prepare and empower healthcare professionals, ensuring the highest standards of care and safety. As we conclude the first lecture, we will start with testing your knowledge with 5 MCQs for each presentation we will go through today. So our first question for this presentation, the policies, and it is a true and false question. It asks, the policies and procedures section of the IBC manual include guidelines on hand hygiene, use of PPE, and environmental cleaning standards. Is it true or false? Excellent, everyone. The correct answer is true. It's an easy question. Let's go to question number two. Question number two is, it asks, which of the following is not typically considered a foundational reference for the IPC manual? Which of the following is not typically considered a foundational reference for the IPC manual? Excellent. So the CDC is an excellent reference. WHO is an excellent reference. National regulation from the Ministry of Health is an excellent reference. So the one that is not a good reference for our IBC practices is when we are use popular media articles. So something that is not medical journals, but media articles, something that is posted on media. So this is not a good reference. So the correct answer is C. Question number three, the IBC manual should be updated only when a new diseases emerges. True or false? Well done, everyone. Excellent. So the correct answer is false. Well done. Question number 4, which strategy ensure uninterrupted access to the IBC guidelines, especially important during the power or system failure? So which strategy you will have to uh, to to have when you have uninterrupted to ensure that you have uninterrupted access to the IBC guidelines when you have an issue with the power or system failure. So A is talking about relying solely on digital copies, but we might have a system failure or a power failure. So digital copies maybe not a good choice on this example. Keeping a backup copy on an external hard drive, also it is a digital form. We might not have an access to computers, so digital, or we might lose the hard drive. So maybe it's not a good choice as well. C, having a printed copy available, it is the best option and it is the correct answer. D, memorizing the guidelines, I'm sure we can do that, but it is not enough. So the correct answer is C, having a printed copy available in case of power failure or system failure. Last question, how often should the IBC manual be reviewed and updated to ensure its relevance? Is it going to be updated every 5 to 10 years, or only when a new infection is discovered, or every 2 to 3 years, or as indicated by new evidence, or once at its initial publication? Well done, everyone. The correct answer is C. So it is recommended to revise policies and procedure every 2 to 3 years to make sure that it is relevant. And you can also update it sooner if any new evidence is indicated. Thank you very much, everyone. I think we will go to the second presentation before Al-Isha prayer. Then we will take a break. Or maybe we will take a break half of this presentation if we couldn't finish it earlier. So our next presentation is regarding IBC practices and ICU. We will continue our presentations today with talking about the ICU now. So diving into the complex, yeah. So diving into the complex world of infection prevention and control within intensive care units, our roadmap unfolds through 4 important segments, each layer building upon the next wave, a comprehensive narrative on safeguarding our most valuable patients. So our first stop takes us deep into understanding the risk factors for infections in ICUs, where we unravel the complexity tied to the patient condition, medical devices, and the very air we breathe. And this exploration uh, it helps us to understand our specific population, which are the ICU population. And shifting gears, we navigate the proactive strategies um, to go deeper into the infection prevention in the ICU. And here we delve into the art of science of device management and nourish our knowledge with nutritional support tactics and reinforce the bulwark of staffing and training and all designed to fortify our defense. And as we chart the course through special focus areas, the spotlight shines on the formidable foes of multi-drug resistant organisms and the beacon of hope presented by technology and innovation. And these discussions are not merely academic, they are the vanguard of our evolving strategies to outmaneuver the microscopic threats that lurk within the beyond the ICU walls. So our journeys continue in strategies for implementation and improvement, and it goes through the a magnifying glass or lens of screening and surveillance, where we care more about our patients and make sure that our patients are um spotted earlier if there is anything happens and managed swiftly. And the final flourish of our expedition is in the Q&A session, and where we will discuss few questions at the end of this presentation. So the battle against this infection is fought on multiple fronts, reflecting the diverse origins and the significant impact they have on patient health and healthcare systems. ICU infections do not stem from a single source, rather than they arise from a complex interplay of factors. And those factors include the inherent vulnerabilities of our patients, the necessary but invasive devices we rely on for life support, and the environment of the ICU itself. The ramification of these infections are profound, extending hospital stays and escalating the cost, and more critically affecting our patients' health and survival chance. And this understanding compels us to focus keenly or more on identifying and understanding and addressing each of those risk factors. As we proceed, we will delve deeper into the specific of those risk factors, and we will pay more attention to some of them. So, as we said, we will go more into the complexity of preventing the infection in the intensive care units. It is very important to categorize and understand the diverse source of risks. First, we have the patient-related risks, which revolve around the inherent vulnerability of our patient due to their medical condition, nutritional status, or immune system functionality, immune system functionality. Next, we have the device-related factors come as a very important risk factor, which highlight the risk introduced by necessary but invasive medical devices that breach the body's natural defenses. And lastly, the environment and staff-related factors reminds us of the critical influence of our practices and the environment we maintain and the protocols we follow in mitigating or exacerbating the risk of infections. By categorizing these risks, we not only better understand the battleground, but also tailor our strategy more effectively to shield our patient from potential infections. Um, and in this segment, we will focus on the intrinsic vulnerability of patients that elevate the risk for infections in the ICU. The forefront of these patients-related factors is compromised immune systems, whether due to underlying medical condition, the impact of treatment or surgeries. These weakened defense mark patients um, for increased infection risks. Chronic conditions such as diabetes and cancer further compromise the body defense, creating an environment where infection can take hold more easily. Nutritional status plays an important role because malnutrition not only diminish the immune response, but also prolongs the recovery time, highlighting the critical need for nutritional support in patient care plan. Also, we have the age. The age is a significant factor both for the very young and the elderly face greater risks due to less robust or deteriorating immune system and the presence of multiple comorbidities. Lastly, we must consider those with genetic and acquired immune deficiencies who who battles are uphill from the start. And understanding those patient-related factors allow us to tailor our care more effectively, ensuring that our intervention are as proactive and protective as possible. Each patient unique vulnerability require individualized attention to mitigate the risks and safeguard their health during their ICU stay. In this critical examination of device-related factors, we confront the double-edged sword of invasive devices in the ICU care, and those devices, while essential for life support and monitoring, it also opened the door for infections to enter the body. Central to our discussion are vascular devices like central venous catheters, which are vital yet pose a risk for bloodstream infections if not meticulously inserted and maintained. Also, we have the urinary catheters, the predominant cause of urinary tract infections in the ICU, underscore the importance of evaluating the necessity of prolonged use of mitigate infection risks. And also we have the mechanical ventilation, a lifeline for patients with respiratory failure brings the challenge of ventilator-associated pneumonia or event, highlighting the need for strict adherence to preventive protocols and the common thread among these devices is their disruption of the body natural barriers, emphasizing the need for vigilant care. Our shield against these risks in the adoption of a bundle approach, comprehensive sets of evidence-based practices that guide the insertion and maintenance of those devices. So here we explore the critical role played by the ICU environment and the behavior of healthcare team in influencing the infection risks. The foundation of infection prevention lies in diligent hygiene practices, notably hand hygiene, which cannot be overstressed, for it is important in the curbing of the spread of infections. Equally crucial is the cleanliness of the ICU itself, where regular and comprehensive cleaning regimens are vital in maintaining a safe environment for patients. However, the effectiveness of these practices focus on the staff through continuous education, training, and adherence to IBC guidelines, and healthcare workers become the front line of the defense against infections. Yet their ability to maintain high standards of care is significantly influenced by staffing level. Adequate staffing ensures that the pressure on workload do not compromise the infection control efforts. Moreover, the proper and consistent use of uh, personal protective equipment forms another barrier against the transmission of infection, underscoring the need for vigilance and adherence to PPE protocols. And finally, the structural aspect of the ICU, including ventilation, air filtration, and the provision of isolation rooms, represent environmental controls that further mitigate the risk of airborne pathogens. Together, these environmental and staff-related factors underscore a holistic approach to infection prevention, highlighting that beyond patient care, the environment we create and the practices we uphold are equally important in saving or the well-being of our ICU patients. So as we move forward, it becomes clear now that our path is both has a lot of challenges and as well as it has a lot of opportunities. It demands a comprehensive approach that integrates our deep understanding of the risk factors that might push us forward for the commitment of evidence-based practices. And this journey toward excellence in IBC require us to be ever vigilant, constantly educating, and training our team to not only follow, but to champion these protocols. In the heart of our efforts lies our patients, each with their unique needs and vulnerabilities. Our strategies must be as individualized as they can be, ensuring that care is not just standardized but personalized for each patient vulnerability. Yet the strength of our practices and efforts comes from our collaboration with the when we always say united front, a united healthcare workers, and we unite ourselves also with patients and their families and listen to them, can also advance our IPC measures. As we look ahead, let's go through the innovation. Let's embrace the innovation and encourage the research and be willing to integrate a new solution that can further protect our patients from infections, and uh, building a system that has monitoring and feedback can also push the cycle for continuous improvements. Charting this course require more than just adherence. It calls for a collective commitment to exceed our current limitation, to learn from each experience, and to always strive for better outcome. Um, so next slide, we will talk about strategies for preventing infections in the ICU. As we said before, we have the general IBC measures, nutritional support and management, staffing and training, device management. All of those pillars are important when we come to prevent the infection in the ICU, as we discussed before. So let's take it deeper in the presentation. So let's talk about the general IBC measures and standard precaution. So in the intensive care unit, our commitment to patient safety and infection control is grounded in the rigorous implementation of general infection prevention and control measures, aligned with the critical framework of standard precautions. And these universally safety measures are designed to minimize the risk of transmission of pathogens, protecting both our patients and healthcare environment. The hand hygiene stands at the forefront of the of all the IBC practices. It is the fundamental aspect of standard precaution, and it underscores the importance of cleanliness in breaking the chain of infection. Whether through washing or sanitizing, this simple act is our first line of defense. Equally important is the use of PPE, personal protective equipment. By donning appropriate gear, healthcare workers shield themselves and their patients from infectious agents, and practice that is essential in every patient interaction within the ICU. Environmental cleaning extends our infection control efforts beyond personal safety to the broader ICU environment, where regular and meticulous disinfection routines ensure that our care setting does not become a reservoir for infectious agents. And lastly, the aseptic technique is a critical procedure and standard precaution that encapsulate our commitment to maintain the sterile condition during invasive procedure. And we will talk about those elements later on in detail in the later presentation today. So here we talk about our commitment to prevent the central line associated bloodstream infections. And we have two type of bundle, a bundle that is used during the insertion of central line and another bundle that is used on a daily basis during a maintenance of our inserted central line. So the insertion bundle initiates with stringent hand hygiene. It starts always with proper hand hygiene, followed by a maximal barrier precaution, ensuring both the provider and the patient are equally protected. And here, when we talk about our patient, we want to make sure that they are covered by a sterile large drape that cover the whole patient from head to toe. And for our staff, we want to make sure that they have sterile gowns, sterile gloves, face shield, head cover when they are performing such a procedure. Transition, and we want to make sure that chlorhexidine skin antisepsis is done appropriately to our patient and according to the patient age and weight if they are neonatal. And we want to make sure that it has appropriate contact time and appropriate method when it is applied to the patient. Optimal catheter site selection, always we prefer the subclavian vein over the internal jugular and femoral vein, except when we are talking about dialysis catheter where subclavian is not recommended, and we go through the internal jugular as the preferable site. For maintenance, transitioning to maintenance bundle, the daily reassessment of the line necessitate prompt timely removal, reducing the exposure window to potential infections, and the choice and management of dressing along with the administrative sets adhere to strict guidelines ensuring the integrity of the central line environment. So when we talk about catheter-associated urinary tract infections, also we have the insertion bundle as well as the maintenance bundle. And the insertion bundle, we always say at first, try to avoid unnecessary catheter on only use the urinary catheter when absolutely necessary, assessing the need carefully. So when there are an appropriate reason to insert a urinary catheter, that an appropriate reason should be avoided. And the patient should have an alternative. For example, a condom catheter, or for example, a diaper if it is necessary. So it is not always advisable to use a full urinary catheter because of the risks of infection that it carries. So it should be inserted aseptically, starting with the hand hygiene, utilizing sterile equipment, gloves, drape, sponge, antiseptic solution for urethral cleaning, sterile lubricant for insertion, and choose the smallest possible catheter size to minimize urethral trauma and infection risk. And the insertion bundle also can be expanded more than that. It depends on the how far you want to make sure that the aseptic technique during the insertion is appropriately done. Maintenance bundle, we focus on the hand hygiene, daily catheter necessity review. So we review on a daily basis if this catheter is actually today is needed or not. Sterile closed drainage system, we make sure that it is maintained. Catheter and collection bag management, we ensure that the catheter is properly secured. The bag is below the level of the bladder with the tubing. We make sure that there is unobstructed urine flow, and we ensure that the urine bag is regularly empty and not full, or 3 out of 4 full. Routine catheter hygiene, we encourage perform routine cleaning of the meatal surfaces during daily bathing without disturbing the catheter position, and aseptic technique should be followed when collecting urine sample to prevent introducing pathogen into the urinary system. So in our ongoing commitment to safeguarding and well-being of our ICU patient, the implementation of the ventilated associated pneumonia or VAP bundle is also important. Our first step in the bundle is as we know, it is elevation of the head of the bed, maintaining the head of the bed from 30 to 45 degree in adults and 15 to 30 in neonates is really important to prevent the aspiration risk. Daily sedation, interruption, and assessment for extubation is really important, along with assessing to minimize the duration of mechanical ventilation. Peptic ulcer prophylaxis and deep venous prophylaxis is no longer recommended for valve strategies, as they carry no evidence of reducing the valve risk. And lastly, daily oral care with chlorhexidine. Also, the chlorhexidine nowadays in the recent guidelines is no longer recommended because it is connected with high mortality with VAP. So the recommended is to do a daily oral care without chlorhexidine. So in the intensive care environment where patients face critical health challenges, and nutritional support is very important, as we said before. It begins with the thorough assessment, a critical first step where nutritional needs are identified, setting the stage for tailored interventions. Each patient nutritional plan is really important, and it should be meticulously crafted to meet their unique requirement. And this individualized strategy often involves a preference for enteral nutrition, leveraging the natural gastrointestinal route to support gut integrity and optimize nutrient absorption. However, where enteral feeding is not feasible, parenteral nutrition become a vital alternative, ensuring patients receive the necessary nutrients intravenously. So we always talk about empowering the ICU team and ensuring that our staff are met. Um, we want to make sure always that we have adequate staffing level. We want to make sure that our patients are properly cared for without compromising the infection control due to shortage of staff. Also, when we are talking about empowering ICU team, we are talking about staffing education, and we empower them also with giving them the sense of ownership over infection prevention and control, and involving them in our improvement projects, in our committees as a decision making, and etc. Combating MDRO in the ICU, it starts with the surveillance and monitoring, where we do a surveillance to make sure that we monitor all type of MDROs. Then it goes to antimicrobial stewardship, where we promote for the accurate use of antimicrobial or antibiotics and to reduce the development of resistance, and the infection prevention protocols, where we enhance the infection prevention practice through hand hygiene, PPE, environmental cleaning, where we mitigate or stop the spread of those MDROs. Isolation cohorting the same, and education and awareness is very important role when it comes to isolation and etc. Leveraging technology to enhance the infection control, it starts with purchasing or supporting the need of electronic surveillance system, as it saves a lot of time when we are dealing with a lot of patients in our healthcare settings. Telemedicine and remote monitoring, it's very important. Antimicrobial surface and materials, it is really helpful when to minimize the number of microbes on the surfaces. Robotics and automated systems and data analysis and machine learning in the AI realm, it is very important when it comes to leveraging technology to enhance the infection control, especially in settings as such as ICU. So enhanced surveillance and targeted screening in the ICU, it is very important to, from the moment of admission, our targeted screening protocol should be into action. We should identify potential carriers of MDROs, candidates, uh, patients with for example, respiratory diseases. Also, discontinue with surveillance of device-related infections such as CLABSI, CAUTI, VAP, or VEE. And this focused surveillance empowers us to swiftly identify outbreak patterns and assess the effectiveness of the primary team practices and the infection prevention and control measures. Central to these efforts is our collaborative approach, bringing together expertise from various disciplines to ensure a comprehensive and coordinated response to the challenge posed by the MDRO and candid auris. Additionally, we place a strong emphasis on the education to educate our staff about those high-risk pathogens. Through this enhanced focus on device-related infections and target screening, we not only safeguard our patients, but also contribute to a broader battle against emerging and resistant pathogens. So recognizing this, we focus on strategies enhancement aimed at architecting an environment that inherently support our mission to minimize the infection risk and provide exemplary patient care. Central to our design philosophy is the delineating of designated zones which within the ICU. By clearly defining the clean contaminated area, we create a physical blueprint that naturally mitigate the cross-contamination risks. Air quality also, it is very important to ensure a proper air quality and isolate those patients who might have an airborne disease or in an airborne isolation room that is negative pressure. Hand hygiene is really important. We want to make sure that the accessibility of hand hygiene station is smooth and easy in the ICU. Isolation room availability, as we said before, and smart use of space. Designing the patient area to maximize the efficacy and safety, allowing the easy cleaning and disinfection while minimizing unnecessary contacts. So our last slide for this presentation before we go with the MCQs is talking about advancing care through equipment and environmental innovation. As the forefront of our strategy is the adaptation of advanced medical device featuring built-in infection control technology, such as antimicrobial coating and material that are just helpful when we are dealing with such patient who might have prolonged device use or at risk of infections. Understanding the importance of equipment integrity, we enforce a strict maintenance and sterilization protocol. Our approach to maintain a sterile environment extend to the adaptation of cutting-edge disinfection technologies such as UV light or fogging machine. And the concept of smart ICU room is transform the way we monitor them and manage the patient care environment, equipped with sensors and automation technology that those room in real time optimization can tell us for example, the opportunities of hand hygiene, etc. And finally, our attention to detail is reflected in the ergonomic design of patient care area by selecting furniture and fixture that prioritize ease of cleaning without compromise the comfort and functionality of the ICU beds. So let's go with testing our knowledge. So our first question for this presentation will be regarding what is the primary reason for implementing the CLABSI insertion and maintenance model in the ICU? Excellent. So the correct answer is B, to reduce the incidence of central line associated bloodstream infection. Next question will be, which of the following is not a component of the cow team maintenance bundle? Excellent. Use of antimicrobial catheter for all ICU patients. Well done. Perfect. So what is the recommended elevation range of the head of the bed to prevent the ventilator-associated pneumonia for adult patients? Excellent. So the correct answer is C. It's from 30 to 45 degree. Well done. Next question, in managing urinary output for ICU patients, which scenario appropriately justifies the use of an indwelling Foley catheter over a non-invasive method like a condom catheter? So in which scenario it is justified to use a indwelling Foley catheter over a non-invasive method, such as a Foley catheter, such as a condom catheter? So um, from those answer, the correct answer is B, because A is talking about a patient who is fully conscious and has occasional incontinence. So since he is conscious and he is awake, he can know that he needs to go to the bathroom, and he can go to the bathroom without the need of using a Foley's catheter. So there is no need for Foley's catheter. He can use a condom, or he can use a bedpan, or he can go to the bathroom if he wants to. The second one is a patient requiring accurate hourly urine output monitoring due to severe acute kidney injury. And in this example, it is very important to make sure that the urine output is accurately measured, because it will be replaced by fluids. And for that reason, it is important to have an indwelling Foley's catheter to make sure that the measurement of urine or urine output is accurate. C is talking about a mobile patient with a mild urinary tract infection preferred not to use a bathroom. So he doesn't have uh, incontinence, he just have an mild urinary tract infection, which is common, which means that due to that infection, he might go to the toilet more often. And for that reason, I don't need to insert a Foley's catheter, because it will just be colonized, and it will keep uh, it will make things worse. And for that reason, he can easily go to the bathroom. And if in case that it is difficult, he might think about other alternatives other than using an invasive device, such as Foley's indwelling catheter. Last one is talking about a patient who is embarrassed by using a bedpan during hospital stay. Yes, I know it is sometimes يعني embarrassing, but يعني it is much safer for the patient not to use an invasive device such as a Foley's catheter. He might look for other alternatives that might help him, but using a invasive device such as a Foley's catheter is not indicated, and will just cause him risk of infection. Last question, for which of the following reason is a central venous catheter most appropriately used in ICU patients? So the correct answer is A, frequent administration of blood products and medication that require a central line due to high osmolarity. Osmolarity. This is a very good indication to insert a central line, while others, all of them are not considered as an appropriate reasons for central line insertion. Thank you very much, everyone for your attending. We will start a poster presentation after me now, after I leave. And what do you think? Shall we come back at 9 or shall we come back at 8:45? Sure. We will resume. Most of you are saying 9, so we will say that I will continue with you at 9 o'clock, inshallah. After me now, you can enjoy the poster presentation, which will take from 5 to 10 minutes. And later on, we will continue our presentations at 9 o'clock. Thank you for everyone and see you at 9. Bye-bye.
Hi, everyone. My topic for today, infection control in the hospital departments. The definition of infection control is its means to prevent or stop the spread of infection in healthcare settings. Healthcare workers can reduce the risk of healthcare associated infection and protect themselves, patients, and visitors by following CDC guidelines. The infection control in the hospital among the departments is for ensuring patients' safety and minimize nosocomial infections. Also, the protocols of infection control are designed to protect patients and visitors and also the healthcare workers. The main, yeah. By adopting infection control practice among the healthcare workers, the hospital can enhance overall healthcare quality and patient safety. There is three types or many types for the infection control. First of all, is surgical site infection. This type of infection control occurs when the bacteria enter surgical wounds. It occurs in the operation room usually, and it's lead to complications for the patients, extend hospital stay, and impacting recovery times for the patients. The second type of infections in the hospital is urinary tract infections. This caused by the misuse of urinary catheters, leading to significant morbidity for the patients. The third infection type is bloodstream infection. This type of infection is serious complications, is associated with the intravenous therapy and maintenance protocol. There is a lot of measures for preventions for infection control. It's applying in all the hospitals around the world. First of all, hand hygiene. This measure is involved with antibacterial soap, water, or alcoholic-based hand rub, and it's used to remove or kill microorganisms that colonize the hands. There is a type for hand hygiene. One of them, hand rubbing. It's use the alcohols from 70 to 80% of alcohol. Second one, hand washing, using the soap and water. The third is surgical hand scrub. Second infection control practice is PPE. This is the cornerstone for the standard precaution. It's providing direct contact with the infection agent. Third one, isolation precaution. This is also implementing globally recognized isolation procedures. Fourth, environment cleaning and disinfection. And the third or the last one is training and education. By continuous training and education for the healthcare workers is essential to keep all the staff informed and engaged in best practice for infection prevention. Conclusion, each department play a vital role in this effort from nursing, medical staff, and to support services. By working together, we can enhance patient outcomes and create a safe hospital environment for everyone. Thank you very much, everyone, for listening.
السلام عليكم ورحمة الله. الصوت واضح؟ تمام. يعطيكم العافية جميعا الحضور، وأشكر القائمين على المؤتمر والمنظمين. I'm Dr. Saif Abdul Rahman. I'm a senior family medicine, senior registrar in family medicine. Today I would like to speak about my poster, which is the sexual maturity in children with regular hemodialysis. As we know all, children with chronic kidney disease on dialysis often experience delayed puberty and reduced adult height due to low testosterone in boys and low estradiol in females. The participant in our study was 106 children, 56 of them with chronic kidney disease on regular dialysis 3 times per week for 4 hours per session, and the control are 60 healthy children. We use in our method the Tanner staging for pubertal assessment and the blood test to assess the total and free testosterone in boys and the total estradiols in girls. We compare the height, the weight, and the disease duration between groups. The finding are we saw that the patient with chronic kidney disease had significantly lower testosterone and estradiol levels than the healthy control children. We noticed also delayed puberty and stunted growth were strongly linked to these hormonal deficiencies. We found also that longer dialysis duration correlated with more severe pubertal delays. We found also testosterone and estradiol levels correlated positively with the Tanner staging, but negatively with disease duration. We mean as as long as the disease is chronic, as long as the testosterone and estradiol are low. To conclude my poster and to get the recommendation, children with CKD hemodialysis often have significantly delays in puberty and adult height. Early kidney transplant may help prevent these complications. So early identification is necessary, and proper management and proper kidney transplant, early kidney transplant may prevent these complications. Further research is needed to explore maybe hormonal therapy as a potential treatment. That's the end of my poster. Thank you everyone for listening.
Assalamu alaikum everyone, and welcome back to our third presentation for today. So now we will be discussing the preventing infections in the OR and delivery room. So as we continue, we will start navigating through the unrestricted, semi-restricted, and restricted zones. We have covered the layers of protection from each area provides, emphasizing the importance of maintaining these barriers to infections. في صوت صحيح، تسمعني كويس؟ ممتاز. We will talk about traffic control, environmental management, and we will talk about minimizing the contamination risk and optimizing the surgical environment for a safe environment for both our patients and staff. In the realm of pre-operative preparations, we delved into the comprehensive measures taken to prepare our patients and staff, ensuring readiness that transcends more physical preparation to make sure that we have appropriate care. And the journey through interoperative recommendation highlights the critical practice that define the surgical excellence. Each step and technique will help to minimize the risk and maximize the patient outcome. And later on, we will talk about the post-operative care and recommendation. And we will talk also about special consideration brought to light to the nuanced needs to each patient, each condition, ensuring our practices are as diverse and inclusive as the individuals we serve. In managing patients and their isolation precaution, we will put a spotlight on that, and we will ensure that even the most vulnerable and vulnerable patients are protected with the highest standard of infection control. And the discussion on the SSI bundle and continuous improvements will help us to resolve to not just follow best practice, but to continuously evolve and enhance our protocol for infection prevention and control. And lastly, we will talk about, we will go through the Q&A session. So as we start today, our journey, let's ground ourselves in the principle that forms the cornerstones of medical ethics. First, do not harm. This principle is especially important when we talk about infection prevention. It's not just about adhering to protocols, It is about actively safeguarding the well-being of every individual who comes to us when we provide the care. Infection prevention is at its core a patient safety issue. It is about taking every possible measure to ensure that our patients emerge from surgery not only healed, but also unharmed by preventable infections. This commitment translates into more than just improved health outcomes. It significantly impacts the economic aspect of healthcare delivery. By effectively managing infection risks, we can avoid the extensive costs associated with post-operative complications, such as extended hospital stay and the need for additional treatments. Moreover, in a world grappling with the rising tide of antibiotic resistance, our infection prevention effort serves a dual response. They are our frontline defense against the spread of resistant organisms, ensuring that antibiotics remains an effective tool for generation to come. As we delve deeper into the nuances of infection prevention, we also recognize its role in enhancing the success of surgical interventions. The efficacy of our strategies is measured not just by the immediate outcome, but by how well we can prevent complications down the line, ensuring the patient satisfaction and overall well-being. It's also crucial to remember that our commitment to infection prevention is not just a matter of best practice, it is a legal and ethical obligations. Adhering to stringent infection control measure is how we honor the trust our patients place in us and ensuring that we not only heal but also protect. So as we progress to understanding the structural and procedural backbone of infection control within our operating rooms, let's focus on the critical concept of OR zones. These zones are not just physical spaces, but are strategic layers of defense against infections, each with its own set of rules and protocols aimed at minimizing the risk of contamination. Starting with the unrestricted zone, the threshold of our surgical environment, it serves as the initial filter. Here, the transition from the everyday hustle and to a more controlled setting begins. It's where we start to shed the outside world and we prepare to enter the realm where the stakes of infection control are significantly higher. Moving inward, we encounter the semi-restricted zone. Think of this as a buffer zone where the commitment to infection prevention takes a more visible form through the donning of surgical attire. And this zone marks a significant escalation in our infection control efforts, preparing us for the entry into the core of surgical area. And lastly is the restricted zone, which represents the core of the OR, and entry is reserved for those who are fully prepared through a surgical scrub and the donning of sterile gowns and gloves to engage in a surgical procedure. And this is where the most stringent infection prevention measures are in practice, reflecting the critical importance of maintaining sterility at all costs. And the delineating of these zones and the strict control of traffic patterns within them are fundamental to our infection control strategies. They ensure that movement of persons, patients, material do not compromise the sterility of the surgical environment, and each zone with its specific guidelines and restriction contribute to a layered defense strategy against potential infections. So let's take one by one in a deeper context. So let's begin with the unrestricted zone. This zone serves as the operational getaway where the seamless transition of patient, staff, and material into this into the surgical care is observed. Unlike the more controlled zone that lie beyond, the unrestricted zone allows for street clothing and hosts a variety of essential functions. So the heart of this area is the central control point, a crucial hub where the movement into semi-restricted area is carefully monitored, and this point ensures that while accessibility is maintained, it is never at the cost of the safety or order. Despite its openness, the unrestricted area is bound by policies that limit public access, a testament to the balance it strikes between being welcoming and maintaining the sensitivity of the surgical environment. And this zone is home to vital components that supports the surgical processes, such as staff changing area, where the transition toward surgical readiness begins, lounges, offices that support staff well-being and administrative efficiency, and waiting rooms where patients and family await there. Importantly, it is also encompasses of pre and post-operative patient care area, making the start and completion of the surgical journey for many patients. The unrestricted area might be the least restrictive in form of access and attire, but it is by no means the least important. It sets the stage for the strong infection control measures that follow, highlighting the principle that every layer of our surgical environment contributes to the patient safety and care excellence. As we go forward from the unrestricted, we will enter now the semi-restricted zone or area. And this zone where a balance between accessibility and surgical attire become more pronounced. This area serves as a crucial buffer, supporting the core activity of surgical care while upholding the principle of infection prevention. The semi-restricted area is characterized by its role in peripheral support. It houses the essential supplies and facilitates and facilities that is needed for surgery, including clean and sterile storage, area for instrument storage, and also it ensure that the highest standard of cleanliness and readiness are met. In this area, you should wear your surgical attire, and this is included for staff and who are accompanying the patient if they are given the approval to do that. Also, there should be a head cover and facial hair cover in that area as well. Lastly, we have the restricted area is where the operations are done, and it is the last area, and it is the most important area in the OR. And in this area, the access to this zone is highly controlled, marking a transition to an environment where every protocol and practice is aimed to eliminate the risk of infection. And this area it include the OR theater with the scrub sink area. And in this area, they have to cover their hair either from head or facial hair. And they have to wear, if they are the OR team, they have to wear sterile attire, while the support team, they can help without invading the sterile field in the OR theater and without the need to wear sterile attire. So here, let's talk about the traffic control. And the traffic control is not about a normal thing we do. It is a cornerstone in our infection control prevention strategy. And it isn't just about directing the flow of people. It is a multifaceted approach designed to maintain the integrity of the clean versus contaminated area. Our operating room are delineated into distinct zones, each with its own sets of rules aimed at minimizing the risk of contamination. And our journey begins with the unrestricted, as we said, where street clothing are permitted. Then we go to the semi-restricted, where they have to wear surgical attire and cover their facial hair and head. And also it ends with the restricted area. And in the restricted area, as we said before, they have to be sterile. So also, we have to make sure that when we are talking about the door in the OR, it has to be maintained closed at all time because we are making sure that the OR air quality is at excellent care. And we want to make sure that only necessary passages of equipment and personnel and patients are done when we open or close the door, because it will interrupt the airflow in the OR and will cause turbulence and might increase the risk of infection. So here, let's uncover the advanced strategy employed to fortify our defense against infections. Our operating theaters are engineered not merely as spaces for surgical procedures, but uh, um, as stations for infection prevention, where every detail from airflow or to temperature is meticulously calibrated for safety. So in here, we focus our measures on multiple things, including the positive pressure ventilation system, which is a critical component that ensure that operating room maintain a higher pressure compared to other adjacent areas. And the pressure should be at least 20 air, it should be a positive pressure with also we use the air change per hour, and the air change per hour, it should be a minimum of 20 air change per hour, which means all the air inside the OR theater will be changed. It will 20 times every hour. And the air that comes to the OR, it must be at least 20% fresh air. And the optimum or the ideal way to do it is to have it 100% fresh air. Climate control, we are talking about temperature maintaining between 21 to 24 with a relative humidity from 20 up to 60%. And we want to make sure that it feature a minimum of 4 exhausts. There should be a HEPA filter in the OR for the supply duct. So all the air that goes to the OR, it should pass through a HEPA filter. And it should be working or operational for 24/7, even in weekends or night. The OR ventilation system should never stop. Also in the OR theater, we have the laminar airflow system, which is like forming an air curtains around the patients. And you can see in the OR design that the OR flow is coming above the patient, supply is coming above the patient vertically. And then it spreads to the borders of the room where the exhaust is placed on the floor to have the air going through a unified direction, washing off all the microorganisms away from the patients. Also in the OR, we have usually the UV light disinfection inside the ducts to disinfect the air before it goes to the patients. So as we embark on the critical phase of preoperative preparation, we embrace a dual focus approach that places equal importance on preparing both our patients and our staff for the journey ahead. This section reveals the comprehensive strategies and meticulous protocols that lay the groundwork for surgical success, ensuring that every aspect of care is optimized for safety and efficacy. For our patients, preparation extends beyond the physical. It encompasses a series of tailored screenings to identify potential health concerns, optimizing of existing condition and specific hygiene protocols aimed at reducing microbial load on the skin. And this preparation is critical not only for minimizing infection risks, but also for enhancing the overall success of the surgical procedure. Parallel to patient preparation, the readiness of our surgical team is very important as well. From surgical hand scrub to the donning of appropriate surgical attire and personal protective equipment, every step is taken to ensure that our staff is fully prepared to maintain the highest level of sterility within the operating room. And this includes a commitment to hand hygiene, a cornerstone in infection prevention, and meticulous use of PPE to protect both patients and healthcare providers. The essence of preoperative preparation lies in its collaborative nature, and it involves the coordination and dedication of surgical, nursing, and ancillary staff, each playing an important role in upholding the standards of care that our patients expect and deserve. Underpinning these efforts is a commitment to continuous education in the rapidly evolving field of medicine, staying abreast of the latest protocol innovations and the best practices in infection prevention is essential. Regular training sessions ensure that every team member, regardless of their role, is equipped with the knowledge, skills necessary to contribute to the safe and successful outcome of every surgical procedure. And as we delve deeper into the specifics of patient and staff preparation, let's keep in mind that these protocols are more than just steps in a process. They are the foundation upon which we build our commitment to patient safety, surgical excellence, and the relentless pursuit of a better outcome. So as we go deeper, let's put a focus on the patient preparation, where we focus on serious preoperative steps designed to minimize the infection risk and optimize the surgical outcome. It starts with the pre-surgical screening, which is our first line of defense, aiming to identify and address any existing infection that could complicate surgery, such as urinary tract infections, and to screen for conditions that could affect surgical outcome, including, for example, HIV or hepatitis B, C, or MRSA. And for those surgeries deemed to be high risk, this step is particularly important, ensuring we tailor our care to each patient's specific health profile. Then we talk about glucose control. They represent another critical aspect for our preparation, with evidence showing that maintaining blood glucose level below 200 milligram per deciliter significantly enhance the wound healing and boost immune function, which is very important when we are talking about surgical success. Also, we counsel patient on the benefits of smoking cessation well before their scheduled surgeries, and we ask them to reduce or stop the smoking for at least 30 days before the before can be dramatically which can such practice can improve the recovery rate and decrease the likelihood of complication. Then we talk about hair removal, which is necessary, and it is performed in a manner that should minimize the skin irritation and the risk of infection, using electric clippers or rather than traditional razors. So razors are not recommended, and it is recommended to use the electrical clippers for hair removal for the OR. Then we talk about the role of preoperative bathing, and we advise the patient to take at least 2 showers using antiseptic soap to significantly reduce microbial flora on the skin and thereby decrease the chance of post-operative infection. And usually we recommend that they do it the night before the surgery and the day where the surgery will happen. Finally, we focus on the accurate or the proper use of prophylactic antibiotics administered within the specific time frame before surgery, and it is very important in the infection prevention strategy. And this practice aligned with the recommendations of our antimicrobial stewardship program and committee, which is essential to prevent the surgical site infections. Now we will talk about staff preparation. And here we recognize the immense responsibility that our surgical team carries in preventing infection and ensuring a successful operation. The surgical hand scrub stand as the fundamental practice, and it is very important when we talk about surgeries, and it's very important to be done accurately. The antiseptic hand washing is not just about cleaning your hand. It is a proactive measure to significantly reduce the microbial load and protect the area of the sterile field. We got a question regarding the antimicrobial prophylaxis, if I'm not mistaken. The time frame and everything, we will discuss it at the end of the presentation. Okay. So adhering to surgical attire is also very important. Scrub suits, hair covering, and mask forms the basic armor in our battle against infections, creating a barrier between the sterile environment of the OR and the potential contaminant of the outside world. So hand hygiene is still simple, but it is still a powerful tool that is practiced before every entry of the operating theater, and even after you finish the OR operation. And the health of our staff in the OR is closely monitored, with a clear protocol for managing those who might be infected or colonized with the transmissible pathogens. And this caution approach ensures that we minimize the risk of introducing infection into the OR. And then we talk about PPE compliance. It is a critical component for our staff, as it will protect both our staff and patients. And it's very important to emphasize on the ongoing importance of the ongoing education and competency assessment for all the staff who are working in the OR. So in the following video, now we will play a video that shows how to appropriately do a surgical hand scrub using the brush stroke method. And please pay close attention to the technique, as it is a critical skill that underpins the safety and success of every surgical procedure.
This video is for training purposes only. Surgical site infections, or SSI, remain a prevalent threat to patient safety. Proper surgical hand scrub or rub techniques are essential to decreasing incidence. This video provides instructions on anatomical surgical hand scrub procedure using the brush stroke method. If done correctly, this procedure should take 3 to 5 minutes. Before beginning the surgical hand scrub procedure, you must remove all jewelry from both hands and arms. Inspect your skin and nails. Ensure your skin is free of any cuts and wounds. Nails must not extend past your fingertips, and nail polish must be intact without chips or scratches. Remember, acrylics, artificial nails, and nails with foreign bodies are not allowed in the operating room. Put on your personal protective equipment. Make sure your hair and ears are tucked into your surgical head covering, and that any neck jewelry is contained in your surgical attire scrubs. Don proper eye protection and a surgical mask, covering your nose, mouth, and if applicable, facial hair. To begin the scrub, tear open a sponge of your preferred hospital-approved antiseptic, either chlorhexidine or betadine, also known as povidone. Place the open packet on the shelf above the sink with the tear facing the ceiling. You must pre-wash your hands and arms only if this is the first case of the day or if your hands are visibly soiled. Use the soap from the dispensers located within the scrub sink or in a separate container above the sink. Then, use the disposable nail pick and clean under your fingernails under running water. Dispose of the nail pick in the trash can beside the scrub sink and rinse hands and forearms. Once hands and arms have been washed, remove the sterile surgical sponge from its wrapper and moisten the sponge under running water by squeezing and releasing it. With fingertips together, use a light but firm pressure to stroke the nails in a back and forth motion with the abrasive brush side of the sponge approximately 30 times. The abrasive brush side is only used on your fingertips. The non-abrasive side should be used for the remainder of the scrub. Next, turn the surgical sponge over to the non-abrasive side. Place fingers side by side, including the thumb, and scrub the surface of the palm 10 strokes. Then, turn the hand over and scrub the dorsal surface 10 strokes. Next, scrub the outside surface of the thumb from wrist to tip of the thumb 10 strokes. Continue to apply 10 strokes to the other side of the thumb and to each side of your fingers. Once you scrub an area, do not go back. Now that you've scrubbed your hand, it's time to scrub your arm on the same side. Mentally divide the forearm into thirds from wrist up to 2 inches above the elbow. When scrubbing each third of your forearm, apply 10 strokes to the top, bottom, and both sides of each section. Like before, once you scrub an area, do not go back. Repeat the scrub on the other hand and arm. Once both hands and arms are complete, discard the surgical sponge in the trash can beside the scrub stick. Start rinsing at your fingertips and continue to the hand, forearm, and elbow, moving in one forward direction through the water. Always keep your elbow at a right angle and hand raised above the level of your elbow. Do not move arms back and forth in the water. If you need additional rinsing, completely remove your arm from the water stream and re-enter at the fingertip until you reach the elbow. Once rinsing is complete and no antiseptic remains on the hand and arms, turn off the water with the knee control. To avoid contamination, keep hands above the level of the elbow and away from scrub attire and non-sterile surfaces. Allow residual water to drip off the elbows and into the sink. Do not shake or wave hands and arms to remove excess water. Walk backwards through the operating room door and dry hands and arms with a sterile towel before donning a sterile surgical gown and gloves. This video.
Excellent. So in our next video, we will go through the sterile gowning and gloving technique for OR. Please observe those steps closely, and as it's very important to understand how to wear your surgical attire, even if you are alone or with help of someone else.
Hello, and welcome to another Amboss tutorial. In this video, we'll show you how to put on a surgical gown and gloves. First, let's go over the technique of gowning and gloving with minimal assistance using the closed glove technique. Make sure to check that you have the correct glove size and that the packaging is intact. The gown is often one size fits all. Open the gown packet and drop the package wrapped in paper onto a clean table. Open the gown pack by only grabbing the edges of the paper to maximize the sterile field. Make sure to really only touch the corners while doing this. The paper surface you've created in front of you is now your sterile field. You can now drop the sterile paper packaging of the gloves onto it as well. Do this by opening your glove package and letting the inner sterile packet drop onto the sterile field without touching it. Depending on what you're planning to do, it's now time to either disinfect your hands or perform a surgical scrub. After scrubbing in, keeping your arms elevated, dry your hands and forearms with the sterile towels in the gown packet. Now you can put on the gown that is lying in front of you, folded inside out with the collar and one of the two shoulder areas visible. Pick up the folded sterile gown so that it can't unfold on its own. Hold it securely in front of you and step away from the sterile area. The collar should be at the top. Now reach into the inside shoulder areas with each hand in turn and hold the gown in front of you with outstretched arms. Stand so the gown can't touch anything when it unfolds. Then, allow the gown to unfold by itself, making sure it doesn't touch the floor. If it doesn't unfold easily, try giving it a gentle shake. Once the gown is fully unfolded, carefully slide your arms into the armholes one at a time. You can slightly raise and spread your arms to guide each arm through the sleeves. Since you're going to use the closed glove method to put on your gloves, make sure to keep your hands completely inside the sleeves for now. Keep them at shoulder height so you don't touch anything and so that the gown doesn't slide back down. At this point, you'll need some help. Ask an assistant to pull the gown all the way over your shoulders and to help fasten the back and waistband. Keep your fingers inside the cuffs. Now we'll show you the closed glove method. First, unfold the sterile paper package and press the edges down so they don't fold back again. Grab the right glove with your left hand. Now place the glove on your right palm, flipping it over so the fingers point towards you and the thumb is on the correct side. With your left hand, pinch the part of the cuff facing up, and with your right hand, pinch the part of the cuff facing down. Next, use your left hand to pull the glove over your right hand and the gown sleeve. When you pull back the gown sleeve, the glove will pull back with it and let you slide your hand into the fingers. Done. Do the same with the left glove. Turn it, put it on your left palm, grab part of the cuff facing down with your left hand and the part facing up with your right hand. Pull the glove over your left hand and sleeve, pull it back with the gown, and slip into the glove. Finally, the surgical gown has to be secured. If you'd like to look at this straight away, just skip to the last section of this video. Otherwise, we'll first look at how the whole thing works when you have an assistant to help you gown and glove. The sterile gown will often already be held open for you by an assistant after you scrubbed in, especially in the OR setting. All you have to do is slip your arms into the sleeves and the gown is pulled up over your shoulders and closed at the collar and back. The wrists should remain covered by the gown. Keep your hands in front of your chest so you don't accidentally touch anything and the gown doesn't slip back down. Now it is time to get your gloves on. The assistant will often stretch the right glove open for you so you can easily get your hand in. Slide your hand in with the thumb adducted, then spread your fingers slightly. The assistant will then pull the glove all the way over your wrist and the gown sleeve. Next, the left glove will be handed to you. Stretch the cuff open with your right hand and pull it on. Again, keeping your thumb adducted initially as you slide your hand in. Now, secure the gown. The technique is always the same, whether you have self-gowned or gowned with assistance. Grab the paper tag hanging at waist level and pull off the left tie. Hold that tie firmly in your left hand and hand the paper tag to your assistant. Then do a counterclockwise turn, making the tie close the gown. Grab the end of the other tie, taking care not to touch the tag itself. Pull the tie off the tag, tie a bow, and your gown is secured. Now that you have your gown and gloves on, it's best to keep your hands clasped to your body at chest height while you're not actively using them. Great! Now you're fully gowned, gloved, and ready to go.
So as we move into the critical phase of the intraoperative recommendation, our focus sharpens on the practices and protocols that define the surgical excellence. This section is dedicated to the strategies that ensure not only the successful completion of surgical procedure, but also the maximization of patient safety and minimization of the infection risks. One key aspect we will delve into is the maintenance of normothermia, keeping our patient at a normal body temperature during surgery is crucial for reducing blood loss and enhancing tissue oxygenation and ultimately improving the outcome. We will also explore the importance process of skin antisepsis. So proper skin preparation before incision can significantly reduce the microbial load and decrease the risk of surgical site infection. Our discussion will extend to surgical technique and wound management practices that prioritize gentle tissue handling, effective hemostasis, and the careful management of foreign bodies, all aim to reduce the infection risk as well. Also, the integrity of the sterile field is very, very important. We will cover the measures taken to ensure that asepsis is maintained throughout the procedure, including the disciplined use of sterile drapes and equipment. Also, limiting operating room traffic continue to be a focus during surgery. By minimizing personal movement and door openings, we can maintain optimal air quality and further reduce the infection risks. And finally, we will touch on the intermediate post-operative care protocol, from the way we dress wounds to how we handle patient transfer and equipment, where every action is guided by the overarching goal of preventing infections and promoting the healing. As we transition to the post-operative care, our focus shifts to the strategies that ensure our patient journey toward recovery is as smooth and complication-free as possible. And the key to this phase is diligent incision care and monitoring, proper dressing change, vigilant observation for signs of infections, and strategies to promote wound healing are very important in preventing complication and ensuring a swift recovery. The importance of temperature and glucose control extends beyond the operating room into the post-operative phase. Maintaining normothermia and managing blood glucose level is very important and critical component of post-surgical care, supporting the overall patient well-being and recovery. Effective pain management not only ensure patient comfort, but also play an important role in minimizing the risk of complication. By effectively managing the pain, we encourage faster recovery and facilitate the return to daily activities. Physical activity and rehabilitation is very important in the recovery phase. Gradual increases in the activity levels guided by tailored rehabilitation plan helps to enhance the physical function and overall health. And also we talk about the nutritional support, which is another cornerstone in the post-operative care. A well-balanced diet rich in nutrients supports wound healing and can significantly impact the speed and the quality of the recovery. And lastly, follow-up and patient education is very essential, ensuring patients are well informed about their care plan, signs of potential complication, and when to seek medical advice empowers them to actively participate in their recovery phase. As we progress further, special consideration in surgical care, we recognize that every patient, procedure, and situation begins with unique challenges and needs. And this section is dedicated to explore and tailor approach and protocols that exploring the tailored approach and protocols that addresses these specific aspects, ensuring that our surgical care is as comprehensive and individualized as possible. From managing patients in isolation to mitigate the risk of cross-contamination to the meticulous handling of surgical specimen, each consideration is important for maintaining the highest standard of care and safety. Blood management, a critical component of surgical care, focuses on minimizing the blood loss and optimizing the transfusion practices, which is paramount for patient recovery. The use of technology and innovation, again, represents our commitment to advancing surgical care. By incorporating cutting-edge tools and practices, we aim to enhance surgical outcome, minimize the risk, and improve the patient experience. Moreover, recognizing and respecting culture and ethical consideration is fundamental to our approach. It is essential that we align our care with the diverse values and beliefs of our patients, ensuring that every individual feels respected and valued throughout their surgical journey. And lastly, we address the growing importance of environmental sustainability in surgery. As healthcare providers, we are increasingly aware of our roles in reducing waste and minimizing the environmental impact of our operations, striving for practices that are not only beneficial for our patient, but also for the planet. As we explore the critical aspect of managing patients in isolation precaution, we delve into the specialized protocol and measures that safeguard both our patients and healthcare team from communicable diseases. And this section is dedicated to discuss providing surgical care under isolation condition, emphasizing the strategy that ensures safety without compromising the quality of care. Isolation protocols, as we know, they are very important and designed to prevent cross-contamination and protect all individuals within the surgical environment. And this include meticulous attention to the use of PPE and barrier precaution, which are essential for maintaining a sterile field and ensure the safety of both staff and patients. Recognizing the importance of scheduling, we discuss strategies to minimize the exposure risks, such as timing surgeries for infectious patients at the end of the day, or when the OR can be appropriately prepared and cleaned afterward. Environmental control play a crucial role with enhanced cleaning and disinfection protocol tailored to the need of isolation care, and this ensures that every surface, instrument, and piece of equipment is meticulously sanitized to prevent the spread of infection. Team communication and training is a very important component to our approach. By ensuring that all members of the surgical team are well versed in isolation procedure, we foster an environment of safety and preparedness. Through this process, we remain deeply committed to patient dignity and support, balancing strong infection control measures with compassion care, ensure that our patients feel respected and cared for even under strict isolation precaution. And lastly, we underscore the importance of vigilant post-surgical monitoring. Patients previously under isolation precaution require careful observation for any signs of infections, ensuring timely intervention and support during their recovery. In the face of surgeries involving patients with suspected or confirmed airborne bath and transmission diseases, our protocols are meticulously designed to safeguard both patients and healthcare team while minimizing the risk of airborne infection transmission. Given the positive pressure nature of our operating rooms, these surgeries are reserved for emergency or medically necessary cases only, emphasizing the need for careful planning and execution. Scheduling these surgery at the end of the day or during minimal OR activity is the key strategy, reducing the number of individuals potentially exposed. Whenever possible, the initial intubation is performed in a negative pressure room, underscoring our commitment to containment and safety before transitioning the patient to the OR theater. The presence in the OR is strictly limited to essential staff only to minimize the exposure. And during critical phases such as intubation and extubation, the use of portable HEPA filter is a cornerstone, and it is very important to not be turned off during the surgery, and it should maintain the air optimal quality in the OR. Furthermore, protective measures include the integration of bacterial filters within the breathable circuits of anesthesia machines, and the mandatory use of approved surgical respirators by all team members like N95 or PUPR, specifically avoiding those with inhalation valves that might to protect the sterile field. Post-operative recovery is managed with the highest level of cautions, preferring recovery in negative pressure isolation room or at minimum single room equipped with a portable HEPA filter. Throughout the procedure, the doors of the OR remain firmly closed, and there is a strict policy against altering the ventilation parameters of the theater, ensuring that we maintain controlled and safe environment for everyone involved. Through those strong protocols, we demonstrate our unwavering dedication to provide safe surgical care under even the most challenging condition, where we prioritize the well-being of our patients and the health and safety for our staff. So as we go through the SSI bundle and the philosophy of continuous improvement, we embark on a journey toward enhancing patient safety and surgical outcome. And this approach is not static, it is an evolving strategy and underpinned by a commitment to reducing the post-operative infection through a meticulous designed set of practices. The SSI bundle represents a synthesis of evidence-based interventions, including appropriate hair removal before the surgery, timely administration of prophylactic antibiotic, strict maintenance of normothermia, and effective glucose control in the perioperative period. Each component is chosen for its impact to reduce the risk of SSI, emphasizing the critical role of preoperative and vigilant in surgical care. By implementing these measures is only, implementing these measures is only the beginning. The true strength of this approach lies in the commitment to continuous improvement. By utilizing detailed surveillance form and the tracking event data, we can monitor our compliance with these practices, identify areas where improvement are needed, and adjust our strategies accordingly. And this data-driven approach ensures that our actions are always aligned with the best possible outcome for our patients. Collaboration across disciplines in the is the cornerstone in this process. Like we have surgeons, nurses, anesthesiologists, infection control specialists, and other healthcare worker professionals working together, sharing insights and experience to refine and improve every aspect of our infection prevention efforts. So as we move forward, we will go into understanding the wound classification, which is crucial element in tailoring our infection prevention strategies. And this system which categorize emergence and this system which categorize wounds based on their contamination level serves as a vital guide for surgical teams in managing infection risk and optimizing patient outcome. So when we talk about class 1 is called the clean wounds and represent the ideal scenario where the surgical environment and the procedures are controlled meticulously to avoid contact with microbial rich area. And these wounds have the lowest risk of infection, reflecting the effectiveness of our sterilization and procedural protocols. Moving to class 2, it's called clean contaminated wounds. We encounter surgery that inherently involve entry into the respiratory, gastrointestinal, or genital, or even urinary tracts. Despite this, the condition are managed to minimize the contamination, maintaining a balance between surgical necessity and infection control. So if the surgery involve respiratory, gastrointestinal, genital, or urinary tracts, it will be classified into class 2 clean contaminated. Then we talk about contaminated wounds, which is class 3, which include scenarios where despite our best efforts, contamination occurs. This might involve accidental wound or operation where sterile technique is compromised. Here, our focus shifts toward aggressive infection prevention measures to mitigate the heightened risk or the high risk. So if, for example, if you have a patient with accidental wound, it means that this wound is in the classification of contaminated. Or, for example, if you have a patient who was in the OR and the operation was there, the operating team were operating on the patient, and during that time, the sterile technique was compromised, then the classification of that surgery will jump to classification class 3, which is contaminated. Lastly, we have class 4, which is dirty or infected wounds. And it is challenging us with pre-existing infection or heavily contaminated wounds. And these cases require not just surgical intervention, but also it requires a comprehensive approach to manage and resolve the infection, underscoring the complexity of surgical care. Then we will talk about the ASA score, which ASA, it stands for American Society for Anesthesiologists, which this score stands as an important tool for preoperative assessment by anesthesia team, offering a standardized method to evaluate a patient's physical status and associated surgical risks. And this scoring system enables us to tailor our approach to each patient, ensuring that we are not fully aware of the potential challenges that are prepared to address them. So it goes into 5 classes. ASA1, it represents the ideal scenario where we have a normal healthy patient embarking on a surgical procedure. These patients typically have the best outcome due to the absence of complicating systematic diseases. Then we have ASA2, which refers to patients with mild systematic disease. These conditions, while present, do not significantly limit the patient activity. They include well-controlled disease such as controlled hypertension or controlled diabetes without systematic effects. Then we have the ASA3, which is for patients who have severe systematic disease that limit their activities but are not immediately life-threatening. Example includes stable angina or moderate to severe asthma, and those conditions require careful management to mitigate the surgical risks. Moving to a higher level of concern, which is ASA4, patients with severe systematic disease that poses a constant threat to their life. Disease such as severe heart failure or advanced pulmonary renal or liver dysfunction fall into this category, demanding meticulous planning and monitoring throughout the surgical processes. And lastly, ASA5 patients are those considered moribund and facing an immediate threat to life without surgical intervention. And those cases are the most challenging, requiring not just surgical expertise, but also comprehensive care to navigate the delicate balance between the urgency of surgery and the risk involved. Thank you very much. I think we received one question regarding surgical prophylaxis. And for the surgical prophylaxis, we follow the MOH regulations. In the MOH regulation, it classifies each surgery each surgery, it classifies them into groups, into systems, like for example, respiratory surgeries, cardiac surgeries, etc. And in each section or group, It describes the most common usually surgeries that are done in that group. For example, if we are talking about orthopedic surgery, we are talking about knee arthroplasty, for example, or spinal cord surgeries, or etc. And for each surgery, they describe which type of antibiotic is needed. Yes, so the timing of the antibiotic prophylaxis depends on the type of, mashallah, you're starting the questions. I didn't check that. I already put the question in here. So the timing of the surgery, the timing of antibiotic prophylaxis is based on the type of antibiotic that is given. For example, if we are giving cefazoline, 2 grams, which is the commonest, usually the timing is 1 hour before the surgery, or within 1 hour before the surgery. But if you are, for example, giving vancomycin, it is recommended to put it for at least 2 hours. And the reason is that we want to make sure that the minimal inhibitory concentration, or the MIC, or will not and the which is called the highest level of antimicrobiotic what is it called invasion of the tissues, it reach the tissues at the maximum level at this time of the incision time. And the antibiotic can be given again during the surgery in cases of obese patients. He might double the dose also, or increase the dose, let's say. Or if the patient's operating procedure is prolonged, so it's exceeding, for example, 2 to 4 hours, then the antibiotic prophylaxis should be given again. Otherwise, the antibiotic should be given only as 1 dose before the surgery, and that's it. So question number 1, excellent, everyone, all of you. Okay, is giving antibiotic need skin tests? This is related to the allergies of the antibiotics. So some antibiotics might cause an allergy to the patient, and there are alternatives for that. For example, cefazoline might cause an allergy for people who are allergic to that antibiotic, and sometimes the alternative could be erythromycin, or I'm not sure which alternative is common, but it is usually described in the MOH regulation regarding antibiotic prophylaxis. And why I'm talking about MOH regulation, because each country have their own regulation when it comes to use of antibiotics according to the national which is called antimicrobial stewardship program. Also, hospitals, if they have a high number of surgeries, they might be able to build their own protocols, but we prefer to use this national one because the national one represents the community, which is the community of Saudi Arabia, which is the best practice when we are talking about surgical prophylaxis. That's it. For question number 1, which area in the operating room allows street clothing and serve as interface between the hospital general areas and the surgical suites? Your answers, all of you answered correctly. It is the unrestricted area. Well done. For question number 2, what is the primary purpose of maintaining positive pressure in the operating room? You have 4 answers. Enjoy. Excellent, well done. So the correct answer is B, to prevent airborne infections from entering the room. Question number 3, which of the following is not a component of the surgical site infection bundle? Excellent, everyone. So the correct answer is B, hair removal using razors. Question number 4 is saying, generally, during which phase should prophylactic antibiotic be administered to minimize the risk of surgical site infection? And here we are talking generally, it's in a specific situation. Excellent. The correct answer is C, within 1 hour before surgical incision. Well done. Not at the time of surgical incision, within 1 hour before surgical incision. This is the optimal answer. And last question is, for diabetic patients undergoing surgeries, maintaining serum glucose level below what value is recommended for post-operative glucose control? So at which level the glucose control should be maintained for diabetic patients undergoing surgery? Is it 200 milligram per deciliter, or 126 milligram per deciliter, or 100 milligram per deciliter, or 180 milligram per deciliter? In our lecture, we said that it should be maintained within 200 milligram per deciliter, which is A. So patients who are undergoing surgeries, their blood sugar should be maintained under 200 milligram per deciliter. Thank you very much, everyone. Do you want a break for 5 minutes, or shall we continue with the 4th presentation? The majority says continue, so we will continue. أتوقع it will be in the channel, YouTube channel of the Future Vision. It will be there. You can see it from there. So our 4th presentation for today will discuss the IBC practices in the ER primary triage. In this presentation, we will get through our agenda, and we will begin by grounding our understanding in the importance of the IBC in the emergency settings. It is here we will uncover why IBC is not just a protocol, but the very foundation upon which the safety and efficacy of emergency care rests. Moving forward, we will delve into the front line of defense, ER triage, examining the crucial role of initial assessments and the strategic implementation of IBC measures right from the first point of contact. Our journey continues as we explore implementing IBC at the front desk and waiting areas, focusing on initial screening measures, the design of waiting areas, and the critical adjustment required to maintain a safe environment for all. We then transition to assessment, isolation, and patient flow, where the principles of rapid assessment and safe transport of patients to isolation area underscore our commitment to minimize the spread of infection within our facility. And in the infrastructure and operational consideration section, we will discuss the physical and procedural adaptation necessary to support the IBC, from ER layout modification to environmental cleaning and disinfection practices. And acknowledging an evolving landscape of global health, we will address case definition and triage protocol for notable infectious diseases. And this segment is dedicated to equipping you with the knowledge to identify and manage diseases like COVID-19, MERS-CoV, monkeypox, Ebola, emphasizing the importance and the precision and preparation in our ongoing battle against infectious threats. And finally, of course, we will enjoy our Q&A session. So infection prevention and control, or IBC, stands as a pillar in our continuous efforts to combat the spread of infections, a challenge all the more pronounced in the high octane environment of the emergency room. And here, where decisions are made in seconds and outcome can last a lifetime, the implementation of strong infection prevention control measures is both our challenge and our shield. The ER unique landscape, marked by an unparalleled diversity of patients, conditions, and the sheer unpredictability of emergency care, demands our utmost diligence in IBC practices. It is sitting where vulnerabilities are most exposed and the stakes and risks are high, underscoring the need for an unwavering or a lot of commitment to infection prevention and control protocols. And this commitment not only plays as our defense against the transmission of infectious diseases, but also it encapsulates our dedication to protecting the very heart of our healthcare system, our patients and the healthcare worker who serves them as well. So effective IPC in the emergency settings go beyond mitigating immediate risks. It resonates through the corridors of our healthcare facilities, influencing patients' outcomes, staff well-being, and the overarching of public health landscape. It's about creating an environment where safety is inherent, where every procedure, every interaction, and every decision is imbued within the highest standard of infection control. As we delve deeper into today's discussion, let us be guided by the principles of vigilance, empathy, and innovation. Together, we will explore the complexity of the IBC in the ER, and with the knowledge that our action contribute to a larger narrative, one of the resilience, progress, and collective commitment in excellence in healthcare. So as we turn our focus to the very heart of the emergency department, the ER triage room, we recognize it not just as a hub of activities and decisions making, but as our front line of defense in the battle against infections. Here, every patient journey begins with it our opportunity to implement stringent infection prevention and control measures right from the first points of contact. The essence of triage in the ER is rapid identification and action. It's where our preparedness meets practice, enabling us to swiftly identify potential infectious cases and take immediate steps to minimize the risk of transmission. This rapid response is crucial not just for the patient in question, but for the protective of all patients and staff within the emergency department. But the challenge in the ER triage is the delicate balance of priorities. We are tasked with distinguishing the urgent from the non-urgent, all while integrating effective IBC measures. It is a complex dance requiring a deep understanding of both medical triage and infection control protocols. The balance ensures that each patient receives the care they need when they need it without compromising safety. And behind this balance acts is our dedicated staff whose training and preparedness form the backbone of our IBC efforts in the ER, and they stand ready, equipped with the knowledge and tool necessary to make informed decisions swiftly. Their role is important, for it is through their expertise and actions that can be uphold the highest standard of patient care and safety. As we approach the crucial first step in our emergency department, the entry point serves not just as a physical threshold, but as a critical juncture where our commitment to infection prevention and control is put into immediate action. The mitigation of comprehensive screening protocol right at the entrance underscore our proactive stance towards safeguarding health. By meticulously assessing symptoms and exposure history, we are not merely processing information, we are actively filtering potential threats, ensuring that our emergency departments remains safe for the people who comes. And to augment the efficacy of our screening measures, we turn to visual alerts and information displayed prominently across our entry points, leveraging both signage and digital screens, and mindful of the diverse patient population. We convey crucial IBC measures and expectation in both Arabic and English. This dual language approach ensure that our message of safety and vigilance resonate with every individual stepping into the emergency department, fostering an environment of inclusivity and awareness. The strategic placement of hand hygiene station serves as a tactical reminder of a simple yet profound act of sanitization, positioned for maximum visibility and accessibility. And those stations invite all who enter to join us in the collective effort to stem the tide of infection, reinforcing a culture of health and hygiene from the moment of entry. Moreover, the provision of personal protective equipment to those identified as symptomatic or at risk of is also a testament to our layered defense strategies. By equipping our patient and visitor with masks and other necessary PPE if needed, we fortify our barrier against the transmission of infectious diseases or agents, and ensuring that the principle that protect us is a shared responsibility between us and our patients. And finally, our commitment to IBC extends into the very layout of our facility by thoughtfulness designing queue lines and waiting areas. We ensure physical distancing is not just encouraged by seamless integration into the fabric of our environment. This spatial configuration minimizing the risk of airborne transmission among those waiting, which is a crucial adjustment in our ongoing battle against those infectious diseases. In redesigning our waiting area with infection prevention and control, we have meticulously crafted spaces that prioritize the safety and well-being of every individual. Our approach centers on a fundamental restructuring to ensure that every aspect of the waiting area serves a purpose in our IBC efforts. Key to this redesign is the strategic placement of seating with chairs anchored to the floor or wall and spaced to no less than 1.2 meters apart. And this arrangement isn't just about physical space, it is about a proactive measure to significantly reduce the risk of person-to-person transmission within these common areas. And at the heart of our redesigned waiting areas lies the respiratory waiting area, a space carved out with a singular purpose to serve patients presenting with respiratory symptoms. This area is not just a section of the waiting area, but a dedicated zone outfitted with portable HEPA filters that work 24/7 to clean the air of potentially viral particles. Importantly, this area is reserved exclusively for those with respiratory symptoms, ensuring they are segregated from other patients to minimize the cross-contamination risks. Complementing our spatial and environmental controls, hand sanitizing stations are strategically placed, ensuring everyone has the means to engage to one of them easily visible and easily accessible. As we transition to the next critical phase of our discussion, we delve into the dynamic realm of rapid assessment strategies for IBC within our emergency departments. And this stage is where our preparedness and agility are put to the test, requiring not just not knowledge only, but precision and speed in our response to potential infectious threats. And at the heart of our rapid assessment is the implementation of strong triage protocols. And these are our blueprints for actions designed to swiftly identify patients who may pose an infection risk. Through these protocols, we can ensure that patients with infectious diseases are promptly recognized, minimizing the time they spend in the general waiting area and reduce the risk of transmission. To aid our healthcare worker in this fast-paced environment, we have developed decision-making tools such as checklists and algorithms. And these tools are not just aids, they are critical resources that empower our staff to make a quick, informed decision regarding the care pathway for our patients, ensuring that those who require isolation are identified and managed without delay. The efficacy of rapid assessment is significantly bolstered by effective communication systems. Clear, direct lines of communication between triage personnel, ER staff, and isolation units are essential, ensuring that information flows swiftly and that suspected cases are managed with the urgency that they require. Understanding that readiness is not a static state, we commit to ongoing training and simulation for our staff. These exercises are invaluable not just in reinforcing protocol, but in ensuring that every member of our team is equipped to respond with confidence and competence when faced with the challenge of infectious diseases. And lastly, we recognize the importance of adaptability. By establishing a feedback loop, we engage in a continuous process of evaluation and improvement of our rapid assessment strategies. This approach allows us to refine our protocol, ensuring that they remain effective against the backdrop of evolving pathogen and emerging public health challenges. So now we will talk about the safe transport to isolation area. Our transport protocols are meticulously designed to ensure safety at every step. From the initial decision to isolate, we engage dedicated pathways through thoughtfully mapped out to minimize the contact with the general hospital population. And these pathways leads directly to isolation area strategically located near the entrance, further reducing the risk of exposure and making the transport process as efficient as possible. The role of barriers precautions cannot be understated. During this process, both the transport staff and the patients, they should don a mask and when necessary, additional protective gear to create a barrier against transmission. And this is a simple yet effective measures that significantly contribute to the safety of everyone involved. Dedicated transportation team trained specifically in these IBC measures are a critical component of this strategy, and their expertise ensures that potential patients are moved safely and efficiently, adhering to the highest standard of care and infection control. In our commitment to excellence in infection prevention and control, the isolation area within our emergency department stands as a beacon of safety and vigilance. And these special zones are not just designated spaces, they are the areas where our proactive measures starts towards the health and safety. Maintained through a rigorous and frequent cleaning and disinfection schedule. Our isolation area are always at the ready. And this isn't merely about reacting to potential contamination. It is about ensuring these critical spaces remains in a constant state for preparedness. And through this ongoing effort, we ensure that every individual who enters the isolation area, patients or a provider, is afforded with the highest level of protection against infection. So moving forward to adapting ER layout and facilities for IBC, the strategic redesign of the ER layout is more than an architectural endeavor. It is a critical IBC measure by creating clear pathway for patient flow and establishing segregated zone based on the risk assessment. We minimize the cross-contamination opportunities and enhance the overall safety. Ventilation is very important, as it maintain a safe environment, especially in the contaminant of airborne pathogens, and the implementation of advanced ventilation system ensure that we are not just circulating air, but actively purifying that air, significantly reducing the presence of airborne contaminant and safeguarding the health of everyone within the ER. Surface transmission and surfaces that are not only durable, but also easy to clean and disinfect. This choice is a testament to our commitment to minimizing the infection risks at every possible point of contact. Among the most significant adaptation are our isolation rooms equipped with the negative pressure technology. These specialized rooms are designed to care for patients with airborne infections, effectively preventing contaminated air from escaping into other areas of the ER. And this technology is important in our efforts to provide care while preventing the spread of highly infectious diseases. Sorry. So in the next slide, here we are talking about environmental cleaning and disinfection. And we already talked about it in short before, but to summarize it, regular cleaning and schedule, implementing of stringent regular cleaning schedule for all ER is very important to ensure that the area is free from contamination as much as possible. Use of approved disinfectants, training of cleaning staff to tackle down the challenges that they might face in the ER environments, such as emergency situations, blood spills, airborne diseases, etc. And monitoring and compliance, and lastly, patient and staff education, which is can be done by direct education by frontliner as physician and nurses. And also we play another role there where we do a lot of education personally or through our signs and TV and etc. So let's discuss here the respiratory visual triage checklists. And in this checklist, it is dedicated for respiratory illnesses, mainly the COVID-19 and MERS-CoV. And in this checklist, there are two parts. The first part is discussing the exposure risks, while the second part discuss the clinical sign and symptoms. For the exposure risks, it goes for adult and pediatrics, and if they have any of those four exposure types, they will be scored for 3 points. And the exposure risks include exposure to travel history abroad in the past 10 days, or a contact with a confirmed case of COVID-19 or MERS-CoV in the last 10 days before the onset of symptoms, or an exposure to camels or camel products either it is direct or indirect in the last 10 days before the onset of symptoms. And here it means that they have been exposed to camel directly or the camel products, which is indirectly. And the camel products, we have two types, either the meat or milk. So the meat, if you are exposed to a cooked camel meat, there is no exposure and there is no risk. However, if you was exposed to uncooked meat, then that's considered as risk. Also for the milk, if you are exposed to the milk before pasteurization, then it is a risk. Otherwise, if it is pasteurized, it is not a risk. And lastly, working in a healthcare facility is considered one of the things that score you for 3. Then we discuss the clinical signs and symptoms, and here they are talking about fever or recent history of fever. And here we are talking about subjective fever and documented fever. So if they have fever, either subjected or documented, which means he saw the fever or he felt the fever, and it was obvious on him, then he will be scored for 4, either for pediatric or adults. Then we talk about the cough, either it is a new cough or worsening cough. So if he is one of the patient who is regularly coughing because of COPD or asthma or smoking, for example, those patients will not be scored for 4 unless their cough is worsening. Then shortness of breath, same thing. It will be scored if it is a new or for chronic patients who have chronic shortness of breath, then it will be only counted if it is worsening. Headaches or throat, runny nose, it will be scored for 1. Nausea, vomiting, diarrhea, it will be scored for 1. Chronic renal failure or chronic heart failure or immunocompromised patient, they will be scored for 1 only for adults. And if the score is 4 or above, then the patient will be directed into the respiratory pathway. Otherwise, they will not. And since we did this, this checklist doesn't mean that the patient will be swabbed for COVID or MERS-CoV. It will only help us to segregate the patient in the entrance to not cause harm to other patients. So the decision of swapping the patient will be built on the suspected case definition. So the COVID-19 suspected case definition discussed that the patient with acute respiratory illness, such as sudden onset of at least one of the following: fever, cough or shortness of breath, with no need for exposure criteria. The second case definition discussed the patient with sudden onset of at least one of the following, and here they focus on secondary symptoms like headache, sore throat, runny nose, nausea, diarrhea, loss of smell or taste, and they must have an exposure criteria in the last 10 days. Third definition is when we have any admitted adult patient with unexplained severe acute respiratory infections, either community-acquired pneumonia or hospital-acquired pneumonia, and it is unexplained severe acute respiratory infection. They cannot know what's the reason. And in this scenario, they have to screen the patient for COVID. MERS-CoV is a little bit similar. For adults, all the definitions are applied, while for pediatric, only the last 2 definitions are applied. For adults, the first definition talks about severe pneumonia with severity score of 3 and above, or having adult acute respiratory distress syndrome based on a clinical or radiological evidence. So the severity score of 3 and above, it is based on 5 criteria, which is, they call it CURB 65. The C is for confusion. U is for urea nitrogen, which is in the urine. Urea, and it should be in the blood not more than 7 mmol, or I think 19 milligram per deciliter R for respiratory rate. If it is more than 35, it will be counted. B for blood pressure. If the diastolic is less than 60 or systolic is less than 90, then it will be counted. And if the patient is more than 65 in age, it will be counted. Then we have the second definition, which is unexplained deterioration of a chronic condition of patients with congestive heart failure or chronic kidney disease on hemodialysis. Those definitions are applicable only for adults. The next two definitions are applicable for both adults and pediatric. So the first one, and both of those definitions, they must be linked with an epidemiological link or exposure to MERS-CoV. So the first one of them, which is the third definition, is acute febrile illness of temperature of more than 38 or equal to 38 with or without respiratory symptoms, or a patient with gastrointestinal symptoms such as diarrhea or vomiting, and they are having a leukopenia, which means that the white blood cells is less or equal to 3.5, or thrombocytomenia, which means that the platelet is less than 150,000. The monkeypox case, suspected case definition, the suspected case definition says that the patient has unexplained rash, macular, papular, vesicular, pustular, it doesn't matter what is the rash, and one of or more of the following. So they must have at least one or more of the following in addition to having the unexplained rash. And they must have either high-grade fever, 38.2 or above, lymphadenopathy, intense headache, back pain, myalgia, or intense asthenia, which means fatigue or lack of energy. And the unexplained rash is defined as the rash for which of the following causes of acute rash do not explain the clinical picture, like drug eruptions or food allergy or varicella zoster, herpes zoster, measles, herpes simplex, bacterial skin infection, primary or secondary syphilis, or any other local relevant common cause of papular or vesicular rash. In addition, an unexplained rash include unexplained genital, anogenital, or orogenital. For example, ulcers, nodules, or bronchitis are included. Our last slide for this presentation is the Ebola suspected case definition. And it includes illness in person who has both consistent symptoms and risk factor as follow. So the clinical criteria, which include fever greater than 38.6 and additional symptoms such as severe headache, muscle pain, vomiting, diarrhea, abdominal pain, or unexplained hemorrhage from gingival, nasal, cutaneous, petechia, bruises, ecchymosis, gastrointestinal, rectal, gross or occult blood, urinary, gross or microscopic hematuria, vaginal or puncture sites bleeding. So he has bleeding from anywhere, either something we see or something we find in the lab results. And the patient must have epidemiological risk factor within 21 days before the onset of symptoms, such as contact with the blood or other body fluid of a patient known to have or suspected to have Ebola virus disease or Marburg disease, or they are residents in or travel to an area where those diseases transmission is active, or direct handling a dead or alive fruit bats, monkeys, chimpanzees, gorillas, forest antelope, or another animal that I cannot read their name from disease endemic areas. Lastly, malaria diagnostics should also be part of the initial testing because of it is common cause of febrile illness in persons with a travel history to the affected countries of Ebola. Now let's go to the Q&A session for this presentation. So our first question is, what is the minimum distance recommended between chairs in waiting area to ensure physical distancing in the ER? For respiratory waiting area. Excellent, well done. So the correct answer is 1.2 meters. The next question is, which of the following is not a primary component of IBC measures at the entry point of the ER? Which of the following is not a primary component of IBC measures at the entry point of the ER? Excellent. So the correct answer is providing literature on disease treatments. It is not a primary component in the early entry point of the ER. Next question, what type of room is essential for the care of patients with airborne infectious diseases to prevent the spread of pathogens to other areas? So what type of room is essential for care of patients who has airborne infectious diseases, and this room will prevent the spread of those airborne infectious particles to other areas? So am I going to use positive, standard, negative, anti-room? Of course, it should be negative pressure room. Excellent. Negative pressure room will prevent the spread of microorganism outside the room. So the correct answer is C. Question number 4, what is the purpose of having a respiratory waiting area in the ER? Obviously, it is B, to isolate patients with respiratory symptoms from others. Excellent. So our last question for today, not for today, sorry, for this presentation, which of the following is not a correct practice in the design of ER facility for IPC? Which of the following is not a correct practice in the design of ER facilities for the infection prevention and control? So all the answers is correct except one of them. So the incorrect answer is A. So using soft porous material is not correct practice in the ER because it will harbor microorganism and it will make cleaning and disinfection efforts impossible. So this is not correct. We shouldn't use porous and soft materials when we are designing our ER environments. For example, chairs, beds. I can't use fabric couch, for example, in the ER because it will just harbor the microorganism and it will not be easy for us to clean or disinfect. Unlike the other three, all the other three are things that are recommended for the ER design. Thank you, everyone. I believe we should take a break. We have still 4 presentations ahead. We can resume our presentation at, I think we can take 15 minutes or a little bit more. We can resume it at 11. So you can take a break, drink water. We will be fasting tomorrow, inshallah. So drink water and everything, and we will see you after 11, inshallah. It will be at 11, after more than 5 minutes. 11. Assalamu alaikum, everyone, and welcome back to our 5th presentation for today regarding the standard and transmitted based precautions. It will be a little bit long, but hopefully we will finish it quickly since we are discussing basics. So if you have any questions, Please feel free to ask any questions at any time. So in this session, we will be discussing the infection prevention and control measures with the focus on standard and transmission-based precautions to minimize the risk of healthcare-associated infections. And we will begin with the standard precaution, which are the foundation of infection control and apply to all patients regardless of their infection status. And this section will include the chain of infection, hand hygiene, personal protective equipment, cough etiquette, environmental cleaning and disinfection, biological spells, safe injection practices, aseptic technique, and device-associated infections. Next, we will cover the transmission-based precaution, which are used in addition to standard precautions when dealing with specific infectious agents, such as contact precaution, droplet precaution, and airborne precautions. And lastly, we will finish our session with a Q&A questions. So the chain of infection describes the process by which infection spreads from one host to another. Breaking this chain at any point is crucial in preventing disease transmission. There are 6 key links in the chain of infections, each playing a role in the spread of pathogens. So infectious agents, which are called germs, these include bacteria, viruses, and parasites that causes diseases. And to break the chain of infection, proper diagnosis, treatment, and antimicrobial stewardship should be implemented, which means, let's say you have a patient who came to the hospital to be with a COVID sign and symptoms. And let's say that the physician didn't identify that this patient is COVID. In this case, the patient will return back to his family, or even in the hospital, he might expose other patients. And all of that because of misidentifying of the case, which led to inappropriate treatment, maybe, and maybe led to also inappropriate isolation. So the patient wasn't isolated in a timely manner. And we can say that such incidents, we see it sometimes happening in hospitals where staff, healthcare worker might be misidentified from COVID sign and symptoms when they visit any near hospital near them, for example. And then they just take a sick leave and they come back to duty the day after while they are symptomatic or infectious with a respiratory illness, for example. So misidentifying or inappropriate treatment or diagnosis of the patient can lead to the continuous cycle of chain of infection and can lead to the spread of infection. Same thing goes with the antimicrobial stewardship. Not implementing antimicrobial stewardship appropriately can cause development of multi-drug resistant organisms, and those organisms might cause difficulty in treating them and might spread from a patient to another because of the difficulty of treating such patient or prolonged duration of being infected. In this cycle, we go next to the reservoir where germs lives, and germs thrive in people, animals, food, soil, and water. So they live there usually. So to break the chain of infection, we are talking about hand hygiene, we are talking about cleaning and disinfection, sterilization, pest control, eliminating that help eliminate or reduce reservoirs of infections. Then after that, we talk about portal of exits. So how germs gets out. So germs gets exit the body through the mouth, like from vomit or saliva or even respiration. Also, it can exit through a skin cuts or a skin lesion, such as if they have herpes or blisters on the skin. or they can exit through stool during diapering or toileting, etc. So the exit could be a lot of things. So how we can break the chain of infection in this point is by practicing hand hygiene, proper PPE, respiratory etiquette, proper waste disposal, etc. Then it goes to the next part where it is called mode of transmission. And we can say it how germs gets around, how the germ go from point A to point B. Usually germs spread through airplanes, and the airplanes could be direct contacts, hands, toys, surfaces, anything that uh, can spread the infection through direct contact or indirect contact through a surface or telephone or elevator buttons or anything. Also, it could spread through droplet or airborne status. And to stop or break the chain of infection in this point, we break it through also the same things, but this time it is done by the both parties, the one who is infected and the one who is not infected. So the germs gets around, we can stop them by hand hygiene, PPE, and control of aerosol or splatters, respiratory etiquette, waste disposal, air filtration, proper placement of patients, isolation, respiratory waiting area, etc. Then next, we talk about how germs gets in, and it is the portal of entry. So the germs enter the body through the mouth, broken skin, eyes, etc. And this can be prevented by using PPE, personal hygiene, wound care, removal of invasive devices such as catheters, tubes, etc. And we always emphasize on the importance of not touching your eyes or nose, not eating before you do hand hygiene, etc. Let's say in certain scenarios where germs did reach the body and it reached the next host. So the germs were living in an animal, in another human being who is infected with COVID. This person coughed and he wasn't taking any precautions. And the person next to him was just sitting next to him with no social distancing, and he wasn't wearing any PPE or any precautions. And they had like prolonged exposure of coughing going around next to him. And then that organism, let's say, entered the susceptible host. In this scenario, is the susceptible host going to be sick or not? That goes to different factors. First, there are certain individuals who are identified as people at risk, who have who their immune system is still premature or deficient, such as babies, children's, elderly, immunocompromised patient, or unvaccinated individuals. And for those, if I want to break the chain of infection, I have to act fast, and I can do it through immunization, which is the best way to prevent any infection, even better than hand hygiene. Also, it can be done by treating underlying diseases or health insurance or patient education. For example, let's say we have a patient who has herpes zoster or hepatitis B. Vaccination in those scenarios can actually prevent the disease from, it can prevent the disease from, sorry, it can prevent the organism from causing a disease to the susceptible host. Because if they are immune against hepatitis B, even if they are exposed to hepatitis B, they will not acquire that infection, except طبعا in certain scenarios where they are يعني their immune status, immune system is totally deficient. Also, treatment of underlying diseases such as people who have diabetes or who have a disease that might alter the immune system. In those conditions, a treatment of those underlying diseases can boost the immune system and can help protect the patient from acquiring such diseases. Health insurance, it helps everyone to protect themselves, go to the hospital, being checked, and etc. And patient education about what are the importance of hand hygiene, PPE, proper use of antibiotic, importance of removal of devices, respiratory etiquette, etc. All those education material and isolation precaution can help actually to break the chain of infection, because awareness is the key of a lot of things. So infection prevention and control in healthcare setting rely on two main type precautions. We have the standard precautions that is applied for all patients at all time, regardless of their infectious status. And we have the transmission-based precaution, which are additional measures, additional to the standard precaution, that is used for patients with known or suspected infections that require extra precautions to prevent contact, droplet, or airborne transmission. And throughout this session, we will explore both types precaution in detail. So let's move to the standard precaution. So as we said, infection prevention in healthcare setting is built on a foundation of standard precaution. So every single practice we conduct in our hospital setting, from a simple tasks to the OR tasks, the more complicated tasks, all of those practices are under the definition. It should go under the definition of standard precaution. So the standard precaution is a set of infection control measures that is applied to all patients, and it is applied at all times, regardless if they are infected or not. And those precautions are designed to protect healthcare workers, patients, and visitors, and the healthcare environment from the risk of infection transmission. We don't want to be a carrier. We don't want to be a reservoir. We don't want to be a susceptible host. And the standard precautions are based on the understanding that any patient, regardless of their symptoms, might be carrying an infectious agent. And this is why these practices must be consistently followed across all healthcare settings to reduce the risk of healthcare associated infections. And now let's explore the key components of standard precautions. So when we say standard precautions, it means a lot of different practices. The most important element of standard precaution is the hand hygiene, because it is the most effective way to prevent infection spread after, of course, immunization, but immunization is something different. And a proper hand hygiene should be performed after patient contact, after removing, after contact with patient surrounding, etc., as per the 5 moments. Then we have the second one is the use of personal protective equipment, such as gloves, masks, gown, eye protection, etc. When the exposure risk is anticipated, which means, for example, we wear eye goggles, we wear gloves in a phlebotomy, because there is an exposure to blood. Is this blood going to infect me? We don't know, but this gloves is essential to protect ourselves from an exposure of blood that might happen. It might not happen as well. Same thing when we go wear our eye goggles or face shield in a procedure that might cause aerosols or splatters to our eyes, etc. Which we will talk about it later on in details. Then we talk about respiratory hygiene and cough etiquette. Patient and staff should follow proper cough etiquette, such as covering their mouth and nose and using masks when necessary to reduce the respiratory pathogen. Appropriate patient placement. Patient with suspected or confirmed infectious infections should be placed in the designated rooms to prevent cross-contamination. Sterile instruments and devices, all reusable medical equipment should be properly cleaned, disinfected, or sterilized between uses to prevent pathogen transmission, and all those single medical devices should be disposed immediately. Cleaning and disinfection of environmental services and high-touch surfaces such as bed rails, door handles, medical equipment must be a routine and should be done by using a hospital-grade disinfectants. Proper disposal of waste, biomedical waste, sharps, and contaminated material should be disposed of safely to minimize exposure. And safe injection practices, the use of single-use needles and syringes, and adherence to proper aseptic technique to prevent bloodborne pathogen infections is really important. And lastly, of course, the aseptic technique, essential for invasive procedures, ensuring that the environment, equipment, and handling remain aseptic. So hand hygiene is the first and most effective line of defense against the spread of infection in healthcare settings. And healthcare-associated infections, or HAIs, remains a serious challenge, often resulting in a longer hospital stays, increased healthcare costs, and adverse patient outcome. The germs responsible for these infections come from two main sources. Either they are endogenous, which mean the germs already exist on the patient's skin, nose, or gastrointestinal tract, or it could be exogenous, which means that those germs came from external contamination, such as unsterilized medical device, contaminated surface, and most critically, the hand of healthcare worker. But how do these germs spread? Hands plays a crucial, central role in transmission. Without proper hand hygiene, harmful microorganisms can be picked up from one surface and transferred to another patient, medical device, or even a vulnerable body site. And this can occur when touching contaminated surfaces or equipment before interacting with another patient and during procedure that involve direct contact with mucosal, mucous membranes, wounds, or medical devices. After handling bodily fluid or contaminated material without performing a proper hand hygiene, so how do we break this chain of infection? We already discussed it before, and we can understand that breaking chain of infection is something that is easier than we think, and it can be something that should be done in our routine practices. Let's go back to where do germs come from? And we said like they could come from an endogenous source or they can come from an exogenous source. And here we have to stop. Because whenever we are assessing our patients, we sometimes know that our patients might acquire a disease from endogenous or exogenous source. Whenever it is exogenous, we can say that certain infection control practices were unfollowed appropriately because this organism came from outside. And those practices could be a hand of a healthcare worker that he didn't do hand hygiene, or for example, a contaminated instrument or equipment, etc. So we can understand that there is a breakdown in our IBC practices from from a member of the team. However, endogenous source, it is something that we should be worried about a little bit more because usually our patients sometimes they cannot care for themselves. Usually in certain scenarios where we have patients who are bedridden, we have our nursing staff, for example, or RT or physician, they are caring for that patient. And some of those patients might not be able to even go to the toilet, or for example, they might not be able to do certain tasks like feeding themselves. And in those scenarios, we can tell that sometimes when we see an organism that is known to be endogenous infection, endogenous source, we can see that this organism has transmitted from being, for example, MRSA in the axilla, from being a normal flora into being an infection in the blood. we can understand that sometimes a breakdown in the care of this patient happens. Giving you an example, if you don't brush your teeth on a daily basis, what will happen? Dental caries will develop and you will start losing your teeth because of dental caries. But if you are brushing your teeth every time and you are caring for your teeth, something like that will not expected to be happening. Same thing with the patient. If, for example, the nursing is not doing a proper suctioning for the patient, or for example, if she is not appropriately doing hand hygiene after before aseptic procedure. For example, she was changing the diaper for the patient, and after that she decided to feed the patient, or for example, she decided to insert a cannula for the patient. Those certain practices after having a contaminated hand should be followed with the hand hygiene before they start with the next task. And this is the importance of understanding whenever you have a patient with an endogenous source of infection, it is advisable that you focus your investigation of that case to understand what failed in that circle to take appropriate action when you are doing an education or a tracing for that incident. So hand hygiene is not just a responsibility for healthcare worker, it is a universal practice that is applied for everyone, regardless of their profession or work setting. While healthcare providers are the forefront or the frontliner in infection prevention, the importance of a cleaning hand extends beyond the hospital and the hospital staff. We can tell that even visitors, the patients, the engineers, the students, educators, everyone in the hospitals, they should comply and understand the importance of the 5 moments, hand hygiene, etc. The technique of hand hygiene, etc. So hand hygiene is the act of cleaning hands to remove dirt, soil, and harmful microorganisms, reducing the risk of infection transmission. It is one of the most fundamental and effective measures in infection prevention, ensuring that healthcare workers, patients, and general public minimize the spread of pathogens. Hand hygiene is a broad term that includes different methods of hand cleaning, which include, for example, hand washing using soap and water to remove visible dirt and organic material, antiseptic hand washing, which means hand wash with antimicrobial soap for added protection against pathogens, antiseptic hand rubbing, applying alcohol-based hand rub or alcohol sanitizer, which is the preferred method in most clinical settings and most clinical scenarios, except when hands are visibly soiled and except when you are dealing with a C. diff patient. Surgical hand antisepsis, also it could be a surgical hand scrubbing or a surgical hand rubbing. So the WHO, the World Health Organization, has defined what are the my 5 moments for hand hygiene. And it provides a structured and evidence-based approach to ensure that hand hygiene is performed at the critical points during patient care. And this concept promotes a unified global vision, helping healthcare worker trainers and observers reducing the variation in practice and increase the compliance with effective hand hygiene measures. The 5 key moments of for hand hygiene are before patient contact, before aseptic procedure, before blood and body fluid after blood and body fluid exposure, after patient contact, and after contact with the patient's surrounding. So alcohol hand dropping is quick and effective, and it is about using an alcohol-based hand sanitizer to kill the germs on your hands. It's fast, typically takes 20 to 30 seconds, and you can do it almost anywhere. While hand washing with soap and water is a bit different, and this traditional method is just as effective, especially when our hands are visibly dirty, and it involves a few more steps than hand hair rubbing, like rinsing, drying, and generally takes more time because of that, and it takes around 40 to 60 seconds to do it right. And the steps we use for rubbing all our hands with sanitizer and washing them with soap are pretty much the same. It is the technique that matters. However, because of the extra steps like rinsing, drying, hand washing takes a little bit longer, as we said. Both methods are important, and it is crucial to know the right way to do them. And that's why I will be showing you two videos that demonstrate the correct technique for hand washing and hand rubbing. And this will guide you on how to do it properly, ensuring you are as effective as possible in keeping those germs away. So let's keep our hands clean and our patients safe. Enjoy the videos. We will start with the hand rubbing video. Then we will go to the hand washing video. So to ensure that the time is covered during hand rub or hand wash, it is advisable that you do each step 5 times and make sure that each step is done appropriately with appropriate friction to ensure that those organisms has been deactivated or washed off from your hands. We have a question that is asking how many presentation left. We will finish at inshallah 3. We still have this presentation and 3 other presentation to finish our session today. So we know that gloves are an essential part of PPE, but they do not replace hand hygiene. Many healthcare workers assume that wearing gloves eliminates the need for hand washing or hand rubbing, but this is a dangerous misconception. Why aren't gloves enough? The gloves can become contaminated just like hands, picking up pathogens from patients, equipment, surfaces, and improper glove use can spread infection, especially if healthcare workers touch multiple surfaces or fail to change gloves between tasks. Gloves may have microscopic tears or defects, allowing pathogens to pass through the skin unnoticed. And hand hygiene remains essential before wearing the gloves. Hand hygiene ensure gloves are applied to clean hands, and after removing gloves, hand hygiene prevent any contaminant or contamination that might have occurred while removing them, and the gloves should be used as an additional protective barrier, not as a replacement for a proper hand hygiene. The combination of correct gloves use and strict hand hygiene compliance is what truly reduces the risk of infection transmission. While proper hand hygiene is essential for infection prevention, there are certain practices that should be avoided to ensure effectiveness and prevent skin irritation and compromised protection. So avoid using soap and water and alcohol-based products simultaneously, as these products are designed to work separately, and using them together can cause skin irritation without additional benefits. If hands are visibly soiled, just wash your hands with soap and water. If they are, or if they have, you have been in contact with a spore-forming organism, and if your hands are not visibly soiled, or you are not in contact with spore-forming organisms, not spore-forming organism, with enteric organisms, then use alcohol-based hand rub for routine disinfection. Also, avoid using hot water for hand washing, as hot water can strip the skin natural protective barrier, leading to dryness, irritation, and even small cracks that increases the risk of contamination. Instead, use warm water to clean hand effectively while preserving skin integrity. And lastly, avoid donning gloves when hands are wet. Wearing the gloves over wet hands can cause skin irritation, increase bacterial growth, and make it harder to put on gloves properly. Always ensure hands are completely dry before wearing gloves to maintain proper protection and comfort. To ensure effective infection prevention and control, there are key hand hygiene reminders that all healthcare workers must follow. Artificial nail, gel nail, or extender should not be worn by staff who are in direct contact with the patient. Those can harbor bacteria and increase the risk of cross-contamination. Do not touch contaminated surfaces after performing hand hygiene, because hand hygiene is only effective if hands remains clean. Touching soiled equipment, doors, handles, or patient surrounding immediately after hand hygiene defeats the purpose of decontamination. Also, avoid touching your face, especially your eyes and nose, as those mucosal membranes of the eyes and nose and mouth are direct entry point for pathogens. Unconscious face touching is a common habit, but it can significantly increase infection risk. Keep nails short, less than a quarter inch. Short nail reduce the likelihood of trapped bacteria and debris, which can persist even after hand washing. And hand and wrist jewelry should be not worn in clinical settings, like rings, bracelets, watches, which trap the bacteria and prevent thorough hand hygiene. Nail polish, we don't recommend it. However, there are two types of nail polish. There are something called the chipped nail polish and unchipped nail polish. The chipped nail polish, it means that the nail polish can be broken easily, and this type of nail polish is completely not recommended. The unchipped nail polish, you might use it for 1 or 2 days, but after that it has to be removed, as it can harbor microorganisms easily, but the risk is less. So personal protective equipment, or PPE, is essential in infection prevention and control, and it serves as a barrier between healthcare worker and potentially infectious agents, reducing the risk of cross-contamination and occupational exposure. The key component of PPE includes masks, such as surgical mask, N95 buffer, which we will discuss in much detail later on. Also, eye protections, goggles, gloves, gowns, coverall, etc. All of those PPE can help in the elimination of transmission of infections. In this slide, I will show you a video. In this slide, I will show you a video for a proper donning and doffing sequence for PPE. I hope you enjoy it. Please, in this video, just be sure that you focus on the sequence. Also, you please focus on the technique on the safe donning and the safe doffing of PPE as it will be explained.
CDC sequence for donning personal protective equipment, PPE. Gown. Fully cover torso from neck to knees, arms to end of wrist, and wrap around the back. Fasten in back of neck and waist. Mask or respirator. Secure tie or elastic bands at middle of head and neck. Fit flexible band to nose bridge. Fit snug to face and below chin. Fit check respirator. First, goggles or face shield. Place over face and eye and adjust to fit. Gloves. Extend to cover wrist of isolation gown. Use safe work practices to protect yourself and limit the spread of contamination. Keep hands away from face. Limit surfaces touched. Change cloths when torn or heavily contaminated. Perform hand hygiene. CDC sequence for removing personal protective equipment, PPE. Gloves. Outside of gloves is contaminated. Grasp outside of glove with opposite hand. Peel off. Hold removed glove in gloved hand. Slide fingers of ungloved hand under remaining glove at wrist. Peel glove off over first glove. Discard gloves in waste container. Goggles or face shield. Outside of goggles or face shield is contaminated. To remove, handle by headband or earpieces. Place in designated receptacle for reprocessing or in waste container. Gown. Gown front and sleeves are contaminated. Unfasten ties. Pull away from neck and shoulders, touching inside of gown only. Turn gown inside out. Fold or roll into a bundle and discard. Mask or respirator. Front of mask or respirator is contaminated. Grasp box, then top ties or elastics and remove it. Discard in waste container. Perform hand hygiene immediately after removing all PPE.
So, respiratory hygiene or cough etiquette is a simple yet critical measure and preventing the spread of respiratory infections. Coughing and sneezing release droplets that can carry infectious pathogens such as influenza, COVID-19, and tuberculosis into the air and onto surfaces. And to reduce the transmission, always cover your mouth and nose with a tissue when coughing or sneezing. This prevents the droplet from becoming airborne or contaminating the surfaces. If no tissue is available, use your upper sleeve, not your hand. Hands frequently touch doorknobs, medical equipment, and other high-touch surfaces, increasing the risk of cross-contamination. Dispose of used tissues immediately in a waste bin, and tissues are single-use item and should never be kept in your pockets or reused. Wash your hands with soap and water after coughing or sneezing, and the hand hygiene removes any residual germs to prevent further transmission. If soap and water are not available, use alcohol-based hand rub. This is not the last presentation. After this presentation, we have 3 other presentations. And we have another question is, what is the reason for this sequence of donning? I mean, what happens if I start with the mask first, for example? The idea of the sequence, 2 things, is to make sure that you minimize the contamination of those certain PPE, and you keep the PPE that comes in contact with the patient directly at last to wear, which means that I will have the gloves at last to don. And whenever we are taking off our PPE, we try to take off the PPE that has the highest contamination first to avoid contaminating our hands further. And later on, we can do hand hygiene in between the steps if we feel there is a risk of exposure to ensure that our hands are free of contaminants. So next, here we say, who holds the responsibility for environmental cleaning and disinfection within our hospitals? And the answer might surprise some. It is not about just the dedicated housekeepers or diligent nurse staff. It extends to every individual who steps through our doors. Considering that doctors meticulously disinfect their stethoscope or proper mask if they used it. Nurses ensure their medical equipment is free of contaminants. Respiratory therapists clean their ventilators. Radiologists clean their machines when they are using, for example, portable X-ray or ultrasound machine, etc. So the end user or the user of that device or machines, they are responsible to clean and disinfect that machines immediately after use. And this collective efforts underscore a critical value in our fighting against nosocomial infections. And the realization that the responsibility of cleaning and disinfection falls on us all. It is a shared duty that spans across various roles and departments, each contributing to a safer, cleaner hospital environment. So here we discuss the high-touch surfaces that are with a green, light lime color or light green color that are known to be frequently touched when we are caring for the patient. And those high touch surfaces, we should give them an extra attention when we are cleaning the patient's room. And it should be focused and it should be in a checklist to ensure that each one of those surfaces has been thoroughly cleaned during our routine cleaning and disinfection. And it includes a lot of items from bed rails, IV pole, telephone, chairs, room sink, doorknobs, switches, etc., as well as the high touch surfaces in the medical equipment, such as the IV pump control panel, the monitor control panel, the ventilator control panel, etc. So infection prevention relies heavily on effective chemical disinfection, but not all disinfectants are suitable for medical environments. To ensure safety and efficacy and regulatory compliance, only approved disinfectants should be used. This means using products that have been approved by the Ministry of Health or the Environmental Protection Agency, APA, ensuring that in the US, ensuring they meet strict standards for healthcare settings. Beyond selecting an approved disinfectant, it is equally important to follow the manufacturer guidelines for dilution, ensuring that the correct concentration is used to achieve the effective microbial kill without being too strong or too weak. Also, dispensing and shelf life, some disinfectants degrade over time, so using them beyond their recommended shelf life can reduce the effectiveness. Also, contact time, every disinfectant requires a specific amount of time to effectively kill pathogens. Wiping a surface too soon can leave behind viable microorganisms, increasing the infection risks. Additionally, not all disinfectants are safe for all medical equipment. It's crucial to check the compatibility with manufacturer recommendation to prevent damage to sensitive equipment such as endoscopes or imaging devices, and ensure that the equipment warranty remains valid, as using unauthorized disinfectant or incompatible disinfectants could damage or void the manufacturer support. Next, we will be discussing the biological spills. And here we are dealing with two types of biological spills based on the size of the biological spills. So we know that biological spills can pose a significant infection risk, requiring an immediate and appropriate response to minimize the exposure and contamination. And approach to manage the spills depending on its size, as the cleanup process differs between the small and large spills. For small biological spills defined as those up to 10 centimeter in diameter, the following steps should be taken. First, select the appropriate PPE, such as gloves and, if necessary, mask or gown to minimize the direct exposure, and to immediately wipe up the spill using an absorbent material such as a paper towel or to prevent it from spreading. The area should then be cleaned with warm water and detergent, followed by a thorough rinsing and drying to remove any residual contaminant. And all contaminated absorbent material should be placed in a container or a plastic bag for proper disposal, ensuring safe handling. And lastly, we should start with the hospital-grade disinfectant that should be applied to the cleaned area to ensure complete decontamination. Once the process is complete, you can remove your PPE safely and do hand hygiene. But when we are dealing with a large biological spill, which are greater than 10 centimeter in diameter, the scenario is a little bit different. So the first step, you have to restrict the access to the spill area to minimize the exposure to staff and patients. Also, it will help prevent unintentional contamination of shoes, clothing, or equipment. Next, proper PPE should be worn, including gloves, gown, and mask, and eye protection if necessary. And this ensures that direct contact with potential infectious is avoided. Once PPE is in place, the spill should be contained during using absorbent material from the spill kits. And those material will soak up the liquid and prevent further spread. And after the spill is contained, a hospital-grade disinfectant should be prepared For blood spills, we can use chlorine tablet. For other spills, we can use alcohol wipes. Not other spills, for example. Sorry, for blood and other body fluid, we can use chlorine. And for urine and vomit, because they can interact with the chlorine, we can use alcohol. So we can prepare our disinfectant, and once the absorbent material is done, we can just scoop them out. Then we can clean, and then we can disinfect with our disinfectant of choice, following the recommended dilution and the contact time for that spill. Usually for chlorine, we should achieve 10,000 ppm, depending طبعا we have different materials, we have different companies, and the idea is to achieve 10,000 ppm when we are cleaning the spill, which is the highest concentration for chlorine. Once everything is cleaned, dispose everything into the biohazard waste bag, the yellow one. And later on, after you finish, remove your PPE and do hand hygiene to prevent cross-contamination. So the responsibility to clean biological spills, in our opinion, all healthcare workers are responsible to not to clean, but during biological spills. They at least have to control, contain, contact, and supervise. So they have to control the area, not to allow anyone to step in. They have to contain the spill, either with the granules if it is available or nearby. If it is difficult to reach the granules, we can at least contain it with a paper towel, not to prevent it from spreading farther from its location. And also we have to contact the one who is responsible for cleaning. We recommend always the housekeeping to do that, as they are properly trained to clean spills. And then we can supervise to ensure that a safe environment, a safe technique has been done, and no one is stepping while the cleaning is conducted, stepping in. Ensuring safe injection practices is critical in preventing healthcare-associated infections and protecting both patients and healthcare workers. Injections should be performed under a strict aseptic condition to prevent contamination and transmission of blood-borne pathogens such as hepatitis B, C, or HIV. Medication vials and injection equipment must remain sterile. Always use a new sterile syringe and needle for each injection. Before access a vial, disinfect the rubber stopper using an approved antiseptic. Use single-dose vial whenever possible. Single-use vials are meant for one patient and one procedure only. While multi-dose vial should be kept in a designated area away from the patient care area when it is accessed. Needle handling and disposal. In this section, we will say needles should never be recapped, bent, or broken after use. If recapping is necessary, use the one-handed scoop technique that should be used to minimize the risk. Hand-to-hand passing of sharps should be avoided. Instead, place them directly into a puncture-resistant sharp container. Safe disposal of sharp, it should always be done immediately, and it should be disposed in a secured sharp container, which means it should be wall mounted or secured to something that it will prevent it from falling. Never reach inside the sharp container, as it poses risk of needle stick injury, and do not try to shake the sharp container or make it overfilled. This is a quick video showing the one-handed scoop technique, how it is done.
The one-hand scoop technique. To avoid an accidental needle stick injury, never recap a needle using both hands. If the needle has to be recapped, use the one-hand scoop technique.
Excellent. So exposure to blood-borne pathogens, if needle stick happens, is a significant concern in healthcare settings due to the risk of infection from microorganisms present in the human blood. Blood-borne pathogens are microorganisms such as viruses, bacteria, and they are carried in the blood and can cause diseases in humans. Some of the most well-known blood-borne pathogens include HIV, hepatitis B and C, which poses serious health risks for individuals exposed to infected blood. The Occupational Safety and Health Administration, OSHA, expands the definition of risk beyond just the blood to include certain other body fluids, which are classified as OPIM, which is for other potentially infectious material. And this broader definition is critical for understanding the full spectrum of exposure risks in healthcare and laboratory settings. So human body fluids that are considered OPIM in the, and can transmit HIV, hepatitis B or C include semen, vaginal secretion, cerebrospinal fluid, synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, amniotic fluid, and other body fluids such as body fluids that are visibly contaminated with the blood, such as, for example, common example is saliva in dental procedure that are contaminated with the blood. It will be falling under OPIM, other potentially infectious materials. So HIV or hepatitis B virus cultures are associated with tested mediums. We have human body fluids and we have other materials that also falls under the other potentially infectious materials. And those materials include HIV or hepatitis B virus cultures and associated testing medium, unfixed tissues and organs before it is fixed, and pathological and histological specimen. So all of those are considered other potentially infectious material, and they should be treated as we are having an exposure to blood. If a needle stick or exposure to eyes or open wound is happened. So the mode of transmission of blood-borne pathogens, and we just said that OSHA described the blood-borne pathogens in a broader term just in the previous slide. So understanding the mode of transmission of this is essential to implement effective infection control measure and protecting healthcare workers and patients from potential exposure. One of the primary mode of transmission is through puncture, wound, or cuts. Injuries caused by needle, scalpel, or other sharp objects can pierce the skin and creating a direct route for pathogen to enter the bloodstream. And these sharps are particularly concerning because they can introduce infectious agents immediately into the body. Another significant mode of transmission is contact with the blood or other potentially infectious material, and this can occur in several ways. Mucous membrane exposure to blood or OPIM that we just discussed can occur through the mucous membrane of the eyes, nose, or mouth, and this typically happens or in intact skin through splashes or spray incident during medical procedure or when handling contaminated fluid. Such exposure can allow the pathogen to enter the body directly through these sensitive membranes. And of course, the non-intact skin, which can be a cut, abrasion, burns, acne, rashes, or hangnail, etc. Lastly, contaminated sharps are another common mode of transmission, which include needles, blades, and other medical instruments. Exposure to blood or body fluid poses a significant risk, especially for HIV, hepatitis B, and C. And if such incident occur, you have to remember four things. First aid, then they have to notify their supervisor, then immediately seek medical treatment, and lastly, report the incident to the employee at the clinic by filling the needed form. So first aid for needle stick is by washing the injured area with running water and soap for at least 1 to 2 minutes. and they have to bandage it if it is still bleeding. It is not recommended to squeeze or use alcohol because both practices increase the blood circulation, which increases the chances of such diseases, which are HIV, hepatitis B or C, to escape the injured area and go to their natural habitats where they can hide and multiply. Flush splashes to the nose, and that's it. For the first aid for splashes of nose, mouth, skin, or intact skin, then in this scenario, we have to flush it, and we have to keep flushing it for at least 10 minutes, preferably with a sterile water, if not possible saline, if not possible at least any type of water. Then we have to notify the injured person. He has to notify the supervisor because they have to immediately seek for medical treatment and they cannot leave their working area. So their supervisor responsibility is to find a replacement or someone to cover their absence till they seek the medical treatment immediately. So when they seek medical treatment, usually in all hospitals during working hours, they can approach the employee health clinic. But after working hours or in holidays, they can simply go to the ER where they can be managed in the same hospital because they have to be tested with testing the source. And lastly, they have to submit an incident report to the employee at the clinic describing the used either needle stick sharp injury object form or the mucocutaneous exposure reporting form or other type of forms that the hospital, your hospital use. No, I think we will not finish now. We have a presentation, this presentation, and after this presentation, we have 3 others. I think we will finish at 3. Aseptic technique is a fundamental set of practices designed to render and maintain objects and areas as free from microorganisms as possible. And we have 2 types of aseptic technique, clean aseptic technique or sterile technique. The clean technique is called medical asepsis, while the sterile technique called surgical asepsis. Clean technique is used for simple procedures such as phlebotomy, closed suctioning, etc. While sterile technique is used for sterile procedures such as open suctioning or central line insertion or OR procedures. And the key elements for all of that is just to ensure you are doing proper hand hygiene. You have to create your sterile field. You have to use no-touch technique. Avoid touching as much as possible with your hands because it is the most common vehicle for transmission of infections, microorganisms. Preparation, make sure that you properly prepare your patients, yourself, and equipment. For example, in central line, you will wear appropriate sterile attire. Your patient, you will cover it with a sterile large drape that will cover the whole patient body. And for equipment, you will use the ultrasound, so guided central line insertion. So the ultrasound has to be properly disinfected and covered with a sterile cover. You can cover the probe with a sterile cover. Even when you do all of this, sometimes your technique is the problem. So safe technique is really important. And when we talk about here, I can give you an example. Let's say, for example, you are wearing your sterile gloves, but while you are wearing your sterile gloves, your hands are loose. You are not keeping your hands in front of your eyes and in the sterile field, which is above the umbilicus and below the nipples, تقريبا almost. This area is considered as a sterile field. Some people sometimes they just make their hand loose or put it in their armpit, thinking that this area is considered safe, but it is not safe. Also, giving your back to the sterile field is not allowed because your back is not considered sterile, etc. So safe technique is really important. So we will go to, we finished the isolation precaution, alhamdulillah. Now we will go to the isolation precaution. And the definition of isolation precaution are infection control measures that are designed to prevent the spread of pathogens within the healthcare settings, and those precautions are tailored based on the transmission routes of those infectious agents such as contact, droplet, and airborne. And the importance of isolation precautions is known. We will just skip it for the sake of time. So historical background and evolution of isolation precautions. The concept of isolation to prevent the spread of infectious diseases has a long and varied history in medieval times. Quarantine was one of the earliest forms of isolation practiced to control outbreak of the plague. This involved isolating ships and people for 40 days, a practice derived from the Italian terms quaranta, meaning 40 days. Interestingly, the concept of quarantine also has root in Islamic teaching. The Prophet Muhammad, peace be upon him, sallallahu alaihi wasallam, advised if you hear of an outbreak of plague in a land, do not enter it. But if the plague breaks out in a place while you are in it, do not leave that place. In Arabic, it says إذا سمعتم بالطاعون بأرض فلا تدخلوها وإذا وقع بأرض وأنتم بها فلا تخرجوا منها. And this hadith highlights the importance of contaminants and preventing the spread of disease, principles that are echoed in modern isolation practices. During the 17th and 18th centuries, isolation hospitals, also known as pest houses, were established to contain those with contagious diseases, reducing the risk of spread infections in the general population. Even in our era, when COVID-19 happened, for example, in Saudi Arabia, in Riyadh, the Ministry of Health has identified certain hospitals to accommodate such patients, such as in Riyadh, Prince Mohammed bin Abdulaziz was the hospital that can accommodate COVID patients. And when the number increased, the Ministry of Health had like quarantine areas for such patients. And in each hospitals, we build our areas to quarantine those COVID-19 patients away from other patients in the hospital. So the goals of isolation precaution is simple: preventing the spread of infectious agents, protecting vulnerable population, ensuring safety of healthcare worker, and enhance the overall public health. In our discussion on transmission-based precaution, we identify 3 specific types, which each aligned with a color code for national standardization and clarity. Starting with the contact isolation shown in green, think of it as 2 layers of defense. Direct contact is like a handshake where germs transfer from a person to a person, or the indirect contact is more like a sneaky one that where germs ride on objects like a patient bedrails or a doctor's stethoscope waiting to be picked up by the next person. Our gloves and gown are our shield in this scenario, stopping the germs in the tracks and ensuring that neither a direct handshake or indirect shared surfaces become a germ expressway. On the droplet isolation, highlighted in red, here we are not just blocking germs, we are creating a no-fly zone for them. When someone coughs or sneezes, those droplets loaded with germs shouldn't go farther than a few feet. This is why we keep a safe distance, ideally around 3 to 6 feet, which is a part of our plan, along with masks, and the mask act as a germ catcher, ensuring those droplets don't find a new home. Transitioning to the airborne isolation, which is marked by the color blue, we address those incredibly small germs, specifically those equal to or smaller than 5 micrometers in diameters. And those are not just any germs, they are the kind that can float in the air for hours, and they can be suspended in the air for hours, making them particularly challenging to contain. So our strategy here is easy. We equip ourselves with a fit-tested N95 mask. If the fit-tested is not available, at least we have to wear our proper mask, or if we are not eligible to wear a N95 mask, we wear our proper mask. which are specifically engineered to filter out those tiny particles, ensuring that they do not find their way into our respiratory system. Additionally, healthcare staff have the option to wear the popper, as we said, which is an alternative method of protection. And this dual option approach ensure that whether through N95 or popper, they are adequately shielded against microorganisms. So contact precaution used for patient known or suspected to be infected or colonized with epidemiologically important microorganisms such as enteric pathogens, MRSA, VRE, ESBL, DRO that can be transmitted by direct contact of the patient or indirect contact. All right, and here, let's take it step by step. So before we enter a patient's room, we start with a number one rule, hand hygiene. Sanitizing our hand might be simple, but it is super powerful. We rub every nook and cranny, front and back. We wash all those germs away. And this isn't just a quick rinse, it is a thorough and important process. Then we move on to our gown, the protective suit. We slip it on, tie it up, and make sure it covers us. This isn't just any gown. This is the barrier that keeps our clothing from picking up germs that could spread around the hospital. Next, we put our gloves and we pull them over our hands, making sure that we don't touch anything else after that. Those gloves are like a second skin that keeps our hands clean while we are with this patient, and we are carefully to touch only what we need to, avoiding unnecessary contact that might contaminate our gloves when we are caring for our patients. And now, when it is time to leave the room, we have we have a routine to keep those germs from coming out with us. So the gloves comes out first. They have done their job, and we don't need them anymore. We toss them in the trash and sanitize our hands again, because we can never be too clean when it comes to fighting germs. After our hands are clean, we carefully take off the gown. We are carefully not to touch the outside of it, because that's where the germs are. We fold it up to sit away, and yes, you guessed it right. We sanitize our hands one more time. This is how we make sure that we are not carrying any germs with us to the next patient or anywhere else in the hospital. And why do we do that? Because germs like Candida auris or those pesky ones that don't listen to antibiotic, which are DROs, can spread so easily. And also, to stop those itchy little bugs called lice, can jump from one head to another. So the mechanism of contact spread, we just said it. We have the direct and the indirect contact. And there is a rule of formats. Surfaces and objects can harbor microorganism for various duration, making them a critical factor for indirect spread. And for infection control measures, we have said what we have to do. In contact precaution, we have something called enteric contact precaution. The enteric contact precaution is a branch of contact precaution, which is crucial in the infection prevention strategy for controlling the spread of highly contagious enteric pathogens. Those bacteria normally residents in the human guts, but can cause severe infection when introduced into the digestive tract through contaminated hands, surfaces, or equipment. Examples are many, but we focus on C. diff, norovirus, and rotavirus. And those pathogens usually often lead to gastroenteritis, which can lead to life-threatening, especially in vulnerable populations. To minimize the transmission, there are certain things we have to change. Before touching the patient, before entering the room, nothing to be changed. But when we are exiting the patient's room, we cannot use the alcohol hand rub. Unfortunately, we have to use the water and soap, because the alcohol hand rub is not uh, effective as it should be when dealing with such organisms. So the easiest way to get rid of them is just by washing their off your hands when you are doing when you are washing your hands with water and soap. Another thing is ensuring that the cleaning of the room is done by proper disinfectant. And we have a lot in the markets. You can ask for the disinfectant that are effective against such organisms, and you have many options in the market to do so. So whenever we have a C. diff, we have to make sure that alcohol hand drop is not effective against them, and the only way to fight them is through this water and soap to wash them off your hands. The contact isolation, we place our patient in a private room, or we can cohort them together in the same cohort patient together if they have the same infections, which mean they are not suspected, they are confirmed, and they have the same type of infection. For MDRO, they have the same time, for example, of resistant pattern. For not MDRO, for example, they have the same time of infection. So, for example, we isolate the lice with lice patients if we have to. Not suspected, but they have to be confirmed. Signage, we put the green signage outside the room, and we use it also for transportation if needed. Contact isolation in special settings such as an OR. We try to delay the patient to the end of the list if possible. If not, we adhere to the patient transfer protocol, and we direct room entry. Patient under contact precaution should be directly admitted to the OR, bypassing common waiting area or pre-operative preparation area to avoid potential contamination. Terminal cleaning, it should be done appropriately based on the type of microorganisms. And pre-procedure preparation, ensure all necessary equipment and material are available in the procedure room to limit the movement of the staff in and out the room during the OR procedure. Visitors and families, they have to be educated by the frontliners about the hand hygiene, the contact isolation, the use of PPE, etc. Standard precaution as well. Duration of isolation for example, C. diff. The isolation for C. diff, it should continue for at least 48 hours after the resolution of diarrhea. So the patient should stop having diarrhea for at least 48 hours. Then you can discontinue the isolation for C. diff. This is as an example. Droplet precaution, it is used for patient known or suspected to be infected with microorganism transmitted by droplets, which are larger than 5 microns in size, and they can be generated by patient during coughing, sneezing, or even talking or breathing. And if the patient is having any aerosol generating procedure, in this case, the droplet precaution will be discontinued, and it will be replaced by an airborne isolation, which we will discuss later on after that. So let's gear up and take a look for the droplet isolation. Before we walk into the patient's room, we start with the all-important step, as we said before, hand hygiene. It's the first line of defense. Next, we equip our trusty sidekick, the medical surgical mask. We put it on to shield ourselves from those sneaky droplets that escape when someone talk, cough, or sneeze. Think of it like putting on your invisible armor that keeps those tiny droplet germs from getting anywhere close to us. Now, when it's time to say goodbye to the patient, we don't just walk out, we carefully take off our mask, ensuring a safe distance of 3 to 6 feet away from the patient, disposing our mask safely in the patient's room, and making sure to leave all the germs behind. We don't want to take them as a souvenir with us, especially when we are working with other patients. And what's the last thing we do before we step out? We got it. You got it, of course. We have to sanitize our hands. It is not just a habit, it is a critical step when we are dealing with our patients. So the mechanism of spread of droplets is almost similar. This is a very good question. For those who work in the flu clinic, should they change their gown after each patient? The clinic exposure is a little bit less than when we are talking about caring for a patient in the admission area. Honestly, I'm not sure how to answer this appropriately, but scientifically, we can say that when you are caring for patients who are confirmed, PPE doesn't is not a problem when we are talking about clinic. Of course, we have to remove it and change it, but that is not a problem. But when we are talking about suspected patient, this is a big problem because we don't want to spread that specific infection to others. So let's put it this way. If this gown, let's say, for example, would be in contact with the patient, I would prefer, if they are wearing, if you are talking about gown, I would prefer to change it. Okay. But if it will not come into contact with the patient, for example, the physician will sit in his office and the patient will be far away from him and they will just talk with the patient and there will be no contact with the patient. In this scenario, there is no high risk for that. And they might keep the gown, but generally speaking, they have to change everything between patients because we do hand hygiene between patients as well as we do change our PPE between patients because here we are not talking about only that type of infection. Patients tend to be colonized with a lot of microorganisms, not only the microorganisms that they are infected with, they might be colonized with other microorganisms that are significantly important. And we don't want those microorganisms to spread from a person to another when we are caring for them. Yeah, we can say that based on the degree of exposure. It is a little bit tough. It is a little bit tough because usually flu clinics are a little bit busy compared to others. So let's say it's based on the exposure, but yeah, we encourage changing the PPE. Yeah, it's very important. It depends on how the workflow is done. You can sit with them, for example, in your hospital. You can observe them for half an hour, and then you can decide if there is a risk or not, and you can implement whatever your recommendation you see that fits perfectly to improve the patient safety and staff safety. Yeah, they have to. Vital signs means they are in contact with the patient. They have to disinfect the dynamap between patients, and of course, they have to change their PPE if they are in contact with the patients. So moving forward, mechanism of a droplet spread. Um, it is similar to the contact. There are direct contact where you are welcome, and there is indirect contact. The direct contact is when you are contacting the patient who is coughing or sneezing or talking directly. And there is the indirect contact with the droplet spread is when the droplet lands on a surface or objects and you just pick it up with your hands and then you touch your face or mouth or nose or eyes, etc. Infection control measures, we just said it, use of mask, social distancing, hand hygiene, surface disinfectant, etc. All of those can stop the spread of infection. The patient can be placed in a private room, which is preferred. If cohorting is necessary, they have to be cohorted with other patients with a confirmed disease. You cannot cohort suspected patients altogether. And the signage is the red one for droplet isolation. In OR, it is similar. It's very similar to the contact isolation, and nothing more will happen, except maybe if the patient is going to have an aerosol generating procedure, we should think about upgrading the isolation from droplet to an airborne during intubation, for example, if the patient needs an intubation. In that case, you have to provide the N95, you have to provide the portable HEPA filters, and you have to make sure that it is in a safe environment as much as possible. But all the things that we discussed in the contact precaution will be added to the droplet isolation when we are dealing in the OR theater. Visitors and families, same things, same type of education. However, instead of educating them about contact isolation, we will do the droplet one. And of course, hand hygiene, PPE, standard precaution, all of that. The primary team, physician and nurses are responsible to do the education for the patients, families, and visitors when they come. We will take an example of influenza and we will discuss the duration of isolation for influenza, and the criteria to discontinue the isolation is patient is considered no longer infectious and can discontinue the isolation if 24 hours have elapsed since the resolution of fever, provided either the patient has received 72 hours of anti-influenza medication or 5 days has elapsed since the onset of respiratory symptoms. Repeating the nasopharyngeal swab to make sure the influenza is not there is not recommended. It is not part of the discontinuation of isolation. Airborne isolation is used for patients known or suspected to be infected with microorganisms transmitted by airborne droplet nuclei, which is small particle residuals that are 5 microns or smaller in size, or if of evaporated droplets containing microorganisms that remain suspended in the air, floating, and can be widely dispersed by air currents within the room or over a long distance, such as chickenpox, disseminated varicella zoster, measles, pulmonary tuberculosis, aerosol generating procedure for MERS-CoV, Ebola, etc. And when we want to talk about airborne, before we even step into the room, we make sure that our hands are quickly clean with a thorough hand hygiene routine, as we said before, for all type of isolation. Next, we suit up with our high-tech shield, the fit-tested N95 mask, or we might go for the popper mask if we cannot use the N95 mask, but it is not enough to just put them on. We do a seal check to make sure that there is no way those airborne germs can sneak in, and it is like checking all the locks before we leave our houses. Once we are all clear, we are ready to step in and care for our patients, confident that we are well protected. And when we are done, we carefully take off our N95 and or popper right there in the ante room or outside the patient room. We cannot remove them inside the patient room because all the air inside the patient room is considered contaminated. And we leave it in that space, that like a buffer zone, making sure that we don't take any airborne germs with us. And of course, the last step, hand hygiene. We sanitize our hands one more time to make sure we end our airborne isolation routine as clean as we started. The significance important of airborne infection isolation rooms or AIIRs in our hospital cannot be overstated. And these specialized rooms are important in our ongoing battle against airborne infections such as tuberculosis, varicella, measles, which can easily spread through the air and cause outbreak within healthcare settings. AIIRs are designed with safety at the forefront, providing a secure environment that reduces the risk of airborne diseases spreading to other patients, healthcare worker, or visitors. One of the key features of this room is their negative pressure system, and they are having minus 2.5 negative pressure compared to the corresponding. Also, they have a HEPA filtration, so all the air that is exhausted outside the room should pass through a HEPA filter and should be exhausted to the outside directly. It should not be recirculated in the AC if the HVAC system of the hospital. And the patients who are suspected or confirmed to have an airborne isolation should be placed in those rooms. And also the air change per hour, it should be a minimum of 12 or more. And many others engineering practices are required for those rooms, such as, for example, making sure that the fans that are working for to suck the air is connected to the emergency power supply, making sure that the toilet inside the room is having a shower so the patient will not need to go out except in the ICUs. They have like an exception. The doors of the patient room, it should be closed at all time. The monitors has to be giving an alarm and that is visual and audible at the same time when one of those parameters is out of range, etc. And the temperature and the humidity also important to make sure that the room is safe because the whenever the temperature is higher, like it's hot environment, more evaporation of the microorganism will happen and more aerosols that will produce in the air to cause more airborne pathogens in the air, transforming from being a droplet into airborne. Anyway, mechanism of airborne spread. As we said, aerosol generating procedures is one of the mechanisms. Particle size, if they are less than 5 micron, like for example TB, it is one of the mechanisms for them to spread easily. Environmental influences like humidity, airflow, temperature affect the particle behavior and increase the evaporation of those particles and increase the amount of airborne particles. Inhalation on deposition, particle deposited in the respiratory tract can lead to infection, pathogen viability, survival, and infectious dose of those pathogens are crucial for transmissions. For example, if you are talking about pulmonary tuberculosis, the TB can survive on surfaces for a longer duration compared to other organisms because it is a spore-forming bacteria. What do you mean by high temperature? So the temperature range in the patient room, I don't remember it exactly how it is, but I remember it shouldn't exceed 24 Celsius. So if the temperature is high, for example, 25, 26, 27, and the room temperature is higher than it is recommended, it will cause more microorganism to be evaporated as from being a droplet into an airborne particles. And more airborne particles will be in the air. So the concentration of airborne particles will increase based on the high temperature in the patient room. So the behavior of those microorganisms is linked with the humidity, airflow, and temperature. So you have to make sure that you maintain the room in the recommended temperature and humidity to ensure that those particles will not increase in the air. Aerosol generating procedure refer to medical and healthcare practices that lead to production of airborne particles known as aerosols from the respiratory tract. And those aerosols can contain pathogens such as viruses, bacteria, making them particularly significant in the context of infectious disease transmission, especially in hospital and healthcare environments. So the aerosol generating procedure include a range of procedures that might simulate coughing or involve manipulation of the airway or respiratory tract, thereby increasing risk of airborne transmission of infections. Examples like intubation, extubation, bronchoscopy, dental procedures, non-invasive ventilation like CPAP or BiPAP, high-flow nasal oxygen therapy, manual ventilation before intubation, tracheostomy procedure, CPR, and the use of nebulization. The significance of aerosol generating procedure and infection control and prevention lies in their potential to release large quantity of infectious aerosols into the environment should can remain suspended in the air for extended period of time, and it can be inhaled by the individuals nearby. And it necessitates specific measures to upgrade the patient from being a droplet isolation into an airborne isolation. The patient who are in airborne isolation should be placed in a negative pressure isolation room. If the negative pressure isolation room is not available, we can place them in a single room with a portable HEPA filter. And of course, you can cohort patient with an airborne isolation if all of those patients are having a confirmed disease, confirmed same organism or disease and not suspected. And the signage is outside, it will be the blue one, the airborne precaution sign. Talking quickly about fit test, the fit test is a mandatory requirement before using the N95 mask. And the purpose of the fit test is to ensure that the specific N95 mask you are wearing can properly fit for your facial feature because our faces are not the same. So the N95 should be fitted for your face and should be suitable for your facial feature. When you're doing any exercises in the fit test, it simulates the exercises that you might do in the room. So when you talk, yes, same disease, even for a droplet or airborne. So if they have COVID, they can be cohorted together. If they have TB, they can be cohorted together, but we cannot cohort TB with COVID, for example. And they must be confirmed. They cannot be suspected if you want to cohort patients together. Going back to the fit test. So the purpose of the fit test is to ensure that the exact N95 mask is suitable for your facial feature. So once you complete the fit test and once you successfully pass the fit test, you are only allowed to use the same brand, same model, same size of the fit tested N95 mask. For example, if you are tested for 3M1860 small, this is the only mask you can use. You cannot change the brand, you cannot change the model, you cannot change the size and say that it is similar. If anything changed, the fit test has to be repeated again. And the fit test should be repeated every 2 years or annually. I cannot remember the recent guidelines. I think every 2 years we can repeat the fit test. And sooner if any changes in your facial feature happens. For example, you gained weight or lost weight in a very short period of time, or you had any surgeries on your face. In that scenarios, whenever your facial feature change, you cannot use the N95. You should repeat the fit test, and during that time, you can use only the popper mask. Also for the males, we can say whenever you grow beard, fit test N95 mask is not suitable for you and you have to stop using it and you have to use the alternative, which is the popper mask. Thank you very much. So I will leave you with a quick video talking about how to use the popper mask. Then we will continue.
How to put on your pepper. All right, so these are the materials that you need, and here is where you can check your battery. Press it, make sure it goes all the way up to green. Here is your device. You simply connect the two. Oh, little trouble there. Nope, the other way, this, that way. And that's where you can take it off later if you need to recharge the battery. And then this part here is your tubing that will also connect later on. But first, we're going to go ahead and test the units, making sure that's creating the positive pressure that we would love. So here is the test tube. The little red ball goes above that line, and then you're good to go. Take it off. Perfect. Now you know that you're going to be protected with the positive pressure, right? Turn the device off. Go back over to the tubing system. Connect to the tube like so. Take your either medium large mask or small medium mask, whichever one fits you. Connect it to the back. You're going to look like a ghostbuster right when you have this thing on, but it protects you, so it's good. You take it over your hair. Make sure that your hair is away from your face. You don't have to wear a hairnet, but make sure you tuck your hair all the way in, okay, away from your face. And you put this around your waist, like it. Adjust this. And then you're good to go. Right, and all the way around, place on the back, ensuring that it's not covering your ears, but just over your face, and you're going to feel it blow the wind around your face. And you still hear the patient, but it just sounds kind of loud, you know. Wash your hands, and then you can gown up if you need to, and then come back out. You do your hand hygiene, take off your gown if you need to, turn the machine off. And now you can become a normal person again, taking off your astronaut gear. There you are.
Excellent. So we have a slide for airborne infection isolation rooms, engineering control. I think we covered before. We talked about all those things. We just forgot to mention two things, if I'm not mistaken. Making sure that rooms are tightly sealed to prevent leakage of contaminated air, and make sure that the door has an auto closure mechanism so the door will remain closed at all time. So airborne isolation in OR, it is a little bit more comprehensive. The patient should be postponed if it is elective procedure to the last procedure, or reschedule it to a different date. If it's urgent, we can, they have to manage it immediately, of course. But if it is elective, it should be postponed to the last procedure, or it can be rescheduled till he is cured. Adherence to patient transfer protocols for airborne isolation, it should be done. Signage, it should be done. PPE, all the healthcare worker in the OR, either inside the operating theater or outside the operating theater in the semi-restricted area. All of the staff who are working in the semi-restricted adjacent corridor, yani, and the OR theater should wear fit tested N95 mask and or popper. Also, patient will directly go to the procedure room bypassing the common waiting area or the pre-operative preparation area. The recovery, it can be done in the OR theater itself, or if they have a negative pressure recovery room, they can be recovered in the negative pressure recovery room. Thermal cleaning, it has to be done appropriately. Also proper ventilation. We have to make sure also that portable HEPA filter, we missed it upstairs. Portable HEPA filter is very important. So the placement of portable HEPA filter, it is advisable to be in the anteroom or inside the isolated operating theater if not possible. So we make sure that all the air that is coming outside the OR theater is filtered through a HEPA filter. If the scrub sink was in an open area or shared between two OR theaters, then the portable HEPA filter, then it has to be inside the OR theater. But to not disrupt the air turbulence inside the OR theater, it is advisable to be outside if the empty room is only serving this OR theater and not serving any other areas. And it is a closed room, not an open, it is not open to the corridor. باقي 3 presentations, and hopefully we will finish at 3. And of course, contact tracing has to be filled. Visitors and families, we encourage people with airborne isolation not to receive any visitors and family members inside their room to limit the exposure. But if it was necessary, sometimes for certain diseases, we might allow it, not all of them. And if it is allowed, we have to give them the proper precautions, and we have to limit their exposure to 5 minutes only of visiting time, if possible. Education must be given to them appropriately by the primary team, and that's it. So we will take examples for 2 diseases, when to discontinue the isolation. For example, duration of pulmonary TB, the patient will be on isolation until they have taken appropriate antibiotic for at least 2 weeks and show clinical improvement and have 3 consecutive negative sputum smears that are collected up to 24 hours apart. Preferably, one of them should be in the early morning. when we are talking about a chickenpox, for example, the duration of isolation will continue until all the lesions are crusted over, which typically occurs after about 5 to 7 days for the majority of lesions. But new lesions may appear in the first several days. Therefore, the total duration from the appearance of the first symptoms until all lesions have been crusted can be longer, potentially up to 2 weeks in some cases. So let's start with the Q&A session. Our first question for this presentation is isolation precaution required for patients suspected to have chickenpox is? Well done, everyone. It is airborne and contact isolation. Perfect. How many negative sputum acid-fast bacilli or FFP samples required from the patient in order to discontinue the airborne isolation precaution for TB suspected patients? Is it 1, 2, 3, or 4? How many sputum AFP sample is required to discontinue a patient who is suspected for pulmonary tuberculosis? Excellent. The correct answer is B, 3 negative consecutive sample, 8 to 2, up to 24 hours apart in the early morning. In case you failed the fit tests, and this is the question number 3, and you must care for a patient who is under airborne isolation, what should you do? So the correct answer for this question is wear a popper, which is powered air purifying respirator, before entering the negative pressure isolation room. B, of course, is not correct because the double, triple, whatever, how many surgical masks you will wear, it will not be sealed on your skin, and it will have no value when you are dealing with a patient under airborne isolation. So you must use popper if you failed the fit tests and you cannot wear a 95. Question number 4 is, what is the primary purpose of contact isolation? Why we are doing contact isolation? Excellent. The correct answer is B, to prevent the spread of infections that are transmitted through direct contact with the patient or the patient environment. Our last question for this presentation is, what additional precaution should be taken when a patient on droplet precaution requires aerosol generating procedure? So we have a patient under droplet isolation, and this patient will undergo aerosol generating procedures such as intubation, extubation, nebulization, CPR, bronchoscopy, a lot. So what type of precaution should be done? Additional precaution, excellent. So the correct answer is D. Healthcare workers should use fitted N95 mask respirator or popper instead of the surgical mask. Thank you, everyone. Let's come back because I need like 5 minutes break. Let's come back at 12:55. What is the difference between the gown and aprons, and where should we wear the aprons? Excellent question. So the gown, it has 2 types. We have the isolation gown, which is usually yellow in color, and we have the sterile gown, which is usually blue in color. Usually, the isolation gown, or the yellow one, is water resistant, while the sterile gown, or the blue one, is waterproof. So if we are dealing with a patient under droplet isolation, for example, or with minimal exposure to fluids, we can use the isolation gown because it will resist the fluids and it will protect our clothing from contaminant from microorganisms. However, if we are talking about isolation gowns, sterile gowns, the blue one, it's waterproof. So the waterproof isolation gowns, the waterproof sterile gown can be used when we are dealing with a expected of high exposure of blood or body fluids, such as in OR settings or in the CSSD decontamination area or any other area where exposure of fluids might be high. So we need to make sure that even if exposure happen, nothing will come to our clothing. And this is where we wear the sterile gowns. Then you are asking about aprons. Aprons is something that waterproof. However, the aprons is not like the gown. The aprons is usually doesn't cover the sleeves and the hands. So you might use it for certain procedures, such as when you are cleaning a spill, for example. You can wear an apron. So it depends on what risks you are encountering. You can use the appropriate PPE to make sure that yourself and the clothing are safe when dealing with such contaminants. I hope I answered your question. Right. We will be back at 12:55, hopefully. I will not be late. Just take like a sip of water or anything else, and we will continue our presentation. We are still having 3 other presentations to finish. Enjoy your break. Patient for. So our next presentation will be regarding infection prevention practices in the dental care or dental clinics. So in this session, we will begin by highlighting the critical importance of infection control, which is a cornerstone of safe dental practices. Following this introduction, we will focus on the dental personal health and safety, reviewing the current immunization protocols required for all dental healthcare personnel, alongside essential health surveillance measures and strategies aimed at preventing occupational injuries within the dental clinics. We will then thoroughly explore the instruments and device sterilization, starting from the initial instruments handling at the point of use, emphasizing the proper management of single-use dental items, and detailed the safe transportation of dental instruments to the CSD. We will continue by discussing critical cleaning and sterilization procedure performed within the CSSD. And next, we will cover the crucial topic of dental unit waterline maintenance. Then we will discuss the dental impressions and prostheses. And lastly, باقي 3 هذا و2 ثانيين. Then we will address special consideration for specific dental specialties tailored for IBC practices for orthodontics, pediatric dentistry, prosthetics and endodontics and dental radiography. And lastly, we will talk about infection control in the dental lab and management of dental patients and their airborne isolation. And of course, we will finish our session with Q&A session. So the importance of infection control in dental settings. IBC is critical in those practices because of the closed and often invasive nature of dental procedure, exposing both patients and staff to potentially infectious risks. And the pathway through which infections can spread in a dental setting include a direct contact with body fluids, use of contaminated instruments, and from airborne particles during aerosol generating procedure. Our commitment here is not only to safeguard against those risks, but also significantly enhance the patient safety and satisfaction. By adhering to established IDC standards, we fulfill both our ethical obligation and regulatory requirements, and we make sure that the dental practice is safe for both our patients and healthcare workers. Inshallah, we will finish at 3, بإذن الله. But we have to be a little bit quick. So immunization is very important when we're talking about transmission of infectious diseases within our dental facilities. First, we talk about hepatitis B and influenza, MMR, varicella, and Tdap. All of those vaccinations are recommended for staff who are working in the dental field, and it should be done appropriately. For example, the influenza, it should be done on an annual basis, etc. And for hepatitis B, they should complete the series, and an evidence of immunity of serological testing is done to ensure that the staff is responding to the vaccine, etc. So it's similar to the vaccination we give to our healthcare workers. Moving forward, our focus now shifts to the critical integration of health surveillance and infection prevention strategies. And the health of our dental healthcare personnel is important, not just for their safety, but also for the protection of our patients. We actively monitor for signs of infectious diseases to swiftly intervene because before any potential outbreak can occur. This monitoring extends to ensuring that all staff members are up to date to essential immunization, provide a foundational barrier against common infectious disease. Equally important to that is our approach to preventing injuries, especially those related to sharps and needles. By enhancing our sharp management protocols, we can reduce the risk of those incidents. Complementing this, strict adherence to PPE and correct use of personal protective equipment is really important. And I think we should have a protocol in place when injuries or incidents of needle stick or sharp happen, or exposure to infectious diseases happens. All those proactive and measures are important to maintain not just the health of our team, but also the trust to those who we serve. Immediately, when we are talking about instrument handling at the point of use, so immediately after any dental procedure, it is essential to remove visible debris such as blood tissues or other contaminant from instrument before they leave the clinical area. Single-use items should be discarded immediately. However, reusable instrument must be transported to the CSSD without delay. If an immediate transfer isn't feasible or difficult, the instrument should be immediately sprayed with enzymatic transportation gel. It should be applied immediately to maintain the moisture and prevent them from drying and prevent the organic matter to dry, making later cleaning and sterilization more effective and efficient. In addition, we must ensure that those instruments are securely contained within the puncture-resistant closed container, clearly labeled with a biohazard sign to minimize injury or exposure risk. While handling and preparing these instruments, always wear suitable personal protective equipment, including gloves, masks, gowns, and protective eyewear to guard against the potential contaminant. Immediately after delivery to your CSSD, remove all your PPE and do hand hygiene. Handling of reusable instruments, managing single-use dental items correctly at the point of care is equally critical. Single-use items are specifically manufactured to be used only once, and ensuring patient safety by significantly reduce the risk of cross-infection. It's important to remember that those items must never be sent to the CSSD for reprocessing. Common single items such as include saliva injectors, suction tips, plastic impression trays, and disposable burrs, files, matrix bands, which immediately should, after the procedure, should be disposed in the biohazard waste. Once we have properly handled instrument at the point of use and safely managed our single-use items, the next critical step is the careful transportation of reusable instruments at the at the CSSD. Proper preparation involves securely placing the instrument into the puncture-resistant leak-proof container immediately after procedures, and those containers must be clearly labeled with biohazard sign, as we said before, and should be dedicated exclusively for contaminated instrument to prevent any confusion or contamination risk. During transportation, careful handling is essential. Always wear your appropriate PPE, such as heavy-duty gloves, to avoid direct contact with contaminated instrument. And we must use the designated or dedicated transportation pathway separate from the route used for clean and sterile items, ensuring minimal exposure risk to other staff, patients, and visitors. Timely transport to CSSD is crucial to maintain effective cleaning and sterilization. If any delay might happen, they should be sprayed with the enzymatic transportation gel immediately. When contaminated instruments arrive to the CSSD, our first priority is safe handling and thorough inspection using appropriate personal PPE. Open the container, conduct an initial visual inspection, check for any obvious damage or missing item. After inspection, they have to be thoroughly cleaned through automated methods such as mechanical washer or ultrasonic cleaning devices. It's essential to strictly follow the manufacturer recommendation regarding appropriate time, temperature, detergent concentration to ensure consistent and effective cleaning outcome. Manual cleaning might be necessary if instruments can't undergo automated cleaning machines. In these cases, instruments are fully immersed in enzymatic detergent solution and gently brushed beneath the water surface to prevent aerosolization, maintaining staff and minimizing environmental contamination. Hope you can hear me clearly. Excellent. So moving to the next slide, sterilization process in the CSSD. Once we finish with the cleaning, the next stage is to do the sterilization. So we package the instruments and we check them for any contaminant as we do in the CSSD, then we send them for sterilization. And in the sterilization, we have the steam sterilizer, which is the most common thing that is used in the dental practices. And we should monitor the sterilization, mechanical, chemical, biological, as we do in the CSSD. And everything has to be documented as we do in the CSSD as well. Storage of the sterile dental instrument, same thing as we do with any other instruments. It should be stored in area that is free from contamination, moist or damage, and it has to be in a clean, dry areas. It should be monitored. FIFO should be applied first in, first out, and appropriate labeling and everything has to be in there, as we do in the CSSD exactly. So effective management of dental unit water line is crucial in maintaining a safe dental environment. Dental waterline can quickly develop biofilms, which are microbial communities adhering to the inner surface of the tubing, especially when water stagnates between treatments. And these biofilms are known to harbor harmful pathogens, including organisms such as Legionella, Pseudomonas, posing a potential risk of infection for both patients and dental healthcare personnel. To control and prevent biofilms formation, regular flushing is essential. Dental water line should be flushed at the beginning and at the end of each clinic a day for 2 to 3 minutes. And also should be flushed at least 20 to 30 seconds between each patient. Constant use of manufacturer-approved antimicrobial solutions significantly helps in controlling microbial growth and reducing biofilms formation. In addition, our practice requires performing weekly invasive chemical shock treatment to effectively control microbial contaminant within the dental unit water lines. Also, monthly microbial testing of water line is also mandatory, ensuring compliance with acceptable microbial limits, no more than 500 colony forming units per milliliter. Water testing result, if it exceed that threshold, the dental unit must immediately be discontinued until the water and the chemical shock treatment should be performed again. Retesting should be done after that. And once you establish the standard, you can reopen the clinic afterward. In managing infection prevention, we must carefully consider dental impression and prosthesis as they represent significant risk of contamination and potential disease transmission. Immediately after removal from the patient mouth, impression should be thoroughly rinsed under running water and disinfected using a suitable intermediate level disinfectant. And similarly, prosthesis, once disinfected, should be clearly labeled to confirm their infection control status before being stored or transported as contaminated item. Maintaining a dedicated clean storage area for the disinfectant prosthesis is essential to prevent any recontamination or confusion regarding their cleanliness status. Furthermore, communication and clarity are critical when prosthesis and impression are transferred to the dental lab. Lab personnel should always treat incoming item as potentially contaminated unless clearly labeled as disinfectant. If disinfection status is unclear, dental lab should repeat the disinfection procedure and make sure that it is safe. Infection prevention and control measures aren't universal. Each dental specialty has unique risks and practices that require tailored IBT practices or strategies. So in orthodontics, where frequent handling of orthodontic materials such as elastics, bands, and adhesive demands strict precautions, segregation and clear labeling of single-use items are also essential to prevent misreuse of those items. While orthopedic players, and cutters require a thorough removal of adhesive residual before meticulously sterilization and minimize cross-contamination. In pediatric dentistry, infection control protocol must accommodate the unique behavior and vulnerability of young patients, providing child-sized personal protective equipment encourages greater compliance, and due to the high-touch nature of pediatric patients, frequent and meticulous surface disinfectant is crucial. Special emphasis should also be placed on the hand hygiene given the closer and often unpredictable interaction pattern from the children. In prosthodontics, we regularly handle a variety of material that require specialized disinfection requirements, specialized disinfection techniques. Prostheses, whether acrylic, metal, or porcelain, must undergo disinfection using approved solutions such as sodium hypochlorite or iodophores before insertion or in delivery to the patients. Furthermore, it is essential to clearly document and communicate disinfection protocol with dental lab, ensuring sterility and preventing cross-contamination risk between lab and clinic. Turning to endodontics, the invasive nature of procedure necessitates strict IBC adherence. Endodontics files and reamers require immediate wiping with sodium hypochlorite solution after use, followed by thorough ultrasonic cleaning and proper sterilization. Sterilized files should be individually packed with gauze to prevent corrosion or moist accumulation. Additionally, gutta percha points must be sterilized with sodium hypochlorite before insertion or to maintain strict infection control standard during root canal procedures. Lastly, dental radiography poses significant specific IBC challenges as well, as it is essential to use disposable protective cover for sensor wherever possible, significantly reducing the contaminated risk. Intraoral radiography devices must be sterilized between patients, while heat-sensitive equipment require careful disinfection using approved high-level disinfectants. Always remember that dental healthcare personnel must wear gloves when handling contaminated films, sensors, or added films, add masks, gown and eye protection when fluid splash or splatter is possible. While general infection prevention and control principles provide a strong foundation, certain dental specialties require a unique IBC measures, as we said before. Beginning with the orthodontics chair present involve placing disposable barrier. So the disposable barrier on the chair controls and surfaces should be placed in all type of procedures, and thorough disinfection of surfaces between patients should be done for all patients the same. When we are talking about dental instrument tray, the differences between each specialty is a little bit different, with more focus going to the endodontics and because of the need of sodium hypochlorite immediately available to wipe the gross contaminant from the instrument before sending them to the CSSD. Specialized PPE, generally speaking, we can say that whenever splashes is anticipated, patient also should be offered an eye goggle to protect them from infections. The staff, generally speaking, should be wearing mask, gloves, gown, and face shield when they are doing any of those procedures. Infection control in dental lab extend beyond the clinical setting into our dental infection control extend beyond the clinical setting into the dental lab, which play an essential role in the patient safety. All dental materials such as impression, bites, registration, and prostheses arrive to the lab must initially be considered contaminated. It's vital that those items be clearly labeled regarding their disinfection status. If there is any doubt or absence of documentation, disinfection should be performed immediately upon recipient of those items using approved disinfectants such as diluted sodium hypochlorite or iodophores as per the manufacturer guidelines. Additionally, lab equipment itself, including articulators and other reusable devices, require thorough routine disinfection. Equipment should be disinfected regularly to ensure safety, functionality, and compliance. Proper ventilation within the lab area is essential during these processes to minimize the staff exposure to disinfected chemicals. Lab environment services demand regular attention, daily disinfection, and intermediate cleaning of visible contaminated area, prevent cross-contamination risks. Clear physical separation between contaminated and clean item within the lab is also critical. Personal PPE is equally essential in the lab setting. They have to wear their PPE, gloves, mask, eye protection, and gown when they are handling contaminated lab items. Strict hand hygiene is also very important when we are dealing with such items. Management of dental patient under airborne isolation. It is similar to what we do in the OR. If the patient is not urgent, it should be delayed or rescheduled till the patient is infection-free. But if it was urgent, it has to be done now. It should be rescheduled at the end of the day if possible. Patient should be placed in a negative pressure room if it is there. If not, a single room with a portable HEPA filter. Door should remain closed at all time. PPE similar to the airborne isolation, fit tested N95 or proper. Additional PPE is required if the patient is having additional type of isolation like gloves, gown, eye protection, Also, it is sometimes required as part of the standard precaution when we are dealing for such, when we are doing any procedure for those patients. Um, limit the aerosol generating procedures such as ultrasonic scaling or high-speed drilling to essential cases only, and utilize high-volume evacuation suction continuously throughout the aerosol generating procedure to minimize the airborne pathogen dispersion. Cleaning and sterilization is the same. Staff protection and management exposure, it's the same. We have discussed it in the previous presentations. Waste management also is the same. Let's go to the Q&A session for this presentation. So our first question for this presentation, what is the primary infection control concern related to dental unit water lines? Excellent. The correct answer is B, contamination by biofilm formation. And this is why we do the flushing in the clinic, and we do that shock treatment for on a weekly basis, and the flushing on a daily and between patients. Excellent. Well done. Question number 2, which of the following is true regarding the sterilization of dental instruments? So for that question, the correct answer is C. Instrument must be properly cleaned before sterilization, because sterilization alone is not enough if it is not properly cleaned before sterilization. Again, for the biofilms and to make sure that the sterilization has reached their effectiveness when dealing with such instruments. However, when we talk about chemical indicator alone confirms sterilization effectiveness, of course, this is not correct, because we do multiple tests to make sure that the sterilization is effective, which include, for example, the biological indicator, which include the chemical indicator, which include the poetic test if we are using an autoclave. All of those are indicators for making sure that sterilization effectiveness. And chemical indicator was never alone enough to to confirm a sterilization process. Question number 3, in endodontic procedure, how should contaminated files be handled after use? When we are talking about files, we are talking about like a thin metal things that goes and to the patient mouth. It's not a paper file. It is an instrument. It's called files. Excellent. So the correct answer is wipe them with sodium hypochlorite gauze and send them immediately to the CSD for sterilization. And this is specific for endodontic procedure. Question number 4, when managing a patient under airborne isolation precaution, which of the following measure is not correct? Is not correct. Excellent. I think this is an easy question. The correct answer is B, using a standard surgical mask instead of 95. This is totally not correct. Excellent. So question number 5. What is the appropriate disinfection method for dental impressions before sending them to the laboratory? Here we are talking about dental lab, not hospital lab. So what is the appropriate disinfection method for dental impression before sending them to the dental lab? Well done. Excellent, everyone. MashaAllah. Immersing in an intermediate level disinfectant such as sodium hypochlorite or iodophores for at least 10 minutes with the correct dilution. Perfect. Well done, everyone. So this is the end of this presentation. Hope you enjoyed it. Next presentation, it will discuss the next presentation. It will discuss the infection and prevention practices in different units such as burn units, physiotherapy, derma, lab, radiology. So as we go through a detailed journey of the essential practice of infection prevention and control in a specialized medical environment, each segment of our discussion is designed to enhance your understanding and implementation of the IBC measures tailored to the unique needs of the various medical units. Introducing the IBC in a specialized unit, we start highlighting the overarching importance of IBC. This fundamental overview sets the foundation for why these practices are crucial across different specialties and underscoring our commitment to patient safety and healthcare excellence. So exploring the burn unit, our first focus will be burn units where we will discussing the specific risks of those environment pose, and we will delve into tailored IBC measure exploring wound management, consider the use of hydrotherapy, ensuring comprehensive care and infection control. Then we transition into the physiotherapy, where we will examine how IBC measure integrates seamlessly into the rehabilitation process. We will cover everything from equipment handling to engaging effectively with patients and maintaining a safe therapeutic environment. In dermatology, attention to detail is a key. We will cover critical pre- and post-procedure care protocol and discuss the sterilization of equipment, which is important in preventing post-procedural infections and ensuring patient safety. Moving into the laboratory settings, we focus on biosafety and contaminant strategies, particularly for microbiology labs dealing with infectious agents. This segment is vital for understanding how to shield both practitioners and the community from potential exposures. Radiology role in IBC, we will explore effective IBC practices within imaging environment. This includes the careful disinfection of equipment and rooms and the meticulous handling of probes based on their level of patient contact. And we will go quickly through the cardiac cath lab, and then we will go through our Q&A session. So infection prevention and control is foundational in maintaining the safety and the quality of care across all healthcare settings. In a specialized unit where patients often face greater risk due to their condition or the nature of their treatment, tailored IBC measures become even more critical, and these protocols are not just guidelines, but essential practices that helps us achieving high standards of care, improving the patient outcome and significantly reduce the incidence of healthcare associated infection. So we will start with the burn units. So the infection control in burn unit present a unique challenge Burn patients are at high risk of infection due to compromised skin barrier and the systemic impact on their immune system. Their vulnerability is often mentioned or explored by pathogens such as Staphylococcus aureus, Pseudomonas aeruginosa, and Candida auris or Candida species, which if not managed meticulously can lead to severe life-threatening complications. To mitigate these risks, our approach to infection prevention and control is multifaceted. We enforce rigorous hand hygiene and the use of PPE to prevent cross-contamination between caregivers and patients. We emphasize the importance of regular environmental cleaning and disinfection, focusing especially on high-touch surfaces around patients and within treatment spaces to ensure a sterile, clean, and safe environment. Wound care in burn patients is critical. It requires the use of sterile gloves, gown, and instruments during dressing changes. We employ antimicrobial dressing and engage in vigilant monitoring of wound healing to swiftly detect and manage any signs of infection. Another crucial aspect of care in burn unit is managing the risks associated with hydrotherapy. Our protocols ensure that hydrotherapy tanks are meticulously cleaned and disinfected between each patient use. We also maintain strict monitoring of chemical levels in hydrotherapy equipment to balance effective disinfection with patient comfort and safety. Furthermore, it's important to recognize that patients with extensive burn covering 25% or more of the total body surface are often considered as immunocompromised, and this substantial loss of skin integrity and associated with associated immune dysfunction necessitate tailored infection prevention strategy to prevent infection. In physiotherapy, where patients' interaction and equipment used are frequent, maintaining an excellent infection prevention and control practices is important. We begin with the essential, strict adherence to hand hygiene and the correct use of personal protective equipment, depending on the nature of patient interaction and the specific procedure involved. Gloves, gowns, masks are utilized to protect both our staff and patients. Regular training sessions are also essential, ensuring that all staff are proficient in the application and removal of PPE and updated to the latest IPC protocols. Turning to our environment and surface disinfection, we focus on keeping the treatment area meticulously clean. High-touch surfaces like door handles, treatment tables, equipment controlled with regular disinfection with EPA approved or hospital approved solution. Adherence to the manufacturer recommendation of contact time and dilution is really important. Our routine cleaning and disinfection protocol extend to all equipment used within the physiotherapy setting, from therapy mats to slings. Each piece of equipment is cleaned thoroughly between patients, following manufacturer guidelines to proper cleaning and disinfection. Lastly, the safety of our hydrotherapy and hydrocollator units is crucial. For hydrotherapy, we meticulously maintain the chemical balance and of the pool and conduct daily cleaning and ensure environment is safe for every patient. And hydrocollator kept at a strict regulated temperature of 71 to 74 Celsius to optimize therapeutic benefits while ensure safety, and regular inspection help us identify and rectify any issue such as mineral deposit or corrosions, and maintaining the hygienic and functionality and hygienic of those therapeutic tools. So to continue, this table outlines the specific cleaning protocol we follow for each type of equipment used during therapy sessions. For mobility aids like canes and walkers, we use hospital-grade disinfectant that after each use to ensure that they are free of pathogens. Always wear gloves during the process. Wheelchairs require thorough cleaning of all surfaces with special attention to handle, and staff may need to wear a gown along with the gloves if the equipment is visibly soiled. Transfer slings being in direct contact with the patient are either disposed or laundered after each use to prevent any risk of cross-contamination. Therapy mats are cleaned with an appropriate disinfectant and allowed to air dry fully before the next use to ensure effective sanitization. Um, Gym devices, which are frequently touched by multiple users, have their grips and seats disinfected after each use. Alcohol wipes are specifically used for cleaning screens to avoid damage and maintain cleanliness. The hydrotherapy pools are subjected to daily chemical balance tests and surface cleaning to ensure a safe therapeutic environment. Gloves and water pools gear are required to be for this process to protect the staff from chemical exposure. And lastly, our hydrocollator units, crucial for moist heat therapy, are checked daily for water level and temperature accuracy and cleaned on the outside to maintain the hygiene and functionality. And the water should be changed for hydrotherapy pool and hydrocollator daily. For hydrotherapy pools, it should be changed daily and after each use, while hydrocollator it should be changed on a daily basis. So in physiotherapy also, our interaction with patients are not just about rehabilitation, but also about ensuring a safe and healthy environment for both patients and staff. And to achieve that, we implement rigorous patient handling techniques. Every member of our staff is trained to utilize safe handling practices that prevent both physical and microbiological cross-contamination. Moreover, we place a strong emphasis on educating our patients about the importance of maintaining personal hygiene before and after each treatment session. But our commitment doesn't stop at training and education. We engage our patients through regular updates and information session about the infection prevention and control measures we have in place. And this ongoing dialogue helps in enhance the compliance and safety, making each patient an active participant in their own care process. We encourage all patients to embrace and adhere to their disease hygiene practice throughout their rehabilitation journey, ensuring a safe environment for everyone involved. In dermatology, the cornerstone of patient safety lies in meticulous infection prevention control protocols, spanning from skin preparation to post-procedure care and ensuring a clean environmental setting. Starting with the skin preparation for dermatology procedure, we employ antiseptic solutions such as chlorhexidine gluconate or povidone iodine. These are meticulously applied to ensure they have sufficient contact time to effectively reduce the microbial load on the skin, which is crucial for preventing post-procedure infections. Patients are advised to arrive with the clean skin and avoid any lotions or treatment that could interfere with the antiseptic effectiveness. Moving to equipment sterilization and disinfection, all critical instruments that penetrate the skin, such as biopsy, punches, and surgical blades, are subjected to rigorous sterilization using autoclave or approved chemical sterilants. Meanwhile, non-critical items that come in contact with the intact skin, like dermatoscope, can undergo disinfectant with high-level disinfectant to prevent any potential contamination. For post-procedure care, we apply sterile dressing to safeguard the wound and enhance the healing process. Additionally, patients receive comprehensive instruction for home care, introducing the sign of infection to monitor and guide on when to seek medical advice, ensuring ongoing vigilance in the critical days following the procedure. And lastly, our commitment to infection control extends to manage environment and air quality. We routinely clean and disinfect all surfaces in the treatment room, especially after invasive procedure. Our clinic can be having a HEPA filter just to improve the air quality if uh, there is a fear from blisters or anything else. airborne pathogen. In our dermatology clinic, maintaining strict infection control standards is important for patient safety and equipment integrity. And this table outlines our comprehensive protocol for cleaning and disinfection essential equipment, ensuring that each item is treated according to its specific requirements and risk level, starting with biopsy punches. These critical instruments are sterilized before each use, either by autoclave or using chemical sterilant, ensuring all microbial life is eradicated. For dermatoscopes, which is frequently in contact with the patient's skin, we can use intermediate level disinfectant after each use, being careful not to damage the sensitive component like the lens. Examination beds, which see high patient turnover, can cleaned with detergent and EPA approved disinfectants. Ultrasonic probes, especially those used for invasive procedure, undergoes thorough cleaning and high-level disinfection, although we use disposable cover as the additional protection barrier for that can be replaced that cannot be replacing the proper disinfection. For cryotherapy devices, they are meticulously wiped down with the detergent and water, then disinfected with an EPA a registered disinfectant after each use. It is crucial to ensure that these devices are completely dry before they are reused to prevent any microbial growth. And lastly, the laser handpieces are cleaned and disinfected with high-level disinfectant after each use to prevent any cross-contamination between patients. In this slide, we will discuss the biosafety contaminant practices in the laboratory settings. So now we are talking about the lab. So the lab are classified into different biosafety levels based on the microbiology unit in the lab. It is classified into 4 different biosafety levels based on the agent they handle and the level of protection requires. So biosafety level 1, BS1, is the basic level of protection suitable for well-characterized agents not known to cause disease in healthy humans. And the requirements here is not that much. Biosafety level 2 is appropriate for agent that poses moderate hazards and include restricted access, biosafety cabinets, and specific training for laboratory personnel, which is the common standard that is used for most of the hospitals when we are dealing for any cultures or anything else. Then we have biosafety level 3, which is designed for agents that can cause serious or potential lethal disease. And laboratory at this level require controlled access, specialized ventilation system, use of biosafety cabinet to contain infectious agents. The air, for example, the door for this room, it should be airtight. The staff who is working in this area should have appropriate PPE. It has a lot of requirement when we are talking about this level. And usually this level is used for when we are handling dangerous microorganisms such as pulmonary tuberculosis, for example. Then we have the highest level of protection, which is biosafety level number 4, which provides the highest level of protection for handling dangerous and exotic agents. And this is usually, you see it in, not in hospitals, usually, you see it in other areas where they encounter something that is not known or very dangerous organisms where they have to take extreme precautions when they are dealing with such organisms. Contaminant practices in laboratory settings are critical to maintain biosafety. The use of biological safety cabinet is essential in handling infectious material, and these cabinets provide a controlled environment that prevents the escape of pathogens. Proper disposal of hazardous waste is crucial to prevent contamination. Regular disinfection of workplace and equipment, along with the use of PPE, ensure that the laboratory personnel are protected from exposure to infectious agents. So, the design of microbiology lab handling infectious agents required restricted access to minimize exposure risks. Entrance should be marked with universal biohazard symbol to alert personnel of potential hazards. The lab should have a separate area for specimen collection, processing, and analysis to prevent cross-contamination. Biological safety cabinet class 2B must be used for handling infectious agents, providing a controlled environment that protects both personnels and samples. Safety equipment is essential for maintaining a secure laboratory environment. Emergency eye wash facility and shower must be available for immediate use in case of exposure to blood and body fluid or chemicals. Autoclave also is necessary for sterilizing hazardous material that are known to uh, have issues when it is in the community. So it has to be treated in the point of in the hospital before it is sent to the as a medical waste. Dedicated hand washing sinks separate from working sink should be available to promote hand hygiene practices among lab staff. Special consideration and required for mycobacteriology laboratory handling mycobacterium tuberculosis, and those lab must meet the requirement for biosafety level 3, featuring negative pressure ventilation, air change cycles, a lot of requirements that we just discussed in the previous slide. Operation practices in microbiology lab include routine decontamination of surfaces, as we said before, regular training and competency, strict adherence to standard operational procedure when handling infectious agents. So radiology departments are a cornerstone in modern healthcare, performing a wide variety of diagnostic and therapeutic procedure, and these range from a non-invasive imaging technique like computed tomography or CT scan and magnetic resonant imaging or MRI to more invasive procedures such as angiography and biopsies. And the unique nature of radiology makes it a critical area for infection prevention. Many of these procedures involve direct patient contact and some require sterile technique due to their invasive nature. This creates a dual responsibility to ensure accurate diagnostic and therapeutic outcome while protecting both patients and staff from potential infections. Key procedures performed in radiology include CT, fluoroscopy, diagnostic radiography, MRI, nuclear medicine, and ultrasound. Additionally, interventional and invasive procedures such as biopsies and angiography bring added challenge, acquiring even stricter infection control measure. And that's it. Radiology department, with their combination of invasive procedure and shared equipment, are environment where infection risks must be proactively managed. So let's break this down into key areas that require attention. First, identifying the risk is essential. Invasive procedure like angiography or biopsy require sterile technique or operative settings. Also critical to evaluate the infection risks specific in radiology equipment, which is often used by multiple patients and interacted between patient and staff. Next, developing protocols and to ensure safety and clear policies and procedure must address core practices like hand hygiene, proper use of PPE equipment, proper use of PPE and aseptic technique during invasive procedure, compliance with the CDC guidelines and MOH regulation, and manufacturer instruction for cleaning, disinfection, sterilization of non-negotiable. I mean, is not negotiable to minimize the infection risks. Staff training and competency is really important, and environmental cleaning is also as important as before. Effective infection prevention in radiology also relies on patient care practices, which includes use of gloves, PPE, following established protocol for vascular access use, such as insertion checklist, dressing management, and help prevent bloodstream infection during invasive procedure. For equipment decontamination, the use of sterile catheter and disposable covers for probes is critical while applicable, where applicable. Reusable probes must undergo high-level disinfectant following the manufacturer instruction to ensure patient safety. Additionally, closed flush and waste contaminant system should be used during procedure like angiography to prevent exposure to biohazard. The final element is monitoring and continuous improvement by doing routine audits, review and update of the policy, and to promote a culture of safety and accountability. We will finish inshallah at 3 o'clock. We still have this presentation and there is one more last presentation after that. So in radiology, the effective management and the classification of probes based on their level of patient contact are crucial to maintain high standard of patient safety and infection control. In this slide, we will outline our protocol for semi-restricted and semi-critical and non-critical probes. So we will start with the semi-critical probes, which include devices like transesophageal echocardiography probes and endocavitary ultrasound probes. Our priority is to ensure thorough cleaning to remove all visible debris before disinfection. These probes require high-level disinfection after each use to prevent the transmission of pathogen. We use EPA-registered disinfectants that are suitable for high-level disinfection, adhering strictly to the manufacturer guideline regarding the contact time and drying procedure. To further reduce the risk of contamination, we recommend the use of disposable covers. Moving to the non-critical probes, such as external ultrasound probes and X-ray imaging surfaces, these are cleaned after each use to remove contaminants. Although these probes are contact with intact skin, they are disinfected with EPA-registered disinfectant appropriate for low-level disinfection. Special attention is paid to area frequently touched by staff and patient, ensuring consistent and reliable approach of hygiene. I think this is the last point for, no. I think this is the last point for this presentation. We will talk about cath lab, if I'm not mistaken. In the cath lab, it is a part of the radiology, we can say. And in summary, it requires a setting similar to the OR, and it requires sterile environment. Similar thing that is required in the OR will be applied in the cath lab as well. And almost that's it. It is similar to the OR, and we already took the OR lecture today, so almost there is nothing different between the cath lab, cardiac cath lab, and the OR settings when we are talking about both of them. Yeah, same. So let's test our knowledge with our Q&A session for this presentation. So which type of disinfection is required for endocavitary ultrasonic probes used in radiology? We are talking about endocavitary ultrasound probes. They are not semi-critical, they are critical. Sorry, they are not non-critical, they are semi-critical items. So the correct answer is high-level disinfection because they will be in contact with the mucous membrane. So they will enter the body. Question number 2. What is the critical practice for managing hydrotherapy tanks in physiotherapy units? Excellent, everyone. The correct answer is B, maintaining precise chemical balance and cleaning the tanks between patients, between every patient use, and on a daily basis. Excellent, well done. So, question number 3, which biosafety level is appropriate when we are handling a Mycobacterium tuberculosis in laboratory setting? Is it class 1, class 2, class 3, or class 4? The 4 is too high. Class 4 is too high. Class 4, yeah, thank you. Excellent. So the correct answer, yes, it is C. Well done. Not class 2. Class 2 is used for other organisms. Class 3 is in Saudi Arabia only, and not in the US. They use class 3 for Mycobacterium tuberculosis because it's still we still have Mycobacterium tuberculosis in Saudi Arabia. Unlike the US, it's almost not there anymore. Class 4 is not used except if we have something that is very dangerous, like a new emerging disease or stuff like that. And usually you don't find the class 4 in any hospital. It's very advanced and require a lot of standards. Question number 4, which cleaning protocol is necessary for external ultrasound probes? External ultrasound, it's like, for example, the ultrasound, we do it for to check the fetus heartbeat, for example. So it is not critical, not critical. It doesn't come in contact with the mucous membrane. It is in contact with the intact skin. So the correct answer is C. I can see a lot of answers. You know the ultrasound machine, it has the probes. Probes means the thing that send waves to read, to see what is in your body. Yeah, we can say it this way. So it is something external. It doesn't go inside the body. It's going outside on the surface of the body. Like, for example, when they are checking the fetus heartbeat, it goes on the abdomen from outside. Unlike the vaginal probe, which is intracavity that goes into the in contact with the mucous membrane or other probes that needs a high level disinfection. This one, low level disinfection after each use is enough. A sterilization, it will damage this probes. You cannot sterilize the probes because it will be damaged. And cleaning once a day, regardless of use, is not practical. It's totally not acceptable. Right. Question number 5. Which of the following statement is true regarding the care of burn patients? 3 statements are not correct. Only 1 statement is correct when we are taking care of a burn patient. MashaAllah, well done. Excellent, everyone. So the correct answer is patient with burn covering 25% or more TBSA, total body surface area, are considered immunocompromised and should be placed in a protective environment. Excellent, everyone. I need to take like 5 minutes break. So we will back at we will be back at 2:05. Good. Because we cannot extend it more than that because our last presentation is a little bit long and it talks about outpatient clinic, and the outpatient clinic is a little bit a busy area. See you after 5 minutes. Enjoy your break. Presentation. Let's go to our last presentation for today. I will try to finish it as soon as possible. Inshallah, before 3 we will finish. So in this presentation, we will discuss prevention and measures and preparedness on outpatient clinics. Thank you very much. Our agenda is a little bit tough. We will be exploring infection prevention control measures in the outpatient clinic, focusing on specific recommendation tailored to different ambulatory care settings. We will begin with introduction to IBC and outpatient clinic, where we will discuss infection risk unique to these settings and provide an overview of tailored IBC strategies. Following this, we will move through various outpatient specialty area, each with distinct infection risk, and control measures. And for example, in infusion centers, we will focus on bloodstream infections, environmental cleaning, NDRO, and immunocompromised patients. Then we will talk about an internal medicine specialty such as cardiology, pulmonology, and radiology and rheumatology. We will cover the safe reprocessing of diagnostic equipment, respiratory precaution, and best practices for infection prevention. Then we talk about obstetrics and gynecology and infertility clinics. We will address the high-level disinfection of vaginal ultrasound probes, environmental cleaning, and IBC measures in infertility treatments units. Then we will talk about ENT and audiology clinics. We will highlight proper reprocessing of nasal and laryngeal endoscopes, safe handling of anesthetic sprays, and cleaning protocols for audiology equipment. Next, we will examine IBC consideration in pain clinic, focusing on aseptic techniques for spinal injection and safe reprocessing of reusable medical devices and bloodstream infection prevention. Then we will move forward to the plastic surgery and wound care clinics, where we will discuss surgical site infection prevention, environmental contamination from wound drainage, and patient care area disinfection. And then we will go through the urology clinic, where we will discuss the infection risk in cystoscope, prostate biopsy procedure, and reprocessing of urological instruments and urinary tract infection prevention strategies. And finally, physician clinics, other clinics, where we will discuss the general outpatient clinic recommendation in reducing infection risk. So as we move into our discussion, let's first establish a clear understanding of the infection risk in outpatient settings. Unlike hospitals, outpatient clinic have a high patient turnover, meaning multiple individuals pass through the same area in a short period, increasing the potential for pathogen transmission, which is very risky. Also, another critical factor is the varied patient population, from individuals who have minor illness to those who are immunocompromised or undergoing complex treatment. This diversity means that some patients are more vulnerable to infections, while others may unknowingly bring infectious agents to those clinics. One of the major challenges in outpatient setting is limited time for environmental cleaning. Since patient visits are often short, there is minimal time between appointment to properly disinfect surfaces and equipment, making contamination a major concern. Additionally, most outpatient clinic operates with shared equipment and facilities, whether it is examination tables, diagnostic tools, or waiting area furniture. So without proper disinfection, these surfaces can act as a reservoir for pathogens. Although outpatient clinics are not traditionally linked to healthcare-associated infection, however, studies have shown that improper adherence to infection measures in these settings has led to outbreak of multiple organisms such as tuberculosis, hepatitis, and MDROs. So given these infection risks, it is essential to implement targeted infection prevention and control strategies that are specific to different outpatient settings, rather than applying a one-size-fits-all approach. IBC measures should be adapted based on the type of care provided. For example, infusion centers need strict bloodstream infection prevention protocols, while pain clinic must focus on aseptic procedure for injections. A key strategies for all outpatient settings is patient screening and triage. Identifying infectious cases early helps prevent exposure to other patients and staff. This is particularly critical in clinics where patients with respiratory illnesses, open wound, or immunocompromised are seen. Next is zoning and patient flow management. Clinics should separate symptomatic patients from non-symptomatic ones whenever possible, using designated isolation area or separate waiting spaces to minimize the contact and reduce transmission risks. Another critical measure is environmental control, which includes routine disinfection of high-touch surfaces, proper ventilation, and safe handling of reusable medical equipment. The goal is to interrupt the chain of infection by ensuring a clean and safe clinical environment. Finally, staff training and compliance monitoring play a crucial role. Even the best infection prevention policies fail without proper execution. Regular audits, competency assessment, and education session ensure that IBC protocols are effectively followed across different outpatient settings. By applying these tailored approaches, outpatient facility can significantly reduce the risk of infection while maintaining safe and efficient patient care. Let's now move forward and explore how these principles are applied in specific outpatient clinic settings. In infusion centers, infection prevention is crucial due to the direct access to the bloodstream during IV therapy. One of the greatest concern is the risk of catheter-related bloodstream infections, which can occur due to break in aseptic technique, contamination of IV ports, or improper handling of infusion supplies. So to mitigate these risks, strict aseptic technique must be followed at all time. This includes performing hand hygiene before and after handling IV lines, using sterile barriers like gloves, masks, drapes during catheter insertion, and ensuring IV ports and hubs are disinfected before each access. A technique commonly referred as scrub the hub. Another critical steps is the use of single-dose vials whenever possible. Multi-dose vial poses a higher risk of contamination, especially when used for multiple patients. Additionally, it's important to avoid unnecessary catheter use and to remove IV line promptly when they are no longer needed. Beyond maintaining aseptic technique for physical environment of infusion centers, plays a major role on infection prevention. Infusion chairs, armrests, IV poles, medication preparation area are high-touch surfaces that can harbor drug-resistant pathogens such as MRSA, VRE, and CRE. Without proper disinfection, these surfaces can contribute to cross-contamination and infection spread. And to address this, routine cleaning protocol must be strictly followed. Before and after each patient, infusion chairs, IV poles, and medication preparation area should be wiped with hospital-approved disinfectants. At the end of each day, terminal cleaning must be performed, ensuring that all patient care area, workstation, and high contact surfaces are fully disinfected. Additionally, a proper biohazard waste disposal is essential. Used sharps and IV-related waste should be handled with strict adherence to disposal protocols to prevent accidental exposure. Infusion centers often serves immunocompromised patients such as those receiving chemotherapy, biologics, or long-term IV therapy. These patients have weakened immune system, making them highly susceptible to infections, even from organisms that may not cause illness in healthy individuals. As a result, strict infection control measures must be in place to prevent exposure to MDROs and other healthcare-associated infections. To minimize transmission risks, a dedicated patient area should be established. Whenever possible, immunocompromised patients should be treated in separate infusion bays or private rooms to reduce their exposure to infectious agents. Similarly, patients known to be carrying MDROs should be cohorted in designated areas to prevent cross-contamination. Another critical component is enhancing cleaning protocols. Any infusion chair, IV pole, or equipment used for an MDRO positive patient must be cleaned last in the sequence and disinfected thoroughly before being used again for another patient. Staff should infections. Lastly, antibiotic stewardship. Lastly, antibiotic stewardship plays a vital role in outpatient IV therapy. The overuse or prolonged administration of antibiotics can contribute to MDRO development, leading to treatment-resistant infections. Therefore, all antibiotic use should be based on evidence-based guidelines, ensuring that medication are prescribed at the correct dose and duration. In internal medicine specialties like cardiology, pulmonology, and rheumatology, the use of stress test masks, spirometry, mouthpieces, and breathing circuits present a high risk of infection transmission if not properly reprocessed. These items often come into direct contact with mucous membrane and respiratory secretion, making them potential vehicles for pathogens such as Mycobacterium tuberculosis, influenza, RSV, and multi-drug resistant bacteria. To minimize these risks, single-use disposable items should be used whenever possible. However, for reusable equipment, a strict cleaning and disinfection processes is required. Each item must be thoroughly cleaned to remove organic matter before undergoing high-level disinfection or sterilization as per the manufacturer guidelines. Additionally, proper storage and handling of reprocessed equipment is crucial to prevent recontamination. All disinfected or sterilized items should be stored in a sealed, contamination-free packaging and labeled appropriately to ensure they are used correctly. Diagnostic imaging plays a critical role in internal medicine, but ultrasound probes and radiology machine can act as infection reservoir if not properly cleaned and disinfected. These devices frequently come into direct or indirect contact with patients' skin, mucous membranes, and even bodily fluids, increasing the risk of pathogen transmission. When it comes to ultrasound probes, proper disinfection level depend on the type of use. For non-critical probes, such as those used for abdomen or vascular imaging, require low to intermediate level disinfection between patients, while semi-critical probes such as transesophageal or transvaginal and transrectal probes require high-level disinfectant due to their contact with the mucous membrane. It's important to remember that single-use probes covers do not eliminate the need for proper disinfection. For radiology equipment, including X-ray tables, CT, MRI scanners, and positioning devices, routine disinfection between patients is necessary. particularly for frequently touched surfaces if the patient has a known infectious disease. Enhanced terminal disinfection should be performed before the next patient is scanned. Pulmonary function tests such as spirometry, peak flow measurement, and gas diffusion tests are considered aerosol generating procedure that can spread respiratory pathogen. Patients undergoing these tests must be unknowingly infectious, may be unknowingly infectious, increasing the risk of the transmission of TB, COVID-19, or influenza transmission and those outpatient clinics. And to reduce this risk, screening and scheduling adjustment should be implemented. Patients with active respiratory symptoms should be tested in a separate room or a negative pressure room if available. If separate room with portable HEPA filter or negative pressure room if available. Scheduling appointments strategically can also allow sufficient time for ventilation and cleaning between patients. For a healthcare worker conducting these tests, the use of PPE is essential. This include N95 respirator or popper, if it tested N95 respirator or popper, also gloves and face shield when handling high-risk patients. Additionally, patients should be provided with masks immediately after testing to minimize the spread of aerosol in shared spaces. It will not be in a shared space. Anyway, another key measure is proper disinfection of PFT equipment whenever possible. Single-use bacterial viral filters should be used for each patient. For reusable mouthpiece and tubing, high-level disinfection or sterilization is required before reuse. In obstetrics and gynecology and infertility clinics, medical instruments such as vaginal ultrasound probes and hysteroscopes comes into direct contact with the mucous membrane and bodily fluid, making proper reprocessing critical to prevent cross-contamination. If these instruments are not cleaned and disinfected correctly, they can become a source of infection transmission, including hepatitis B, HIV, and human papilloma virus. The reprocessing workflow follows a structured approach. Start with pre-cleaning, must be performed immediately after use, using a single-use disinfectant wipe to remove any organic material. Then manually cleaning with an enzymatic detergent, ensure that no residual remain before high-level disinfectant. Then high-level disinfection is done and automated system using hydrogen peroxide or orthoaldehyde based disinfectants are preferred. Manual high-level disinfectant requires strict adherence to contact time dilution recommendation. After disinfection, sterile water or alcohol is used for final rinsing and drying before storage, while single-use probes covered add an additional layer for protection. They do not replace the need for proper reprocessing. Always refer back to the manufacturer recommendation on the type of chemical that is compatible when you are cleaning or disinfection any medical equipment. Beyond medical instruments, reprocessing, environmental cleaning plays a vital role in infection prevention in gynecological and infertility clinics. Services such as examination tables, stirrups, and speculum holders and ultrasound machine are at high risk of contamination with vaginal secretion and bodily fluids, requiring consistent and effective disinfection. To maintain a clean and safe environment, clinics should follow routine disinfection protocols. Between patient high touch surfaces must be disinfected with hospital-grade agents, particularly those designed for blood and body fluid decontamination. At the end of each day, a thorough terminal cleaning at all patient care area is required, ensuring that all surfaces, including floors and less frequently touched area, are disinfected. Additionally, the use of disposable barriers for exam tables and stir-ups is recommended with immediate disposal after each use. If reusable covers are used, they must be laundered at high temperature to eliminate potential pathogens. Proper biohazard waste handling is another critical component. Use of speculum, cotton swabs, and disposable gloves must be discarded immediately in biohazard containers. Any linen contaminated with blood or vaginal secretion should be placed in a leak-proof laundry bag to prevent accidental exposure. In infertility clinic, infection prevention is particularly important due to the delicate nature of reproductive procedure. Assisted reproductive technology, including in vitro fertilization, intrauterine insemination, and egg retrieval, involving direct handling of reproductive tissue, while require strict aseptic technique to prevent contamination. To minimize the infection risks, all procedure must be conducted in a controlled, sterile environment. Sterile single-use instruments should be prioritized for egg retrieval and sperm preparation to prevent cross-contamination. Culture media and specimen container must be pre-sterilized and stored properly to avoid bacterial and fungal contamination. Laboratory equipment also require rigorous disinfection. Microscopes, incubators, and IVF workstations should be cleaned daily using non-toxic embryo-safe disinfectants. Catheters, pipettes, and other lab tools must be either single-use or properly sterilized before reuse. In addition, pre-procedure infection screening is essential. Patients should be screened for active infection, and if necessary, their treatment should be delayed or adjusted to prevent introducing pathogens into the reproductive environment. Finally, to prevent cross-contamination, clinics should be establish a separate treatment zone for high-risk patients to ensure that all reproductive material remains in control and infection-free environments. Laryngology clinics frequently use nasal and laryngeal endoscopies for diagnostic procedure. These instruments come into direct contact with the mucous membrane and respiratory secretions, making them high risk for infection transmission. So without proper reprocessing, endoscope can harbor pathogens such as mycobacterium, tuberculosis, human papillomavirus, influenza, multi-drug resistant organisms, leading to potential cross-contamination. To prevent infection, a strict reprocessing protocol must be followed. Immediately after use, endoscope should be pre-cleaned with an enzymatic cleaner to remove visible debris. They should then go into manual cleaning using detergent solution with a soft brush and reach internal and external surfaces. High-level disinfectant is required with automated system being the preferred method if manual disinfection is used. Contact time and disinfection concentration must be followed. Finally, after high-level disinfection is done, endoscopes should be rinsed with sterile and filtered water and thoroughly dried. Horoscopes that doesn't have lumens, such as the one that we use in the ENT clinics. There are other ways of disinfecting them is by using the three wipes method. There is many companies that provide them that actually can reach the level of high-level disinfection, and each of those wipes actually do a purpose. One of them is for rinsing and cleaning, one of them for enzymatic detergent, and the last one is for applying high-level disinfection. And the whole process takes around 5 minutes, roughly, and everything is properly documented with controlled samples. Another infection risk in ENT clinic comes in from anesthetic sprays and suction tubing, both of which are frequently used during patient assessment and procedure. Anesthetic spray bottles, particularly multi-dose vials, are highly susceptible to contamination. If the spray nozzle come into direct contact with the patient mouth or throat, it can spread respiratory pathogens such as tuberculosis, influenza, or fungal infections. To minimize the risk, single-dose spray vials should be used whenever possible. However, if multi-dose spray are required, direct patient-to-nozzle contact must be avoided. A disposable straw or sterile barrier should be used for each patient. The spray nozzle should be disinfected with 70% alcohol between uses. Similarly, suction tubing and cannulas must be properly managed to prevent biofilm formation and contamination. Single-use suction tubing is the preferred option. For reusable tubing, it should be flushed immediately with an enzymatic solution and then undergoes high-level disinfection and be stored in a dry, contamination-free area. Inshallah, we will finish at 3 o'clock. Audiology clinic can require specific infection prevention measures as diagnostic tools such as otoscopes, tympanometers, and hearing aids frequently comes in direct contact with the external ear canal and mucous membranes. So without proper cleaning, these devices can become reservoir for bacterial and fungal infections, including Staphylococcus aureus, Pseudomonas aeruginosa, and Candida species. And to prevent contamination, all shared audiology equipment must be disinfected between patients. Otoscope and tympanometers should be wiped down with low to intermediate high-level disinfectant after each use. Ear speculum must be either single-use or sterilized before reuse. Hearing aids and ear molds should be cleaned with alcohol wipe-based disinfectant wipes to eliminate the pathogen while preserving the integrity of electronic components. Proper storage and maintenance are also essential. Cleaning audiology tools should be stored in a dust-free container, and any damaged or worn out ear tips and speculum should be replaced regularly to prevent microbial buildup. Pain management procedure, particularly spinal injection and nerve blocks, involve direct access to major nerve pathways and, in some cases, the central nervous system. Without strict aseptic technique, these procedures can lead to serious infection, including bloodstream infection, epidural abscess, and even meningitis. One of the primary risks that come from contaminated medication, injection site, and improperly handling needles or catheters. And to prevent the infection, several critical steps must be followed. Medication preparation must be sterile, with a preference for a single dose vial. Multi-dose vial, if it is used, only will be used if it is really necessary and never be shared among patients. It should be prepared in a medication room away from the patient care area. Before any injection, hand hygiene and sterile gloves must be used, and the injection site must be prepped with chlorhexidine and alcohol, ensuring it has fully dried before needle insertion. For high-risk procedures such as epidural and spiral injection, additional sterile precaution is required. The use of sterile gloves and drapes, wearing a face mask to prevent droplet contamination, ensure all needles, catheter, and syringes are single-use and sterile. After the procedure, monitoring the patient for signs of infection is crucial. Any redness, swelling, fever, neurological change should be assessed immediately to rule out any potential complication like epidural abscess. Beyond aseptic technique during procedure, proper reprocessing of reusable medical devices is equally critical in pain clinics. Many procedures rely on reusable instruments such as nerve simulation, ultrasonic probes, and infusion pumps, all of which require strict cleaning and disinfection to prevent cross-contamination. The level of reprocessing requires depend on the device classification. So non-critical devices such as blood pressure cuffs require low-level disinfection. Semi-critical devices such as ultrasonic probes that are in contact with intact skin require intermediate level disinfection. Critical devices such as ultrasound probes that comes into contact with mucosal membrane require high level disinfection. Four-step back workflow: pre-cleaning, immediately remove organic debris, cleaning, disinfection with high-level disinfection, and sterilization for certain medical equipment, critical devices if they are compatible with the manufacturer recommendation. Then we store them in a sealed, contamination-free packaging until they are used. Pain clinic frequently perform IV therapy, catheter insertion, and injections, all of which pose the risk of bloodstream infections. This infection can be life-threatening, often resulting from non-sterile injection technique, contaminated medication, or inadequate skin disinfection. So to minimize that, strict adherence to aseptic technique is really important. Provider must wear sterile gloves, gown, and mask when handling catheters and IV lines. Chlorhexidine alcohol skin preparation should always be used before injection with adequate drying time to ensure effectiveness. Medication vial should never be re-entered with the used needle, and IV port and connector must be disinfected before access. In addition to proper injection practices, safe handling of IV fluid and medication is really important. As we said before, the single-use vial and the multi-dose vial, which one we prefer. All IV medication and solution must be sterile. Proper IV line management is another key component for bloodstream infection, minimizing the use of indwelling catheter and removing the line whenever it is no longer necessary, monitoring the patient closely for any signs of infection. Same. In plastic surgery clinics, outpatient cosmetic procedures are performed in non-hospital settings where infection prevention measures may not be strict as in a traditional operating room. This makes surgical SSI a major concern, as improper sterile technique, contaminated instrument, or inadequate post-operative wound care can lead to serious complication. So to reduce the infection risk, aseptic technique must be followed preoperatively and intraoperatively and postoperatively when we are doing surgical plastic surgeries. In wound care and plastic surgery clinics, open wounds and post-surgical drainage sites can introduce pathogen into the environment, posing a significant infection risks for both patients and healthcare workers. If wound exudates or blood is not properly contained, it can spread bacteria and viruses, including bloodborne pathogens such as hepatitis B, C, or HIV, as well as MDRO such as MRSA and VRE. And to prevent cross-contamination, clinics must use proper contaminant methods. Absorbent material barriers should be placed on treatment surfaces to prevent leakage. Blood soaking dressing and contaminant disposable must be disposed on a biohazard waste container immediately after use. Wound irrigation fluid should be carefully handled and disposed for according to the biohazard protocols to prevent aerosolization of or spillage of. Healthcare workers should always wear PPE when treating open wound or handling drainage material. Gloves, gown, face shield should be used whenever there is a risk of blood or other body fluid exposure. Gloves should be changed between patients, and clean hands should never touch contaminated surfaces. Proper environmental cleaning is a critical part of infection control in plastic surgery and wound care clinics, since these facilities handle open wound, surgical incision, and post-procedure drainage. Strong disinfection protocols should be in place. Certain area and equipment are high risk for contamination, including treatment beds, countertops, and wound care instruments, which frequently come into contact with bodily fluid and pathogens. High-touch surfaces such as door handles, light switches, and medical equipment could also harbor microorganisms. To maintain a safe clinical environment, a structured cleaning protocol should be followed. Between each patient, all treatment areas should be wiped down with hospital disinfectant. At the end of the day, a thorough terminal cleaning should be performed. For reusable instrument, proper cleaning and disinfection and sterilization should be in place. or non-critical item. For critical instruments such as surgical tools must be sterilized using autoclave or chemical sterilant before use. Non-critical item like blood pressure cuffs or thermometer must be wiped with EPA approved disinfectant after each use. And yeah, that's it. And urology clinic procedures such as cystoscope or prostate biopsy are essential in diagnosing and managing various serological conditions. However, these procedures carry a significant risk of infection due to their direct contact with mucous membrane and in some cases deep tissue penetration. Common post-procedure infection include urinary tract infection, bloodstream infection, and even MDR transmission if proper precautions are not properly followed. The most frequently implicated pathogen, including E. coli, Klebsiella pneumonia, Enterococcus species, Pseudomonas aeruginosa, and for certain patients, they might have, yeah, those are the most common organisms. Several risk factors contribute to post-procedure infections, improper reprocessing of cystoscope and biopsy instruments leading to contamination, inadequate skin and mucosal antisepsis before the procedure, prolonged catheterization post-procedure, which increase the UTI risk, unnecessary antibiotic use, which contribute to drug-resistant infections. To minimize those risks, strict infection prevention measures must be implemented. So before the procedure, thorough clean of urethral opening and perianal area with chlorhexidine or povidone iodine to eliminate surface bacteria. During the procedure, follow an aseptic technique, ensuring the use of sterile gloves, drapes, and lubricants to reduce the tissue trauma. After the procedure, patients should be monitored for signs of infection such as fever, painful urination, change of urine appearance. High-risk patients include those with weakened immune system may require additional follow-up screening. In outpatient urology clinic, reprocessing of cystoscope and biopsy instrument must be part of that. Those instruments must be sent to the CSSD for reprocessing and high-level disinfection or sterilization. I think we can skip the process. Yeah. Also, in urology clinic, the UTI is a common post-procedure complication, particularly after a cystoscope or catheterization or prostate biopsies. This infection often result from bacterial contamination of catheters, biopsy needles, or incomplete bladder emptying following procedure. So to reduce that risk, multiple things we can do, from aseptic technique, catheter care, antibiotic stewardship, patient education, all of that. Other clinics, physician clinics, we can say infection prevention and control must be proactively integrated into daily operation to reduce the risk of cross-contamination. For example, with a high patient turnover, outpatient setting can become a source of pathogen transmission, particularly when patients present undiagnosed infectious diseases. One of the key infection risks in these settings is the use of shared spaces such as waiting area, examination room, reception area, where respiratory droplets and contaminated hands are frequently touching the surfaces, which can contribute to the spread of infection. To mitigate these risks, several best practices should be followed. Screening patients at check-in to identify those with contagious illnesses, and when impossible, separate symptomatic individual in another waiting area. This is really helpful when you are receiving patients with respiratory infectious symptoms, especially in front of, for example, the infectious diseases clinic or respiratory pulmonology clinic. Ensure that hand hygiene stations are accessible and visible in all areas to promote for hand hygiene for all of the customers or patients. Improve ventilation in the examination room and waiting area to help reduce airborne transmission when performing routine patient examination with the appropriate use of PPE is really needed, such as gloves or other surgical masks or gowns. And finally, patient education is very important. It can be done by a lot of signs that promote education for them, leaflets, and even the nurses and physicians who are in the clinics as well. In addition to clinical practices, the physical design and layout of physician clinics plays a crucial role in infection prevention. A well-structured environment can limit the spread of infection, particularly in shared spaces where symptomatic and non-symptomatic patients may interact. To reduce this, a clinic should be optimized by separating well patients from those patients who are infectious. So for example, a specific waiting area for immunocompromised patients, arranging seating and waiting area to allow social distancing, especially with those clinics that might see patients with respiratory illnesses, installing of barriers, protective protection at reception desks, such as glass partition to reduce staff patient exposure to respiratory droplets. And beyond patient flow, ventilation and air quality is very important. You can increase the air exchange rate in areas where it is high traffic or high risk areas in the outpatient clinic. Maybe you can use also a HEPA filter in waiting areas or any high risk or high traffic areas to improve the air quality. For clinics that are performing aerosol generating procedure, a negative pressure room should be available. And finally, surface material also play a role in reducing contamination risks. Non-porous, easily cleanable material should be used for furniture, floors, walls, and countertops, allowing effective disinfection. Infection prevention in physician clinic extends beyond patient care and clinic design. It also requires a rigorous cleaning and disinfection strategies. And I think we have addressed this in previous slides somehow, which one to clean. It was a little bit addressed in all of the previous slides. So that's the end of our presentation. Now we will go with the MCQs of the last presentation for today. I hope you enjoyed all the presentations and sorry for taking all that time. Which of the following best describes the infection control challenges in infusion centers? Excellent. The correct answer is B. Patient often with weakened immune system, increasing the risk of infection. But in infusion centers, we might have patients who are receiving their chemotherapy sessions. So they are usually often have weakened immune system, and they have increased risk of infection. Excellent. Question number 2, what is the primary reason stress test mask and breathing equipment must be properly reprocessed in cardiology and pulmonology clinics? What is the primary reason for that? If we have single use, it is the preferable one, but if we don't, it has to be reprocessed. Excellent. So the correct answer is B, because they are coming in contact with the mucous membrane and respiratory secretions. Well done. Excellent. So question number 3, in an infertility clinic, which infection prevention strategies is most important for handling reproductive specimen? Excellent, everyone. The correct answer is C, ensuring sterile condition when handling egg, sperms, or embryos. Excellent, well done. Fourth question, in outpatient pain clinics, what is a key measure to prevent bloodstream infection during spinal injection? ما شاء الله. Well done everyone. The correct answer is disinfecting the skin with chlorhexidine alcohol before injection. Excellent. Well done. Our last question for today. In physician clinic or office, what is the critical step in preventing the spread of infection in waiting area? MashaAllah. Thank you very much, everyone. Excellent team. So the correct answer is A, placing symptomatic patient in a separate area. Thank you very much, everyone, for attending. It was a pleasure for me to be with you today for all this time. I hope you enjoyed the presentation. I hope you get benefit of all the information that we gave today. I can still stay for another 5 minutes if you want. If you have any questions you would like to ask. I think the slides and everything will be shared with you from your future vision. I think you have to communicate with them. They have, I think, a YouTube channel and everything. You are more than welcome to have that from them if you want to. Also, you can add me through LinkedIn if you want a specific presentation and I can share it with you إن شاء الله. من ناحية إضافة الساعات على ممارس أتوقع هذه راح تكون مع ال future vision. I don't have any idea for that. You have to communicate with them. بارك الله فيكم. I will mute my mic for 5 minutes then I will go. If you have any question, uh, you are welcome to ask. My account in LinkedIn, it is the same with my name, Faris Saad. So let's take the first slide where you can pick up my name. If you want to add me, you can add me there if you want to have any specific questions or anything else. بارك الله فيكم. يعطيكم العافية جميعا. If you have any question, you are more than welcome to ask me. بالنسبة للشهادات والأشياء هذه أتوقع حتكون مع إدارة Future Vision. They are more aware about what is the mechanisms of already الدعم الفني موجود. برد عليك. بارك الله فيك.